Okay. All right, so starting with hematology oncology, first we have embryology, fetal erythropoiesis. So fetal erythropoiesis occurs in yolk sac, liver, spleen, and bone marrow. The mnemonic is young liver synthesizes blood. So yolk sac 3 to 8 weeks, liver 6 weeks to birth, spleen 10 to 28 weeks, bone marrow 18 weeks to adult. So young liver synthesizes blood, yolk sac at 3 to 8, 6 weeks to birth, 10 to 28, then 18 weeks to adult. 3 to 8 weeks. So the initial week, yolk sac. Liver takes over 6 weeks, but up to birth. Spleen takes over 10 to 28 weeks. Then bone marrow, 18 weeks up to adult. Okay, so then we have hemoglobin development. Embryonic globins are zeta and epsilon. Fetal hemoglobins. So yeah, what are the embryonic globins? Zeta and epsilon. Fetal hemoglobin, main one is HbF, which is alpha 2 delta 2. Alpha 2 gamma 2. And then we have adult hemoglobin, which is HbA1 alpha 2 beta 2. So then they say HbF has a higher affinity for oxygen. This is high yield fact. HbF, fetal hemoglobin, has a higher affinity for oxygen due to less avid binding of 2,3-BPG, allowing fetal hemoglobin to extract oxygen from maternal hemoglobin, which is HbA1 and HbA2, across the placenta. HbA2, which is alpha 2 delta 2, is a form of adult hemoglobin present in small amounts. So the major adult hemoglobin is alpha 2 beta 2. The minor amount is alpha 2 delta 2. But HbF, which is gamma chains, alpha 2 gamma 2, has a higher affinity for oxygen due to less avid binding of 2,3-BPG. So thereby allowing HbF to extract oxygen from maternal hemoglobin across the placenta. So then they said from fetal to adult hemoglobin, alpha always, so it's always present no matter fetal or adult forms. Gamma goes from the fetal and becomes beta. So that's the mnemonic. From fetal to adult hemoglobin, alpha always, gamma goes and becomes beta. Okay, then this is the graph showing the levels of different hemoglobins. So fetus, weeks of development, postnatal, and then an adult, versus we are seeing the percentage of total globin synthesis and the site of erythropoiesis. So here we have the first thing so embryonic globins are zeta and epsilon. Then we have the yolk sac. We said this was from 3 to 8 weeks. So by 8 weeks, its synthesis is going down. So yeah, embryonic globins from the yolk sac, zeta and epsilon, going down at 8 weeks. Then next we have the fetal hemoglobin. So then we have alpha, which starts in the fetus and goes all the way up to adult life, because alpha chains is always present. Then we have the fetal hemoglobin, which is again, so the color coded, so it's showing synthesized in the liver. So fetal hemoglobin gamma chains, starting from about 6 weeks and levels going down about 6 months postnatally, and then declining. So that's the gamma chain. Then we have the green one, which is the beta chain. So it starts about 6 weeks of life, for 6 weeks of the fetus, and peaks around 12 months postnatally, and then continues on to be higher. So this alpha and beta chains form the HbA1. And then we have alpha and the delta forming the HbA2. So delta we're seeing starts around 18 months, but very small amounts throughout adult life. So that's the chains. And then your bone marrow takes over at about 18 weeks and then throughout life. Then we have hemoglobin. This was the UL chart. So embryonic is Gower, which is zeta 2 epsilon 2. Portland, which is zeta 2 gamma 2. Gower 2, which is alpha 2 epsilon 2. Then the fetal, we know FHbF is alpha 2 gamma 2. Adult, which is the major one, is alpha A1, which is alpha 2 beta 2 chains. A2, which is alpha 2 delta 2 chains. Then alpha thalassemia intermedia, we have HBH, which is the components are beta 4, alpha thalassemia major, which is BARTS, it is gamma 4. So, yeah, adult form HbA2 is predominant in beta thalassemia.
What's the mnemonic for that BART one? BART.
BART, think fart, think grandma farts. So, gamma
Okay,
4.
4 consecutive BARTs. Okay,
Yeah.
okay.
Yep.
Alpha thalassemia major, BARTs. Gamma 4. And intermediate, it's H, which is beta
Beta
4.
4. Yes.
Something for that too, okay? No? H, beta 4. Okay.
HBH beta 4. Yeah, we said something, but I don't recall what was it. H beta 4, HB.
Hassan has 4 beta, something like that. This is one.
Yeah. What was the name?
Yeah,
Uh,
in the intermediate, Hassan has 4 beta,
yeah.
something like
Hassan
that.
something has 4 betas. Hasab Ali or something like that. We made a name just to remember. So H and A. H and alpha tal. So there has 4 betas, 4 beta. Yep.
Hmm.
Yeah,
Okay,
that was
thank
it.
you.
Thank you. So that's embryology. Next, we have blood groups. So blood groups, yeah, we do have questions on this. We have ABO classification and RH classification. So ABO type A, B, AB, and O. RH is either RH positive or RH negative. So RBC type, so yeah, the main antigens on the surface are A, which is why it is called A type. The main group antigens on RBC surface is B, so that's B type. They're both A and B, that's AB blood group. If there's no surface antigens, then that is O groups or 0. So they're called blood group type O. Antibodies in the plasma, they have antibodies to the opposite. So if they're type A, anti-B IgM antibodies. If they're type B, anti-A IgM antibodies. If they have both A and B, there's no antibodies. If they have no antigens, then they have all the antibodies. So anti-A and anti-B, which is IgG predominantly. So this is IgG type because these groups are having IgM type. So it's important to note blood group type O has IgG predominantly and also some IgM. Then RH classification, if they have the RH antigen on the surface of RBC, that's RHD positive. No RH antigen, RH negative. So this comes up in those RH negative disease, RH hemolytic disease. So yeah, antibodies in plasma, since they have the antigen, no antibodies. They don't have the antigen, so anti-D immunoglobulin IgG type present. Clinical relevance, the compatible RBC types to receive A and O, compatible RBC types to donate to A and AB. So this we know for B group, they can receive from B as well as O to donate A and B and AB. This AB type, they can receive from AB, A, B, or O, and they can only donate to AB. Blood group type O, they can only receive from O, but they are universal donors, so they can give to A, B, AB as well as O. Then RH again, they can receive from RH positive and RH negative, but RH negative, which is negative blood group type, they have to only receive from RH negative, which is why O negative is, you need specifically O negative. So that's something to note. They can receive RH positive, can receive from RH positive can donate to RH positive, RH negative can donate to either. So that's blood group classification. Next, we have hemolytic disease of fetus and newborn. This is step 1 relevant, also called erythroblastosis fetalis. We have Rh hemolytic disease and ABO hemolytic disease. So what is the interaction? Here we have an Rh negative patient with an Rh positive fetus. So what happens during the first pregnancy, the patient is exposed to fetal blood, often during delivery, and this formation of maternal anti-D IgG has now formed. Maternal anti-D IgG. In subsequent pregnancies, this anti-D immunoglobulin, IgG type, crosses the placenta and attacks fetal and newborn RBCs, causing hemolysis. so causing a hemolytic disease of the fetus and newborn. So presentation, how does it present? Hydrops fetalis, jaundice shortly after birth, because hemolysis is going on. So we extrapolate from yesterday, it makes sense. And kernicterus, again from yesterday, it makes sense. Bilirubin goes to the CNS, crosses the BBB, deposits in the tissues, and causes kernicterus. Treatment or prevention, prevent by administration of anti-IgG to Rh negative pregnant patients during the third trimester and early postpartum period if the fetus is Rh positive. Yep. So how do we prevent it? By prevent by administration of anti-D IgG to Rh negative pregnant patients during the third trimester and early postpartum period if the fetus is Rh positive. So this prevents maternal anti-D IgG production. So is this the one? Yeah. So just a visual representation from UWorld. We have Rh negative father, Rh negative mother. So the baby got Rh positive type blood. So when the mom is exposed to this Rh positive blood, so fetal Rh positive RBCs enter maternal bloodstream, and the mom generates maternal anti-D antibodies. In the second pregnancy, also, if it's the same combination with the Rh positive dad and Rh negative, and she has an Rh positive fetus. So this anti-D antibodies that she already developed cross the placenta and cause the lysis of the fetal RBCs. So maternal anti-D antibodies are crossing the placenta and causing hemolytic disease of the fetus or newborn. Okay, this is Rh alloimmunization. And then on the other side, we have ABO disease. Here, type O pregnant patient with a type A or B fetus. So if the patient has type O, then we know she has anti-A and anti-B IgG antibodies. So if the baby is now type A or B fetus, so then those pre-existing pregnant patients anti-A or anti-B IgG type antibodies cross the placenta. So G, we said in, I think in immunology, G goes. So G crosses the placenta and then attacks the fetal and newborn RBCs, causing hemolysis, which is why this IgG type is important, because this will cross the placenta. So it goes and attacks the fetal and newborn RBCs, causing hemolysis. How does it present? Mild jaundice in the neonate within 24 hours of birth. Unlike Rh hemolytic disease, it can occur in firstborn babies and is usually severe. So yeah, this occurs in the second baby mainly. Before that, everything is just getting primed up. Here, it can occur in firstborn babies and is usually less severe. Treatment is phototherapy or exchange transfusion. Yesterday, we saw something which was more common in firstborn males. Anyone remembers? It was hypertrophic pyloric stenosis.
I think, yeah, pyloric stenosis.
Yeah. Firstborn males, macrolides, metabolic alkalosis. Treatment was pyloro-M for myotomy. Yep, that was the answer. All right, so that's done with this. There used to be one more confusing
And
one.
phototherapy, we saw that phototherapy is non-UV, which isomerizes unconjugated to conjugated. It not converts unconjugated to conjugated, but it's something makes them water soluble. How?
Yeah, it may convert it to lumiverdin or something, which is more water soluble. Thereby, it can be excreted in urine. Just changes the form, basically. Yep.
Yeah, and we saw it where? Phototherapy in
newborn jaundice, right? Physiologic jaundice of newborn.
physiological jaundice of the newborn. Okay. And I think in somewhere else,
What was the new name? Neonatal Tigler Najar as well. Yes. The new name is benign neonatal hyperbilirubinemia. This is where we saw phototherapy isomerizes unconjugated to a water-soluble form. Lumirubin, but this is not the yield. Yep, isomerizes to an unconjugated to a water-soluble form. It's not conjugating, it's just converting to a water-soluble form.
Okay, and also we give for Krigler Najar, right?
Yeah, yep. So it's on next page, right? Kriegler and Najjar also we give phototherapy and plasmapheresis. Yes. Yeah, here it says, right, phototherapy does not conjugate UCB, but what it does is it increases polarity and water solubility to allow excretion in the urine. Yeah.
Thank you.
Okay, cool. Back to where we were.
Zaira, we have anti-kel antibody also.
Yeah, but they removed it in the new book. I was happy to see that. What should we do? Yeah, that was very, but yeah, let me just briefly quickly go over it. So what is anti-kel antibody? This is a complex blood group system with high immunogenicity. Anti-kel antibodies, which are usually IgG type, of a kel positive pregnant patient may cause hemolytic disease of the newborn. So antibodies in the mom may cause HDN when produced following previous sensitization to kel antigen and transfer to the placenta. It targets fetal RBC precursors, decreasing RBC production, and mature RBCs, increasing hemolysis. So decreased production and increased hemolysis, resulting in severe fetal anemia. Anti-kel antibodies may also be associated with hemolytic transfusion reactions. So we used to say something, right? Even if she's not been pregnant before, just because she got some transfusion, she can be exposed to the kel antigen. So this can also occur in the first pregnancy, we used to say, correct?
Yeah, I have written as mother is if mother is kel negative and the fetus is kel positive, so mother develops anti-kel antibody that crosses the placenta on exposure. I don't know, maybe Nida had written it down. So I think it also occurs in first pregnancy, right? Like ABO.
Yeah, that was the difference. So the difference is it is similar to ABO. It can occur in first pregnancy. It is unlike RH, where this occurs in the subsequent pregnancies. So yeah. And the confusion was always that where are the antibodies? Yeah, what you said, she was kel negative, but here it said anti-kel antibodies of a kel positive pregnant patient. So she's kel positive. She has the antigen. And she's getting antibodies. I don't know. She's kel positive. The baby is kel negative, I think.
Yeah, something like that. So she's okay. Anti-kel antibodies, IgG of a kel positive pregnant patient may cause hemolytic disease of the newborn when produced following previous sensitization to the kel antigen and transfer to the placenta. So somehow she has the kel antibodies, right, in it.
Yeah, sorry. She has the anti-kel antibodies. But then that's what is conflicting because they're saying it's kel positive pregnant patient. Doesn't make sense. Yeah. Maybe that's why they removed it.
Okay. Anti-kel antibodies basically cross the placenta and causes hemolysis in the newborn.
Yeah, that's all we should remember. I think the anti-kel antibodies are crossing the placenta and they are damaging the fetus RBCs. Yeah.
And what kind of hemolytic transfusion reaction? Acute or delay?
Acute, right?
No.
Oh.
Anti-kel, I think, delayed.
Yes.
Right?
Yes.
Okay.
IgG is always delayed.
Yeah, IgG is always delayed. Yes, thank you.
But ABO is acute.
ABO is acute. Yeah. Okay, so that's also a difference then. Nice. Is kel in the new book?
No, it's not.
No.
Just it says like anamnestic response to minor blood group. Minor blood group orange. Page 112.
So that's what they mean. The minor antigen is the kel probably.
Sarah, sorry, I lost the connection. What you guys were talking about anti-kel, it is not in the book. Neither in 2022, nor on this one.
It is in 2022, but they removed it. 2022 page 413, it was there.
Okay.
But now they removed it. Hamna, if you can please repeat and summarize. I'm sorry, Neelu, did you finish? You were saying something actually.
Okay, first finish it and then I'll do that.
Yeah. So Neelu was saying This anamnestic response part, right?
Yes, exactly.
Anamnestic response to foreign antigen on donor RBCs, RHD, or other minor blood group. This minor blood group, one of the antigen could be KEL. So previously encountered by the recipient, typically causes extravascular hemolysis. Okay. Okay.
And what is this anamnestic, right? Enhanced?
Enhanced reaction of body's immune response. Oh no, enhanced reaction of body's immune system to an antigen that's related to an antigen previously encountered. So we that time when we did this page, we said amnesias we forget. Anamnestic याद रख के बदला लेता है ना, तो enhanced reaction of body's immune system to an antigen that is previously encountered. Yep, that was the meaning. Which is what they've said here. Yeah.
And these are against minor RBC antigens like RHD or other minor blood products like KEL sort of things, right?
Yep.
And this is extravascular hemolysis and ABO incompatibility, which is acute. I think this is more intravascular hemolysis.
Intravascular. Yeah. Yes, correct.
And the time period is very important, usually within 1 to 2 weeks.
It can start within 24 hours and up to 1 to 2 weeks. Yes. Okay. You want to summarize, please?
Yeah, okay. So anti-KEL antibody, basically these are the complex blood group system, but with high immunogenicity, right? So mother is KEL positive pregnant patient developed somehow anti-KEL antibodies, which are IgG type, right? Either due to previous exposure or maybe during pregnancy. So these anti-KEL antibodies, which are IgG, they cause the placenta and causes hemolytic disease of the newborn, right? Because she's exposed to these KEL antigens by previous sensitization to the KEL antigen or transferred through the placenta. So then they target the fetal RBC precursors and causes decreased RBC production or increased hemolysis, either by killing the mature RBCs, resulting in severe fetal anemia. And they say that anti-KEL antibodies may also be associated with hemolytic transfusion reactions, which we say that it's a delayed type.
Yeah.
Delayed hemolytic transfusion reaction. Right?
Thank
So
you.
it can either she developed during previous pregnancies or maybe during transfusion reactions. Or anyhow, if she gets when produced previous sensitization to the KEL antigens transferred through the placenta. Okay.
Thank you so much. I did not know like it is in 2022.
Yeah.
And
And
didn't
it was
notice
very
me.
tricky always. That's why we remember. Yeah.
Thank you so much.
You're welcome.
You're welcome.
It was mentioned. Thank you, Hamna. On the chat, Hafsa says it was mentioned that IgG mediated hemolysis is always delayed. How did we reach this conclusion? It was mentioned that IgG mediated hemolysis is always delayed type. I'm not sure if I'm getting the question. I think she asked, I think we mentioned, right? IgG is always, someone mentioned, I think Dr. Be Positive mentioned it. Doctor, are you there? If you can elaborate, please. Let me see. I'll pull that page back up.
I think we saw that couple pages behind, and also just from the normal principle that IgG always come late. Immunology. That's how I came to that conclusion. Like it's always delayed.
Okay, makes sense. So it's a correlation because IgG, when in the process of synthesizing IgG, it comes later.
Correct.
To correlate with the fact that IgG think delayed transfusion reaction. Okay. Yes.
But we just need to know that blood O make IgG, right? But it's acute.
Yep.
You should remember that.
Yeah. Okay. So yeah, it's just to remember then. So it's a correlation. We are saying IgG during synthesis. This was right. Mom and dad mature to the plasma cells as they age. To say that first was IgM, then D, then A, G, and E. So just a reminder that IgG in this case was delayed type reaction, but we have to also keep the caveat in mind that O type, they have predominantly IgG antibodies, which goes and greets the placenta. I mean, crosses the placenta. So that is causing acute hemolytic. So yeah, it's a variable fact. All right, thank you. Hope that made sense. Hope that summarized what you were saying. So
Yes, thank you. And since you are on this page, Saira, sorry, secretory, which antibodies does not have the hinge? It's IgM and IgA, right?
Yeah, I think we should make a mnemonic for that. It keeps troubling us. Great. This one, right? Hinge is absent in me. IgM and E. Yeah, IgM and IgE type.
So no hinge means decreased attack. Okay.
Yep.
So GAD, IgG, IgA, and IgD has hinge region, right?
DAG. DAG has the hinge. Yep.
Okay. I mean, hinge is absent
I
in me.
think we also said actually at that point, GAD, guard. Oh my God, this protease is attacking me. That was a correlation. So they
Yeah,
have the
something
hinge,
like that. Yeah.
so they will be attacked by the protease. So that's, oh my
Yes,
God.
yes.
And this was me. I hinge absent. Hinge is absent in me. Okay.
Yes, thank you. And IgM has increased avidity.
Yeah, because it is multivalent.
Multivalent.
Yeah, which is a
Thank you. Yeah.
Okay, thank you. So back to where we were, 4:13, I believe. All right, let's pick up pace. So where were we? So yeah, that's done with the hemolytic disease of newborn. Next, we have going to anatomy. So hematopoiesis and then individual cells. All right, so we have a multipotent stem cell, which differentiates into a myeloid stem cell and a lymphoid. Lymphoid is shorter. Let's finish this first. So lymphopoiesis, lymphoblast differentiates into a B cell, T cell, or NK cell. B cell further differentiates into plasma cell and thus produces antibodies. We saw this in immuno. T cell differentiates either into T helper cell or cytotoxic T cell, also seen in immuno. And the other third type is NK cell. We said this was high yield for tumor, to kill the tumor cells. So NK cell. Then coming to the myeloid side, this differentiates into erythropoiesis, thrombopoiesis, granulocytopoiesis, and monocytopoiesis. So one more time, the myeloid is differentiating into an erythroblast, megakaryoblast, myeloblast, or monoblast. Erythroblast differentiates into a reticulocyte. So this comes up in a lot in this chapter. A reticulocyte differentiates in the blood. So yeah, in the bone marrow, we have the reticulocyte, then matures and goes to the blood as an erythrocyte. Then megakaryocyte, again in the bone marrow, megakaryoblast is the precursor, differentiates into a megakaryocyte in the bone marrow, matures and goes as platelets in the blood. Then myeloblast differentiates into a band cell in the bone marrow, then goes into the blood as neutrophil. Yeah, this also comes up. Excess band cells, which telling us that extra production of neutrophils is going on. Then we have myeloblasts also differentiating into eosinophils and basophils. Eosinophils are pink, basophils are blue. Then we have the monoblasts differentiating into monocyte in the blood itself, and then they get activated to become a macrophage in tissues. Yep, macrophage in tissues. Monocyte in the blood, macrophage in the tissues. So that's the big picture. So next, going on to the individual cells, neutrophils, acute inflammatory response cells. These are phagocytic, multi-lobed nucleus, specific granules containing leukocyte alkaline phosphatase, which is the LAP, becomes relevant in the lab score. So you've seen it before, I believe. So yeah, the specific granules contain LAP, then collagenase, lysozyme, and lactoferrin. Yesterday we said fetal calprotectin and fetal lactoferrin was used for
IBD Crohn.
yeah, yep. Nice. Then next we have your azuro.
Excuse me, say again. I'm not able to jog my memory. Say again.
Yesterday we saw fecal calprotectin and fecal lactoferrin is used in Crohn's disease and ulcerative colitis, and that's used for monitoring the treatment and stuff like that.
Okay, great, thanks.
All right, so just a memory jog. So these neutrophilic granules contain LAP, collagenase, lysozyme, and lactoferrin. The azurophilic granules, which are lysosomes, contain proteases, acid phosphatase, myeloperoxidase, and beta-glucuronidase. This also we saw yesterday. All right, so yeah, I think these are NBME questions. The granules, no, I believe that was the granule in another cell. Okay, anyway. So these are acute inflammatory response cells, phagocytic multilobe nucleus, as seen here. Specific granules contain LAP, collagenase, lysozyme, and lactoferrin. Azurophilic granules, which is in the lysosomes, contain proteases, acid phosphatase, myeloperoxidase, and beta-glucuronidase. Inflammatory sites like bacterial infection causes neutrophilia and changes in neutrophil morphology, such as left shift, toxic granulation, so dark blue coarse granules, Tolley bodies, which is light blue, peripheral inclusions, not very clear here, but peripheral inclusions, and cytoplasmic vacuoles. Okay, then Tolley bodies, saw it somewhere. Okay, thing coming up later. So this we've seen before, neutrophil chemotactic agents, C5. So starting with the numbers, C4A, C5A, 5-HETE, interleukin 8. Then we said PANCH for platelet activating factor. Then we said kallikrein, Kali, and one more. N-formyl, oh yeah, it's right here. Sometimes I'm blind, sorry. Kallikrein, platelet activating factor, and N-formyl methionine, which are bacterial proteins. So hypersegmented neutrophils, nucleus has 6+ lobes seen in vitamin B12 and folate deficiency. So yeah, this comes up. Hypersegmented neutrophils is a key clue for B12 and folate. When there's a left shift, what does it mean? That means there's increased neutrophil precursors. So yeah, if the middle is normal, more of this left shift means there are precursors and this side is mature. So left shift means increased neutrophil precursors, band cells, metamyelocytes in the peripheral blood, reflects states of increased myeloid proliferation, like in the cases of inflammation and CML. So increased precursors. Then we have leukoerythroblastic reaction. Here there's left shift accompanied by immature RBCs. Suggests bone marrow infiltration like myelofibrosis and METs. Okay. So this is increased neutrophil precursors in the peripheral blood versus this is left shift with immature RBCs. Okay.
Quick question, ma'am. Quick
Uh-huh.
question. So in the left shift for the neutrophil, we'll see more of the band cells. Is that correct?
Correct. Yep.
Okay. Thank you.
Yeah. So we said here band cells are the precursors in the bone marrow. So this is indicating that more myeloid proliferation. So this myeloid cells are proliferating more. So this is in the case of inflammation or CML, where we need more of these neutrophils to be present. Versus leukoerythroblastic, this is also a left shift, but here the difference is we have immature RBCs, and it's suggesting bone marrow has been infiltrated. So they're not able to mature and come out properly. So that is myelofibrosis and metastasis. So yeah, that's done with neutrophils. So multi-lobed, I mean, histology comes up a lot in these questions. So multi-lobe for neutrophils, and then Dolly bodies, which are not clear here. Hopefully we can find a UWorld image. So Dolly
Yeah,
bodies.
in your world, it's a nice image of dolly bodies, and these are like doll-like, huh? So very pretty light blue peripheral inclusion.
Nice.
Versus toxic granulations, these are coarse granules, dark blue coarse granules.
So what's the significance of these doll bodies?
These are increase in inflammation and infection.
I think we studied in fibroblast or something.
I think we saw it when we did immunology, reactive neutrophils. It just came up over there. So these Dolly bodies are light blue cytoplasmic inclusions of RER in the periphery versus the toxic granules, and then multilobed, and the vacuoles are also seen. So this is all in reactive neutrophilia. Okay.
So what are dolly bodies, they say?
Light blue peripheral inclusions. So then here they said inclusions of what? Of the rough endoplasmic reticulum.
Okay, ARIA, okay.
Yeah. Okay. All right, next, moving on, we have on the next page, we have erythrocytes, thrombocytes, monocytes, and macrophages. Okay, so erythrocytes, as we know, these carry oxygen to tissues and carbon dioxide to lungs, anucleate and lack organelles. This is a highly fact, correlate with biochem. They don't have mitochondria, so they cannot utilize anything other than glucose.
Mitochondria or nucleus?
Both
don't have.
no organelles.
Oh, okay. I thought mainly nucleus. Okay.
Yeah. So biconcave in a structure with large surface area to volume ratio for rapid gas exchange. Lifespan is about 120 days. This is important. Yesterday, endocrine correlation, we said HbA1c is the glycosylated hemoglobin of the RBCs. So it gives us a picture of the previous 1 to 120 days blood glucose levels. And it would be falsely elevated or low in patients who have hemoglobinopathies. So probably we're going to see it later today. And those patients we measured fructosamine, right? Fructosamine. Hamna, you said.
Yes, fructosamine.
Fructosamine. Okay, thank you. So yeah, so lifespan of RBCs is 120 days in healthy adults, 60 to 90 days in neonates. Source of energy is glucose, 90% used in glycolysis, 10% used in HMP shunt. Membranes contain the chloride HCO3 chloride bicarb antiporter. We've seen this when we did some other chapter, I don't remember, but with this allows RBCs to export bicarb and transport carbon dioxide from the periphery to the lungs for elimination. So erythro red side cell, yes. Erythrocytosis, polycythemia, so increased RBCs, polycythemia, increased hematocrit, anisocytosis, so varying cytosis. Iso is uniform, so not uniform, varying sizes. Poikilocytosis, poikilo is multiple shapes, so yeah, varying shapes. Reticulocyte, what is a reticulocyte? This is an immature RBC, reflects erythroid proliferation. If we see bluish color on right GMSA stain of reticulocytes, this represents residual. I think this comes up in a question. The bluish color or polychromasia on right GMSA stain of reticulocytes represents residual ribosomal RNA. rRNA, residual ribosomal RNA. rRNA. Okay. Then moving on, next we have thrombocytes, which are platelets involved in primary hemostasis. These are also anucleate, small cytoplasmic fragments, which are derived from megakaryocytes. Lifespan of 8 to 10 days.
It says that membranes contain chloride bicarbonate antiporter, which allow RBCs to export bicarbonate and transport carbon dioxide from the periphery to the lungs for elimination. So export bicarbonate, they are talking about this. This is not Halden. This is the other one.
Oh,
Boher's.
Bohr effect.
It's Bohr effect, where they export bicarbonate.
This is actually haldane, na? We're removing carbon dioxide in the form of CO bicarb. So it's transporting the HCO3, transporting CO2, hello in the lungs and giving off the CO2, right? So this is haldane, I think. Isn't it?
Okay. Membranes
Correct
contain.
me if I'm wrong.
So
Chloride.
haldane?
haldane carries carbon dioxide. So yeah, they transport carbon dioxide to the periphery of the lung.
No, I'm just curious that RBCs export bicarbonate in which
So
in
they're
one
taking
reaction
up,
bicarbonate comes in and chloride goes out.
yeah, they're taking up in the tissues in the Bohr effect, and then they carry it all the way as bicarb, and then take it to the lungs where they give it off, right? So it starts off with the Bohr where bicarb is loaded on to the RBC. Then it carries it all the way, goes to the lung where it gives off the bicarb and it's changed back into CO2 and it's given off.
So this is haldane, right?
This is haldane because they're talking about this is lungs, right? So yeah, let me see if I can pull up that.
Which allow RBCs to export bicarbonate. So export by exportation.
That's occurring in the lungs, right? We're exporting bicarb from here going out into the lungs. So this is haldane.
No. I'm talking about this bicarbonate exportation. Sarah. This is from the RBCs, bicarbonate is exporting out in the Bohr, right?
No, bicarb here. This bicarb exporting out is haldane, na? Oh, you mean to say via the pump?
Yeah, RBCs, yeah.
Okay,
This
okay.
pump, na? So in
Okay.
one reaction, bicarbonate is going out and chloride is coming in. So that is Bohr, I think.
Okay, so yeah, when we talk about the pump, you're right, my bad. So if the pump here, it's kicking off the bicarb floats in the blood and then is entering back into RBCs. Yeah. So bicarb travels in the blood in the dissolved, carbon dioxide travels in the blood in bicarb form. And then it goes to the lungs. Here it's again entering the RBCs. So yeah, if you're talking about this chloride bicarb symporter, bicarb is exiting the RBC membrane in the tissues. Yeah, you were right. So bicarb is exiting via this pump and it's getting loaded back on in the alveoli when the RBCs is at the alveolar level. Yep.
So exportation of bicarbonate occurs in Bohr. Okay.
Is this import or antiport?
Antipode.
Sorry.
Antiport. Okay.
I
All right, just making sure.
Antipode, yeah, because they're going in opposite direction. Antipode. Yes. Thank you. Thank you for correcting me. Yes. Okay.
So the first part is Bohr, the second part is haldane, right?
Correct.
Mm-hmm.
I mean in the hematology chapter.
No. First is haldane, second is Bohr.
Bicarb coming in is haldane. Bicarb going out is Bohr.
Yes. And no, the second part is a transport CO2 from the periphery to the lung for elimination. This part is haldane.
So in this statement, Neelu, you're saying membranes, can you repeat? So this allows RBC to export bicarb. Yeah, export bicarb. So this is Bohr. And transport CO2 from the periphery to the lungs. So now the lungs, this is again taking it in. Does that make sense?
Yes, thank you.
All right. So we are focusing on the antiporter at this point. So antiporter allows RBC to export bicarb in the tissues and transport CO2 from the periphery to the lungs for elimination. So this first part of the statement is Bohr, second part of the statement is haldane. Yes.
Bicarbonate bahir is Bohr.
Nice. I like that. Bicarbonate.
Just made it.
Bohr. Good one. Thank you. Should write it down before I forget. Okay.
Can you repeat, Hamna?
Yeah, bicarbonate bahir means outside. So it's Bohr.
Okay, thank you.
Yeah, in Urdu, Bahar is outside. How would you translate that?
Bahar. Okay.
And it is also like RBC is bored of this bicarbonate, so it's kicking it out.
Yeah, that also works. Bicarb is bored, so bored effect. Okay, nice. Cool. Thank you, guys. So next, we have thrombocytes. So this is involved in primary hemostasis. These are anucleate small cytoplasmic fragments, as seen here, derived from megakaryocytes. Lifespan of 8 to 10 days. So platelets 8. What did we also say about 8? It goes around in immunology, something one of the group member had said. Anyway, we'll probably come back. Excuse me. So lifespan of 8 to 10 days, platelets, when activated by endothelial injury, aggregate when other platelets and interact with fibrinogen to form a platelet plug. It contains dense granules, which are cash. What is cash? Calcium, ADP, serotonin, histamine. So thrombocytes is the rich guy. It has cash. Calcium, ADP, serotonin, histamine, as well as alpha granules. Alpha granules contain VWF, fibrinogen, fibronectin, and platelet factor. So the dense granules contain cash, the alpha granules containing von Willebrand factor, fibrinogen, fibronectin, platelet factor 4, which makes sense. So these are the tools of the thrombocytes. So it brings them out whenever it needs them. Okay. Thrombocytopenia or decreased platelet function results in petechiae. Von Willebrand factor receptor is the receptor for GP1B. Fibrinogen receptor is GP2B3A. Thrombopoietin stimulates megakaryocyte proliferation. Alpha granules contains VWF and fibrinogen and platelet factor 4. So all the F stuff. Alpha for F in von Willebrand, fibrinogen, fibronectin, platelet factor 4. So all the F stuff is in the alpha, and the dense granules contain the cash. Okay. Nice. So next we have monocytes. These are found in blood, differentiate into macrophages in the tissues. They have a large kidney-shaped nucleus, extensive frosted glass cytoplasm. Kidney-shaped nucleus cells are monocytes, differentiating into macrophages. Mono, one, so one nucleus, one cell. Okay. Then we have macrophages. These are a type of antigen-presenting cell, phagocytosed bacteria, cellular debris, and senescent RBCs. Long life in tissues, they differentiate from circulating blood monocytes, activated by interferon gamma, and can function as antigen-presenting cell via MHC class 2. Also engage in ADCC, other than the NK cells. We saw this in immuno. Important cellular components of granulomas, like TB and sarcoidosis, where they may fuse to form giant cells. Super high yield, we should all be knowing this. Macro is large, phage is eater. So large eater, which is phagocytosing stuff. Macrophage naming varies by specific tissue. Example, Kupffer cells in the liver, histiocytes in connective tissue, osteoclasts in bone, microglial cells in brain, Langerhans histiocytosis in the histiocytes in the skin. What did Hamna? You said some fact about it yesterday.
Coffee bean nuclei
Yeah.
for Langerhans histiocytes.
Yes, thank you. Coffee bean nuclei in Langerhans, other than the tennis racket. Yes, thank you. So then lipid A from bacterial LPS binds CD14 on macrophages to initiate septic shock. This is a high yield fact. Lipid A from the bacterial lipopolysaccharides binds CD14 on macrophages to initiate septic shock. So lipid A component of the bacterial LPS binds CD14. CD14 is on macrophages to initiate septic shock. Okay.
And this one, Saira, also a question. Also engage in ADCC via which receptor? इस macrophages के ऊपर लिखा है ना CD14. It's a receptor for LPS.
14, yeah. So this is for macrophages. NK cells I'm confusing. Yeah, sorry. So macrophages is CD14 and CD40. CCR5, MSC2, B7, FC, and C3b receptors, and enhanced phagocytosis.
So NK cell notorious, what we just talked is 5516. That character is notorious, so we can remember, right?
Yeah. Yes. That's the one we used to say, yeah.
But macrophages also has, if they involved in ADCC, so they will.
So yeah, the whole discussion is macrophages have CD16, which helps with the antibody-dependent cytotoxic killing, which is what I'm now saying, right?
Yeah.
That's what I'm calling. Okay. Okay. Yeah, because it says also macrophages also engage in antibody-dependent cellular cytotoxicity, and this is via the CD16 receptor on the macrophages itself. Because normally I would just remember CD16 being on NK cells. So they're adding that this is also present, and CD16 is also present on macrophages in the context of ADCC. Okay, thank you. All right, so one more time, what is macrophages? These are a type of antigen-presenting cell, phagocytous bacteria, cellular debris, and senescent RBCs. Long life in tissues, differentiate from circulating blood monocytes activated by interferon gamma, can function as an APC via MHC class 2. They also engage in antibody-dependent cellular cytotoxicity along with our NK cells. Important cellular component of granulomas like TB and sarcoidosis, where they may fuse to form giant cells. So macro, large, phage eater, macrophage naming varies by specific tissue like Kupffer cells in liver, histiocytes in connective tissue, osteoclasts in bone, microglial cells in brain. So lipid A from bacterial LPS binds CD14 on macrophages to initiate septic shock. All right, so next we have dendritic cells. These are highly phagocytic antigen-presenting cells, function as a link between the, so this is the link between the innate and the adaptive immune systems via T cell stimulation. They express MHC class 2 and FC receptors on the surface. MHC class 2 and the FC receptors on the surface, they can present an exogenous antigen on MHC class 1, so cross-presentation. They can also present exogenous antigens on MHC class 1, so that's cross-presentation. So yeah, these are highly phagocytic APCs. They function as a link between the innate and the adaptive via T cell stimulation. They express MHC class 2 and FC receptors on the surface. They can present as exogenous antigens on MHC class 1 cross-presentation. Okay, next is eosinophils. Eosinophils' main thing is defense against helminthic infections via major basic protein. This is an NBME question, right? What are the granules in the eosinophils contain? The answer is major basic protein. So something we have to remember. Eosinophils defend against helminths by using the major basic protein. They have bilobe nucleus packaged with large eosinophilic granules of uniform size. Eosinophilic granules of uniform size, highly phagocytic for antigen-antibody complexes. So eosinophils is a good guy. It helps us with helminth infection and also clearing the complexes, thereby preventing autoimmune diseases. So what does it produce? It produces histaminase, major basic protein, MVP, a helminthotoxin, eosinophil peroxidase, eosinophil cationic protein, and eosinophil-derived neurotoxin. So it produces what? Histaminase, major basic protein. What is major basic protein? It's a helminthotoxin. So histaminase, major basic protein, eosinophil peroxidase, eosinophil cationic protein, and eosinophil-derived neurotoxin. So eosine pink diphilic. So it's pink dye-loving and stains pink. Causes of eosinophilia, Spackman eats. Parasites, asthma, chronic adrenal insufficiency, myeloproliferative disorders, allergic processes, neoplasia like Hodgkin's lymphoma, and EGPA, which is eosinophilic granulomatosis with polyangiitis. So what's important to remember is the C, chronic adrenal insufficiency, neoplasia like Hodgkin's, and EGPA. Yeah, these are pretty understandable. So parasites, asthma, chronic adrenal insufficiency, myeloproliferative disorders, allergic processes, neoplasia, eosinophilic granulomatosis with polyangiitis. Then next we have basophils. Basophils mediate allergic reactions. densely basophilic, that's how they get their name, contain. So yeah, what do they contain? They contain heparin, which is an anticoagulant, and histamine, which is a vasodilator. Leukotrienes synthesized and released on demand. This is by basophils. Basophilic stains readily with basic stains. Basophilia is uncommon, but can be a sign of myeloproliferative disorders, particularly CML. So even in questions, if we see basophils, it's going to point towards CML. One more time, basophils mediate allergic reactions, densely basophilic granules. What do the granules of basophils contain? Heparin and histamine. So basophils has H and H. Heparin and histamine. Heparin is an anticoagulant, histamine is a vasodilator. And leukotrienes are synthesized and released on demand. Yep, so this is uncommon, but can be a sign of myeloproliferative disorders, particularly CML. Next, we have mast cells. These mediate local tissue allergic reactions. So tissue allergic reactions contain basophilic granules, originate from the same precursor as basophils, but are not the same cell types. Same origin, but not the same. Can bind the Fc portion of IgE to the membrane. Activated by tissue trauma C3a and C5a. Surface Ig cross-linking by antigen, Ig receptor aggregation leads to degranulation of mast cells, release of histamine, heparin, tryptase, and eosinophilic chemotactic factors. So yeah, this is important. So when there is cross-linking, it triggers the release of histamine, heparin, tryptase, and eosinophilic chemotactic factors. So what activates them? This is tissue trauma, C3a, C5a, which are anaphylotoxins, and surface Ig cross-linking. So any of these can cause degranulation, releasing histamine, heparin, tryptase, and eosinophilic chemotactic factors. They are involved in type 1 hypersensitivity reactions, as we saw in immuno. Cromolyn sodium, we saw this also in the drugs. Cromolyn sodium prevents mast cell degranulation and is used for asthma prophylaxis. Vancomycin, opioids, yeah, this is also a high yield fact. Vancomycin, opioids, and radiocontrast dye can elicit IgE independent mast cell degranulation. Vancomycin, opioids, and radiocontrast. Then we have mastocytosis. This was also a question, I think. Mastocytosis, what is this? This is a rare proliferation of mast cells in the skin and/or extracutaneous organs associated with c-KIT mutations and increased serum tryptase. So tryptase, which is normally present, is super increased. And increased histamine causes flushing, pruritus, hypotension, abdominal pain, diarrhea, and peptic ulcer disease. Okay. So one more time, what are mast cells? These mediate local tissue allergic reactions. They contain basophilic granules. They originate from same precursor as basophils, which explains why they are basophilic granules, but they are not the same cell type. They can bind the Fc portion of IgE to the membrane, activated by tissue trauma, C3a, C5a, surface Ig cross-linking by antigen. So Ig receptor aggregation. This will lead to degranulation and release of histamine, heparin, tryptase, and eosinophilic chemotactic factors. I think tryptase was the question. They gave us multiple things, and yep, tryptase to remember. When involved in type 1 hypersensitivity reactions, cromolyn sodium prevents mast cell degranulation and used for asthma prophylaxis. Vancomycin, opioids, and radiocontrast dye can elicit IgE independent mast cell degran. Mastocytosis, what is this? This is a rare proliferation of mast cells in the skin and/or extracutaneous organs associated with c-KIT mutations, which is why they like to ask it in exams. c-KIT mutations and increased serum tryptase, increased histamine, flushing, pruritus, hypotension, abdominal pain, diarrhea, and peptic ulcer disease. Okay, we good with this page. 414, dendritic cells, eosinophils, basophils, and mast cells.
So, and just a quick review of granules, Saira. Cash, present in where?
Cash is the
Thrombocytopenia, thrombocytes.
thrombocytes.
Platelets.
Calcium, ADP, serotonin, and histamine, right?
Dense granules of thrombocytes. Dense granules of platelets have cash. Alpha granules have the F stuff.
All the Fs. Platelet factor 4, von Willebrand factor, fibrinogen, fibronectin. Okay. And in neutrophils, what is present in the eosinophilic granules?
All the
That's the question
lysozymes,
that,
all the lysozymes thing.
yeah, eosinophilic granules,
lysozyme.
lysosome.
Lysozymes. So these are proteinases, acid phosphatase, myeloperoxidase, beta glucuronidase. All the A's, so lysozymal enzymes. Make sense? And then specific granules contain LAP, collagenase, lysozyme, and lactoferrin.
Yeah, these are starting with L, right? Specific granules, LAP, lysozymes, lactoferrin, and collagenase.
Yep.
I was sneaky. Lysozyme, I meant this one. Specific granules, I was wrong. Okay, but it also says lysozymes here. So yeah, okay, I get you.
And the blue-green color of sputum is due to this MPO thing, right?
That's a question, yeah. NBME question.
Myeloperoxidase, yeah.
Myeloperoxidase, yes.
Thank you.
And you got to know these chemotactic factors, all those 6 factors.
Yep.
Yeah. Oh, that's all. Yeah.
So yeah, neutrophils are specific granules, azurophilic granules. So all the L stuff. So LAP, collagenase, focus on the L. So collagenase, lysozyme, and lactoferrin. So all the L stuff. Azurophils have the lysosomal enzyme, so all the A's stuff. Then we have thrombocytes granules. We have the dense granules of thrombocytes. And I'm just making notes, sorry. Dense granules, and which has the cache. And alpha granules, which have the F stuff. Okay, and then monocyte granules also, we said. Okay, coming on order. Next we have eosinophilic granules. No name for the granules, but they contain major basic protein. And all this stuff can be produced, eosinophil stuff, E stuff. Then we have so this basophilic granules. This has no name, but this is having heparin and histamine, H and H, and leukotrienes on demand. Okay, then mast cells. So these, right? Histamine, protease. Tryptase, eosinophilic chemotactic factors. So mast cells, no name for the granules, but the degranulation will release all the histamine, tryptase, and heparin. So H and H again, histamine, heparin, tryptase, and eosinophilic chemotactic factors. Then we have, yep, so then that's it for now. Okay. Thank you for the review. Beta glucuronidase function, yesterday we saw that's going to conjugate, no, deconjugation.
Yeah, it causes conjugation at days. Oh, break it down.
Deconjugation, yeah.
Yeah.
Yeah, beta glucuronidase is deconjugation.
Yeah.
Lysosomal enzyme for direct bilirubin deconjugation, also found in breast milk, may lead to pigment stone formation. Yeah, we saw this yesterday. So this beta glucuronidase is now present in
Azurophilic neutrophil.
azurophilic neutrophil granules. Yes. So it's present in breast milk and azurophilic neutrophil granules. So this is a lysozyme also. Yep, lysozyme of the neutrophils, which makes sense, right? This is a lysosomal enzyme. Yep.
And also in adrenal insufficiency, we can have eosinophilia.
Yeah, that was some weird fact, right? How
Addison's disease, right? Primary adrenal, no,
Yes,
chronic adrenal insufficiency.
adrenal insufficiency, Addison, yeah, you're right.
Yep. Was it mentioned here? They didn't, but I remember we spoke about it somewhere.
It was in the previous book.
Yeah, I remember I felt like I highlighted it, but no memory now. Okay, yeah. So Addison's was eosinophilia. Okay, cool. Thank you. All right, so back to where we are. Okay, cool. So next page, we have lymphocytes, NK cells, B cells, T cells, and plasma cells before we move on to physio. Okay, so what are lymphocytes? Refer to B cells, T cells, and NK cells. So all of, okay, so these are subtypes. B cells, T cells, and NK cells are together the lymphocytes. B and T cells mediate adaptive immunity. NK cells are part of the innate immune response. They are round, densely staining nucleus with a small amount of pale cytoplasm. Yeah, very small amount of pale cytoplasm, densely staining nucleus. So then coming to NK cells, these are important in innate immunity, especially against intracellular pathogens. This is high yield. Excuse me. So NK cells are larger than B and T cells with distinctive cytoplasmic lytic granules. Okay, so now we have lytic granules of the NK cells. What do these contain? Perforin and granzymes. Okay. So when these are released, they act on target cells to induce apoptosis. Apoptosis, high yield, we did that. So NK cells have cytoplasmic lytic granules. This has perforin and granzymes, which makes sense. It perforates, puts holes on the cells and releases granzymes, which destroys the cell. All right. So it acts on the target cells to induce apoptosis. Distinguish between healthy and infected cells by identifying, this is a super high yield fact. Every NBME, I don't know, they seem to love this. So NK cells distinguish between healthy and infected cells by identifying cell surface protein induced by stress, malignant transformation, or microbial infections. They induce apoptosis in cells that do not express class 1 MHC surface molecules. Example, virally infected cells in which these molecules are downregulated. So that's why NK cells' main thing is viral infections, virally infected cells, and malignant cells which do not express class 1 MHC. Many questions with graphs and tables and stuff with this fact. Okay, so one more time, NK cells are important in innate immunity, especially against intracellular pathogens. NK cells are larger than B and T cells with distinctive cytoplasmic lytic granules, which contain perforins and granzymes that, when released, act on target cells to induce apoptosis. Distinguish between healthy and infected cells by identifying cell surface proteins, which are induced by stress, malignant transformation, or microbial infections. Induce apoptosis, natural killer cells. Killer, so apoptosis, that do not express MHC class 1 soil surface molecules, example, viral infected cells in which these molecules are downregulated. So we're seeing an NK cells with a CD16 FC receptor and CD56. So 1656 NK cells. So they also have lytic granules which contain the perforin and granzymes. Then next
and these are activated by, interleukin 2, 12, interferon alpha, and interferon beta, right?
2, 12,
interferon alpha and beta, if I'm not wrong, and they secrete interferon gamma.
Yes.
Like T helper 1 cells.
Correct.
You know what? I am thinking of a nice mnemonic for this one, natural killer cells. So the woman, when she's 16, she's like naturally killer looking. And at 56, she's killer in terms of her brain. She's smart. So maybe that's the way I'm going to remember.
Nice. Yeah, that's a good one. Thank you. Perforin and granzymes. Okay. So you said induced by IL-2, 12, interferon alpha and beta, which makes sense because viral infected cells, remember we have that image on UWorld, they produce interferon alpha and beta or something like that. Or they downregulate interferon alpha and beta so that the cells won't attack. I mean, the virus doesn't attack the neighboring cells. And we give alpha and beta therapy also for viral infections. So, okay, it's coming together. So their NK cells are induced by IL-2, 12, interferon alpha and beta, and they secrete interferon gamma. Right, thank you. Thank you guys for adding that on. So next we have B cells. These mediate humoral immune response and originate from stem cells in the bone marrow and matures in the marrow itself. They migrate to peripheral lymphoid tissue, follicles of lymph nodes, white pulp of spleen, and uncapsulated lymphoid tissue. So this we saw in immuno. The stem cells are in the bone marrow, but they mature in the marrow itself. Then they migrate to the peripheral lymphoid tissue, which is follicles of lymph nodes, white pulp of spleen, and unencapsulated lymphoid tissue. So then when the antigen is encountered, these cells differentiate into plasma cells and memory cells and plasma cells. So plasma cells can produce antibodies, and memory cells, as the name suggests, they remember and they're helpful in reattack. So they can also function as antigen presenting cells. So B for bone marrow. So 19, 20, 21 are the receptors, is pretty high yield. Next, we have T cells. T cells mediate humoral immune response, originate from stem cells in the bone marrow, but mature in the thymus. Contrast with B cells, they are originating and maturing in the bone marrow itself. So B for bone marrow. Here, they originate from the stem cells in the bone marrow, but mature in the thymus. So T for thymus. They differentiate into cytotoxic T cells, which express CD8, recognize MHC1. Helper T cells express CD4, recognize MHC class 2, and regulatory T cells. So 3 types, Th1, Th2, and reg T cells. We saw this in immuno. CD28 is the co-stimulatory signal that is needed for necessary T cell activation. Most circulating lymphocytes are T cells, which are 80%. CD4 plus T helper cells are the primary target of HIV. Yep. CD4. Rule of 8, MHC2 into 4 is 8, MHC1 into 8 is 8. To remember which cells have what MHC. So TC, yep, the cytotoxic cells. So all T cells have CD3, are CD3 positive. So that's important, comes up in questions. Cytotoxic cells are CD8 positive, helper cells are CD4 positive. All right, next we have plasma cells. So as we said, these cells will differentiate into plasma cells when they encounter the antigen. So these produce large amounts of antibodies specific to a particular antigen. They have a clock-phase chromatin, chromatin distribution, and an eccentric nucleus, abundant RER, and well-developed Golgi apparatus. So as we see in arrows, so clock-phase chromatin, it's not very clear image though. So clock-phase chromatin distribution and eccentric nucleus in the corner, abundant RER, and well-developed Golgi apparatus. So yeah, it's synthesizing proteins which are immunoglobulins. So it makes sense that the RER is abundant and well-developed Golgi because those both are involved. So it makes sense. Found in bone marrow and normally do not circulate in peripheral blood. So they're reserved in the bone marrow. They normally do not circulate in peripheral blood. Multiple myeloma is a plasma cell dyscrasia. So that's why it produces too many proteins. So yeah, multiple myeloma, plasma cell dyscrasia. Okay. Is it just my book that's blurry or all the images are so blurry?
And B7 for B cells and CD28 for T cells, right? Just to correlate.
Say again, sorry, B cells for?
B7 for B cells, which is a complex of CD80 or 86, right?
Yeah.
And CD28 on T cells, the co-stimulatory signal.
Yep,
And
yeah,
we
yeah.
said that CD40 ligand on T cells, right?
Yes, we said L, if you flip it, is like a T, so ligand is on T cells. Yep. Yep. Nice.
Hey, Sarah, once you're done, can you go over the natural killer cells that you discussed something about IL-2 after you're done with all these things?
Yeah. I'll
Yeah,
go back.
thanks.
No problem. So, yeah, I was trying to look at the plasma cells with abundant cytoplasm, eccentric nucleus. Perinuclear clearing is what I think they were pointing, which is the Golgi apparatus. It's much better image. Okay. Arrows in the Golgi apparatus. Yeah. So again, one more time. Plasma cells have eccentric nucleus, abundant blue cytoplasm, and perinucleus. So around the nucleus there's a clearing, which is representing the Golgi apparatus. Because they have lots of RER and Golgi. So NK cells, one more time, they're important in innate immunity, especially against intracellular pathogens. NK cells are larger than B and T cells with distinctive cytoplasmic lytic granules containing perforin and granzymes that, when released, act on target cells to induce apoptosis. So NK cells, when it attacks, it releases the perforins and granzymes and induces apoptosis. Distinguish between healthy and infected cells by identifying cell surface proteins, which are induced by stress, malignant transformation, or microbial infections. So these are infected or unhealthy cells, which will display cell surface proteins. So that's how NK cells is able to distinguish between healthy and infected cells. So the NK cells induce apoptosis, natural killer, in cells that do not express the cell surface protein. So in this context, specifically class 1 MHC cell surface molecules. Example, virally infected cells in which these molecules are downregulated. So if the NK cells it's a protective, right? It's a bodyguard. So it's going around detecting all the cells in the body. If it encounters a cell, and cells, I think MHC class 1 is a non-nuclear cell, something like that. So if it is detecting a cell which does not have the MHC class 1, then it knows that, okay, I need to attack and destroy this cell. So, but if it encounters a cell with the MHC class 1, it's like, okay, check, this is okay to move around. So that's the NK cells function. Yeah, if it finds that no MHC present, it will release the granzymes and perforins, induce apoptosis, apoptotic pathway we did the other day. And then, yeah, that's how it kills the abnormal cells in the body. Yeah, for example, virally infected cells, if this has a virus in it, it's not going to display it. So the virus makes the cell downregulate the MHC class 1. So NK cells will detect this. Okay, there's no MHC, this needs to be destroyed. So that's the function of the NK cells. Does that make sense?
And you discussed about this one, the interferons. IL-2, IL-2 interferons and all.
Yeah.
What
So
was
Hamna had said, she added on that NK cells are induced by interleukin 12, interferon alpha, and interferon beta. So right, these anytimes these interleukins are produced, it causes more and more natural killer cells to come into the picture. So then we said the NK cells themselves produce interferon gamma. So that's what we were saying.
Okay, gotcha. Thank you so much. Yeah.
And then, yeah, I think I had also said the interferon in the virally infected cells. I added on that point. Let me see what I meant. There was a question with the interferon image. Let me see if I can find it. So yeah, I was just correlating how interferon alpha and beta they work. So if there is a virally infected cells. So the virus has entered viral RNA and proteins. They use the host DNA to produce. So the host DNA now is going to, or the host cell is going to release alpha and beta interferon. So what do these do? Why are they important for us? Is because they go and bind to the neighboring cells, and they downregulate or antiviral proteins degrade. And so antiviral proteins, yeah, it degrades antiviral proteins and halt protein synthesis. So if we halt protein synthesis, so the virus cannot replicate. So interferons alpha and beta are produced by most human cells in response to viral infections. The production of alpha and beta interferons helps suppress viral replication by halting protein synthesis and promoting apoptosis of infected cells. So this apoptosis, when we talk about that, NK cells come into the play. So apoptosis of infected cells, limiting the ability of viruses to spread to the tissues. So the body's like, okay, this cell has already been infected. Let's at least protect the neighboring cells. So it releases this alpha and beta interferon signals, so the neighboring cell has this receptor, and it's degrading and halting protein synthesis, basically degrading antiviral proteins. No, antiviral proteins are produced. This degrades the RNA, which is coming in, because virus will infect this cell. Next is like, okay, next cell. So before the virus starts infecting all the cells, our body has this mechanism of interferon production, which will go into the neighboring cell, produces antiviral proteins now, which degrades the RNA, viral RNA, and halts protein synthesis. So it's preventing the cell from allowing the virus to use its machinery in a way. Does that make sense? Sorry.
Yes, well done. Actually, well done.
Thank you. Okay, so that was a correlation between NK cells bringing in the virally infected. So yeah, once these interferons are produced, and we said promotes apoptosis of infected cells, that's when the NK cells come into play. So that was the correlation we were talking about. Okay, are we all good? Okay, so next we have, moving on to physiology, hemoglobin electrophoresis. This is high yield questions. I think it's also on NBMEs. The mnemonic is a fat Santa Claus can't go far. A fat Santa Claus cannot go far, so it stays towards the positive. So from the top, during gel electrophoresis, hemoglobin migrates from the negatively charged cathode. So we start here, from the negatively charged cathode to the positively charged anode. HbA migrates the farthest, followed by HbF, HbS, and HbC. This is because the missense mutation in HbS and HbC replaces glutamic acid, which is negatively charged, with valine, which is neutral, in the case of sickle hemoglobin, and glutamic acid, which is negatively charged, replaced with lysine in the case of HbC. So respectively, so making HbC and HbS are more positively charged, so they don't go that closer to the anode, because positive will repel each other. So yeah, normal adult hemoglobin, what happens when we start? HbA is negatively charged, so it is attracted to the anode and it moves fast in the normal adult. Then when we put HbF, it's slightly less positive than the adult, so it goes and it has the alpha 2 and gamma 2. So this alpha 2 portion goes to the anode, but the other one doesn't as much. So HbF is having 2 bands, so normal newborn. In the case of sickling, the one chain is going, so that's, I believe, the alpha chain. But the other one has now become more positive, so this will repel it, so it doesn't go as far. So this is sickle cell trait, where it has one allele normal, the other one is abnormal. Sickle cell disease, both are SS. So now it's more positive, doesn't go too far, stays here. So sickle cell hemoglobin, sickle cell disease. Then we have HBC. So again, this is more positive because glutamic acid was replaced by lysine. So this is going to stay further away from the anode because it's more positive. So HB trait, again, one allele is normal, so that moves normally. The other one is stuck here. If it's HBC disease, so both the alleles are going to be positively charged, so it stays farther away. And HBSC disease, one is S and one is C, so both are slightly more positive, so they're going to stay further away. So a fat Santa Claus from the cathode to the anode, they don't go far. So yeah, that's again, normal hemoglobin beta chain. So HbA in adult. In HbF, we have normal hemoglobin gamma chains, HbF, which is fetal, sickle cell hemoglobin beta chains, HbS. Hemoglobin C beta chain is HbC. Okay. Next, we have antiglobulin test. This is also known as Coombs test. We have direct and indirect antiglobulin test. So what does it detect? It detects the presence of antibodies against circulating RBCs. It detects if the presence of antibodies against circulating RBCs. So we have direct antiglobulin test and indirect. This is so here anti-human globulin, which is the Coombs reagent, is added to the patient's RBCs. RBCs agglutinate if RBCs are coated with anti-RBCs. So it's antibody to the antibody. So anti-human globulin, which is a Coombs reagent, is added to the patient's RBCs. RBCs will agglutinate if RBCs are coated with anti-RBC antibodies. So this is used for IHA diagnosis, autoimmune hemolytic anemia. So then indirect, so yeah, what are we seeing here? Does this patient have IHA? Perform the direct antiglobulin test, which is a direct Coombs test, where we're taking the patient's RBCs. And if we're suspecting that this patient has IHA, they have with or without anti-RBC antibodies. So we don't know this at this point. So we're adding the patient's RBCs along with the human globulin, anti-human globulin, which is a Coombs reagent. If the patient had antibodies, this Coombs reagent is going to attach and cause agglutination. So agglutination indicates the presence of anti-RBC antibodies. If it's negative, which means no IHA, so RBCs don't have antibodies coated on it, so no agglutination occurs. They keep floating around separately. So no agglutination indicates absence of anti-RBC antibody. So that's the direct test because we're directly sending antibody to the antibody. So that's the direct test. Now we have the indirect antiglobulin test. Normal RBCs are added to the patient's serum. If the serum has anti-RBC antibodies, so here we're using patient's serum versus here we're using patient's RBCs. So what are we doing here? Normal RBCs from another volunteer are added to the patient's serum. If the serum has anti-RBC antibodies, the RBCs will agglutinate when Coombs reagent is added. So this is used for pre-transfusion testing. So that's the difference. Why is it indirect? Because we're using patient serum. So let's see what happens here. Will the recipient react against donor RBCs? So perform indirect antiglobulin test, which is indirect Coombs. We're taking the patient's serum. We don't know whether it has antibodies. So at this point, with or without anti-RBCs or RBC antibodies. So we're taking patient's serum with or without anti-RBC antibodies. We're adding it with anti-human globulin donor, anti-human globulin, and donor blood. So when we put it in let's say a test tube in a lab, if the test is positive, we see a reaction. agglutination indicates presence of anti-RBC antibodies. So what happens? This RBCs is attacked by the patient's anti-RBC antibodies. Then we have the antibody to the antibody. So that causes agglutination. So agglutination will be present. This indicates that antibodies are present in the patient's serum. If there's no reaction, they float around on their own. No agglutination indicates absence of anti-RBC antibody.
So let me add a quick fact, because as I said, I was doing gynae. We do for the pregnant patients, we do Coombs test. Can you tell me which one we do, direct or indirect?
Say again, for gynae patients to test what?
The gynae patient, in order to find out Rh positive and Rh negative, we do direct or indirect. Can you tell me which one?
Indirect, isn't it?
Yeah, you got it. Yeah.
Yeah.
Here they just say pre-transfusion. They didn't add that fact. That's what I thought. Okay, well, why can't? Yeah.
So pre-transfusion testing, this is relevant in gynecologic field before.
No, that's two different things. Pre-transfusion is general for anybody. But then I'm adding a fact of a pregnant woman to test for the Rh factor. This is the particular, this is a test you do. Yeah, that's.
So thank you, doctor. So you're adding not just pre-transfusion testing, we're talking Rh testing in pregnant patients. Nice, thank you. In this case also we do indirect, which makes sense, yes.
It's,
Okay.
I think it's similar to ELISA. No? First we have indirect ELISA, we use antigen. And indirect ELISA, we use antibodies.
Yeah, absolutely.
Next we have moving on to platelet plug formation, primary hemostasis. What is the steps here? First, if there's injury or endothelial damage, which is transient. No, it causes transient vasoconstriction via neural stimulation reflex and endothelin, which is released from the damaged cell. So yeah, first thing that happens, endothelial damage leads to a transient vasoconstriction. How? Via neural stimulation reflex as well as endothelin, which is released from the damaged cells. So endothelin will also vasoconstrict and neural stimulation reflex. Step 2, exposure. So von Willebrand factor binds to the exposed collagen. Von Willebrand is from Weibel-Palade bodies of endothelial cells and alpha granules of platelets. Yeah, we saw this. So now this von Willebrand factor has bound to the exposed collagen. Next step is addition. Platelets bind von Willebrand factor via GP1B receptor at the site of injury only. So this is specific, and platelets undergo conformational change. So once they undergo conformational change, platelets release ADP and calcium, which is necessary for the coagulation cascade, and they also release thromboxane A2. ADP helps platelets adhere to the endothelium. So this ADP, calcium, and thromboxane is causing activation. This is the next step, activation. So ADP binding to the P2Y12 receptor induces GP2B3A expression at the platelet surface. This leads to rapid, irreversible platelet aggregation. So next step is aggregation. Fibrinogen binds to the GP2B3A receptors and links platelets. So yeah, fibrinogen is the platelet aggregator. So there's always a balance between the pro-aggregation factors and anti-aggregation factors. What are the pro-aggregation factors? We have thromboxane A2, which is released by platelets. Decreased blood flow will pro-aggregate, increase platelet aggregation, further causes aggregation. Anti-aggregation factors, we have PGI2 and NO, which is released by endothelial cells. Increasing blood flow, which will decrease aggregation. Decreased platelet aggregation will prevent further aggregation. So temporary plug stops the bleeding. This is unstable and easily dislodged. So to form a proper clot, we go on to coagulation cascade, which is the secondary hemostasis. So platelet plug formation, primary hemostasis has these 5 steps. Number 1, injury causes endothelial damage. Endothelial damage causes transient vasoconstriction via neural stimulation reflex and endothelin, which is released from the damaged cell. Step 2 is exposure. Von Willebrand factor binds to exposed collagen. Where is this von Willebrand factor coming from? It's in the Weibel-Palade bodies of the endothelial cells as well as the alpha granules of platelets. So it's coming from both places, the platelets and the endothelial cell. So then we have adhesion. This platelets bind the von Willebrand factor. How? Where GP1B receptor at the site of injury only. So this is specific process. Then next, platelets undergo conformational change. So now they release ADP and calcium as well as thromboxane E2, and calcium is necessary for the coagulation. ADP and calcium is necessary for the coagulation cascade. ADP helps platelet adhere to the endothelium. Platelet and endothelium from adhering, ADP is helping. So then there's next step is activation. So ADP binding to P2Y12 receptor induces GP2B3 expression at the platelet surface. Rapid irreversible platelet aggregation occurs. Aggregation, how does it happen? Fibrinogen binds GP2B3 receptors and links the platelets. So there's always a balance between pro and anti-aggregation. What are the pro? Thromboxane A2, decreased blood flow, increased platelet aggregation. What are anti-aggregation? PGI2 and NO released by the endothelial cells. Increased blood flow and decreased platelet aggregation. Then we have, so a temporary plug is now formed, stops bleeding, unstable and easily dislodged. So we form a proper plug with the coagulation cascade, which is secondary hemostasis. So thrombogenesis. So yeah, if we correlate, what is thrombogenesis? Here we're formation of an insoluble fibrin mesh. Aspirin reversibly inhibits cyclooxygenase by inhibiting thromboxane A2 synthesis. Clopidogrel, prasugrel, and ticagrelor inhibit ADP-induced expression of GP2B3A by blocking the P2Y12 receptor. Eptifibatide and tirofiban inhibit GP2B3A directly. Ristocetin activates von Willebrand factor to bind to GP1B. Failure of aggregation with ristocetin assay occurs in von Willebrand disease and Bernard-Solier syndrome. Then desmopressin promotes the release of von Willebrand factor and factor 8. So this is high yield fact. Desmopressin promotes the release of von Willebrand factor and factor 8 from endothelial cells. Von Willebrand factor carries protein. Yeah, it's the carrier of factor 8. Volkswagen factories make great cars. To remember that Volkswagen, which is von Willebrand factor, carries a factor 8. Or carries as well as protects factor 8. So if we correlate the processes, so step 1 was injury. So the Weibel-Palade bodies present in the endothelial cell. So this contains the P-selectin, which we saw for migration, neutrophil chemotaxis. So it holds, so two things, right? P for the Weibel-Palade, P-selectin, and W is for the von Willebrand factor. So now this von Willebrand factor is released. Deficiency leads to von Willebrand disease. So we also said PGI2 and NO are anti-aggregation factors. So step 1, injury causes endothelial damage, release of the endothelin, which is released from damaged cells, as well as this PWF is released. This is also stimulated by desmopressin. So subendothelial collagen is exposed. So step 2.
This is endothelin is released, right? What does it do?
Sorry?
Endothelin is released, you said, right? When the injury before this step where you showed. What does it do?
It causes vasoconstriction.
Yeah. So yeah, after that, now if you build the story, it'll go together. Yeah, go ahead.
Yeah, so endothelin, which is released, is going to cause vasoconstriction as well. So then next, von Willebrand factor is inhibited by, it's stimulated by the, sorry, okay, I'll get to the drugs later. So what is happening here? We have, sorry, I lost my train of thought. So von Willebrand factor, which is exposed from the subendothelial collagen, is binding to platelets have GP1B, which is bound to the von Willebrand factors. So this is happening, and this deficiency is in Bernard-Soulier syndrome. No worries, it's okay. So yeah, so we're seeing the platelet. Platelet has GP1B receptor, and then when this binding occurs, it causes GP2B3A expression. So that is going outside and getting displayed. We're also seeing, okay, let me go in order. So step 2 was the exposure. So von Willebrand factor binds to exposed collagen, which is a subendothelial collagen, is this triangle, and von Willebrand factor is binding here. Then next we have adhesion. The platelets bind von Willebrand factor via this GP1B at the site of injury. So this platelet undergoes a conformational change. This releases ADP, which is here, ADP and calcium, which is not pictured here. So ADP, calcium, and the third thing is thromboxane A2. So ADP helps platelets adhere to the endothelium. So this ADP, they didn't picture it here, but this is going to help the platelet adhere to the endothelium. Yep. So next we have activation. What's the activation? ADP binding to the receptor, P2Y12 receptor, induces a change, induces the GP2B3A expression onto the platelet surface. So what causes GP2B3A to be expressed is this ADP binding to ADP receptor, which is a P2Y12 receptor. So this is the activation step. Next is aggregation. Fibrinogen binds GP2B3A receptors on either platelets and it's causing aggregation. So with this multiple platelets aggregating with each other, we form a temporary platelet plug, which is unstable and is easily dislodged. So we need the help of coagulation cascade now. So what are the multiple drugs and deficiencies associated? So yeah, on aggregation, we are seeing arachidonic acid converting to thromboxane A2 by the enzyme cyclooxygenase. Thromboxane A2 is a pro-aggregant factor, which we saw on this. So this released from platelets. So, yep. So also we are seeing subendothelial collagen releasing PGI2 and NO, which are released from endothelial cells, which are pro-aggregants or anti-aggregation, sorry. PGI2 and NO are anti-aggregants. Thromboxane released from platelets is pro-aggregant. So that's the big picture. Then coming to deficiencies, if von Willebrand factor is deficient, that's von Willebrand disease. If GP1B is deficient, that's Bernard-Soulier syndrome. If GP2B3A is deficient, that's Glanzmann's thrombasthenia. Then next coming to drugs, aspirin is working here. So it's irreversibly inhibits cyclooxygenase. Thereby, it inhibits the thromboxane A2 synthesis. Yep. Then next we have clopidogrel, prasugrel, and ticagrelor. Where are these working? These are working here. So they inhibit the ADP-induced expression of GP2B3A by blocking this receptor. So they are blocking at this receptor level, actually. So blocking the P2Y12 ADP receptor. Then we have eptifibatide and tirofiban, which inhibit GP2B3A directly. Ebiciximab also. Eptifibatide and tirofiban are direct GP2B3 inhibitors. So by inhibiting this, they're preventing aggregation. Then ristositin. So we speak about in ristositin assay. So that activates, where is it? Yeah, this is activating von Willebrand factor to bind to GP1B. Failure of aggregation with ristositin assay will occur in von Willebrand disease as well as Bernard-Soulier. So von Willebrand deficiency of von Willebrand factor, this side, this is von Willebrand factor deficiency, and Bernard-Soulier is deficiency of the 1B. So if ristositin assay is not No aggregation occurs, that means it's one of these two. I think Dr. Ryan also on Boards and Beyond, he mentions, when you see the word ristoset in assay, either think von Willebrand or Bernard-Solier, because that's what it's testing pretty much. So then desmopressin, which is over here, it promotes the release. So this is also high yield question, NBME question. So it promotes the release of von Willebrand factor and factor 8 from the endothelial cells. So yeah, the mnemonic was Volkswagen factories make great cars. Von Willebrand factor carries and protects factor 8. So that's the overview for thrombogenesis. Next is the coagulation and kinin pathways. I think should we take a break?
Yes, Saira. What is this desmopressin mentioned over there?
Yeah.
Desmopressin promotes the release of
Von Willebrand factor.
And factor 8, okay, from the endothelial cells.
Mm-hmm. Yeah, this was not in the old book, but then they used to ask it. Was it there?
Explanation is there, but the figure is different.
Yeah, so here they have mentioned it. Desmopressin is stimulating the release of von Willebrand factor from the endothelial cell. Okay. Anything else? Any add-ons? Any pointers?
You did very well. You did very well already. Yeah, epsiximab is very important. Epsiximab, tyrofibin, eptifibatide, these Fib things.
Yeah.
These inhibit, directly inhibit this GB2B3. Restosetin, you said important. Yeah, this for von Willebrand's disease and Bernard-Solier.
Yeah. Mechanism, drugs comes up a lot. Yeah,
P2Y12 receptor blockers. We know that clopidogrel, prasugrel, ticagrelor, ticlopidine. These all are.
Yeah, so main difference is this is binding to the receptor itself. P2Y12 receptor is these drugs. Okay. Okay. All right. Thank you, guys. Let's take a 15-minute break. We'll be back to continue on with the coagulation cascade. Okay, thank you. See you all in 15.
Thank you, ma'am.
Okay. So we're done with thrombogenesis. Next, we have coagulation and kinin pathways. So here, message on the group. Okay, so here PT or prothrombin time monitors extrinsic and common pathways reflecting the activity of factors 1, 2, 5, 7, and 10. PTT monitors the intrinsic and common pathway reflecting the activity of all factors except factor 7 and 13. I think the mnemonic was you play tennis outside, so extrinsic, and you play table tennis inside, so that's intrinsic. I don't know if it was here or, yep. Okay, so that's the coagulation and kinin pathways. So what happens? Okay, so starting from the top, we have 12. So collagen, basement membrane, and activated platelets. So we were here, right? Coagulation cascade and activated platelets, temporary plug. So moving on here, so collagen, basement membrane, and activated platelets will convert 12 to 12A. 12A converts 11 to 11A. 11A converts 9 to 9A. 9A goes to the common pathway now. So this is the intrinsic pathway. Briefly, the extrinsic pathway, we have tissue factor or factor 7 converting or getting activated, so 7A. So tissue factor and 7A, they require calcium and phospholipid. So then tissue factor 7A activating 10 to 10A. So this is where these pathways converge. So
and tissue factor is 3A, right? If I'm not wrong.
3A, correct. Yeah. I think we had it in our old book. Yep. Tissue factor was 3A. Oops, never mind. Yep, tissue factor is 3A. Yes. Thank you, Amna. Okay. So here, so that's where both the pathways are converging. So just to, overview. So you were saying intrinsic pathway, we have starting with collagen-based membrane activated platelets, 12 to 12A, 9 to 9A, 11 to 11A, 9 to 9A, and then converging here, 7 to 7A, as well as tissue factor, which we said was 3A. They're also activating 10 to 10A. So now 10 to 10A, 10A is activating 2 to 2A, 2A is activating 1 to 1A, and the fibrin monomers are formed, and so on. And then we form a fibrin mesh, which stabilizes the platelet plug, which we had in primary hemostasis. All right, so let's look in depth. What is happening at the contact activation or intrinsic pathway? So factors are activated, and then we are also seeing inhibition of 12A by C1 esterase inhibitor, as well as 12A and 11A, both being inhibited by the C1 esterase inhibitor, which also inhibits kallikrein on the other side. So C1 esterase inhibitor deficiency, we saw it in immuno, I believe. Yeah. So if the C1 esterase inhibitor will lead to hereditary angioedema. Inhibitor deficiency. So normally this inhibitor keeps things in check. It's inhibiting kallikrein, so that high molecular weight, what was this, kininogen, I think? Yeah, high molecular weight kininogen breaks down to bradykinin in the presence of kallikrein. Bradykinin causes vasodilation, increases permeability, increases pain. C1 esterase inhibitors keeps this in check. If the inhibitor is deficient, we have too much bradykinin and causing too much vasodilation, permeability, and increased pain. Then, so that's the intrinsic pathway. What about extrinsic? The main thing they've added is this requires calcium and phospholipid, both these steps, 7 to 7A and 7A to going to activate 10 to 10A. So all these pathways actually require calcium and phospholipid. So that's tissue factor. Okay, so then coming to this box, what was happening here? 10 to 10A. Then 2 to 2A, 1 to 1A, 5 to 5A. So 5A is here. There was a mnemonic with 5 2s are 10. So that's for common pathway, right?
One, if you multiply 5 2 into 1, so it goes to be 10, right?
Say again, 5 and
5, 2, and 1. If you multiply all of them, so it's gonna be 10, right?
Yeah. Okay. So this 5 is 2 and this 10. So that's 5 into 2 is 10. Just to remember, help us remember what are the factors involved in the common pathway. Okay, so then 2A is or thrombin is converting 1 to 1A. So this is fibrinogen, which we saw over here. This fibrinogen is now converted to fibrin monomers. So 1 to 1A. These aggregate with calcium and form the fibrin mesh, which stabilizes the platelet plug. We also have 13 to 13A. What is 13? This is fibrin stabilizing factor. So it's stabilizing this fibrin monomers to form a mesh. So this mesh then breaks down. So when it's no longer needed, the fibrin degradation products are D-dimer, which is measured in the lab. So then coming to drugs or medications. We have regulatory anticoagulant proteins, which are protein C and S. So they are working to inhibit 5A and 8A. Protein CNS, so natural anticoagulants in the body, or anticoagulant proteins, or regulatory is a better word. Regulatory anticoagulant proteins are protein C and protein S. Then we have anticoagulants, which are drugs like heparin, low molecular weight heparin, and direct thrombin inhibitors, which are argatroban, bivalirudin, and dabigatran. These are all thrombin inhibitors, so they're working here. Then next, we have on this side anticoagulants, again, heparin, low molecular weight heparin like dalteparin and enoxaparin. Heparin, 10A inhibitor, direct inhibitors like apixaban and fondaparinux are all working at 10A level. So 10A, this is in the name. So they're inhibiting 10A. Then what else do we have? So then plasminogen.
Fondaparinux is a synthetic heparin.
Fondaparinux is synthetic heparin. Okay. Nice, thank you. So then plasminogen over here is converting to plasmin. And plasmin helps in converting the fibrin mesh to fibrin degradation products. So with the help of the enzyme, what was this TPA standing for?
Tissue plasminogen activator.
Thank you. Mind block with it. Tissue plasminogen activator. Yes. Plasminogen is activated to plasmin. Plasmin helps to break down the fibrin mesh to fibrin degradation products. Tissue plasminogen activator, which we use thrombolytics, alteplase, retaplase, and tenecteplase will activate tissue TTA. Antifibrinolytics, we have aminocaproic acid and tranexamic acid, which inhibit the TPA. What else is on this page? Hemophilia A is a deficiency of factor 8, X-linked recessive. Hemophilia B is a deficiency of factor 9, X-linked recessive. Hemophilia C, deficiency of factor 11, which is autosomal recessive. Kallikrein activates bradykinin, and ACE inactivates bradykinin. So which is why ACE inhibitors will increase bradykinin, which we already saw. Then C1 esterase inhibitor deficiency is going to cause hereditary angioedema. And factors requiring calcium and phospholipids are, so steps are 9 to 9A, 9A activating 10 to 10A. So yeah, I don't know how to remember this. Any mnemonics? How to remember calcium requiring steps?
7, 8, 9, like 7, 8, 9. And which we know that 5 2s are 10, right?
5
Common
2s are 10, so that's common.
And 7, 8, 9.
7, 8, 9. Okay, so for what is requiring? Yeah. Okay, nice. Then cofactor green box. So this is 5A and 8A require they are cofactors. Okay, 5A and 8A are cofactors. Okay. Okay, what else on this page? Any other mnemonics?
What is this gray arrow showing? Like C1 esterase inhibitor के नीचे ये वाला सारा
This one?
inhibit कर रहे हैं, हाँ ये सारा पाता कौन कर
2A, which is thrombin, is further activating so that it's promoting the coagulation pathway, right? So thrombin is further, once prothrombin is converted to thrombin, which is 2A, this is going and further activating conversion of 5 to 5A and activating or enabling 8 to 8A with von Willebrand, and also enabling 11A. 11 to 11A. So basically self-auto activation kind of. So I think 2A.
Yeah, thank you.
Thank you. So next, moving on, we have vitamin K dependent coagulation factors. We have procoagulation and anticoagulation. So is someone saying something? Okay. So vitamin K deficiency, there's decreased synthesis of factor 2, 7, 9, and 10 protein CNS. Warfarin inhibits vitamin K epoxide reductase. So that's the mechanism of warfarin. It's inhibiting epoxide reductase. Here, vitamin K administration can potentially vitamin K administration can potentially reverse inhibitory effect of warfarin on clotting factor synthesis, which is a delayed effect. FFP or PCC administration reverses the action. So fresh frozen plasma or PCC, which is prothrombin concentrate. This administration reverses the action of warfarin immediately. So vitamin K is delayed. FFP or PCC administration is reversing action of warfarin immediately and can be given with vitamin K in cases of severe bleeding. So this is a high yield fact. Neonates lack enteric bacteria, which produce vitamin K. Early administration of vitamin K overcomes neonatal deficiency or coagulopathy. So yeah, this is routinely done. Suppression of gut flora by broad spectrum antibiotics can also contribute to vitamin K deficiency. Factor 7, S for S. So S7 is the shortest half-life. Factor 2, longest, too long. So too longer for half-life. Okay. So this is procoagulation. So we're seeing in the liver. So first we have inactive 2, 7, 9, 10 CNS. In the presence of gamma glutamyl carboxylase, recall carboxylation enzymes are K dependent. K, C for C, K for K. So yeah, carboxylase, vitamin K dependent. So they converted to mature CNS and carboxylase 2, 7, 9, and 10. So these are clotting factors and CNS are regulatory factors. So we said they are anticoagulants. So anticoagulants, and it's going to work. So yeah, this mature CNS is now an activated protein C working on the anticoagulant side. And we have clotting factors also working with fibrinogen to fibrin conversion. So on the other side, when inactive are being converted to mature stuff. So here we have reduced vitamin K, which is active, is now an oxidized vitamin K, which is inactive. They are returned to its reduced state by epoxide reductase. So warfarin and liver failure are inhibiting the enzyme epoxide reductase. So in the case of liver failure, for example, if we don't have oxidized vitamin K converted to reduced form, we don't have carboxylation anymore. So we don't have 2, 7, 9, and 10 and protein, nor protein C or S. Okay, so now protein CNS, it's going over to the other side. So this is anticoagulation. Text reads antithrombin inhibits thrombin. Antithrombin inhibits thrombin, which is factor 2A, and factors 7A, 9A, 10A, 11A, and 12A. So antithrombin is inhibiting not just thrombin, which is factor 2A, but also 7A, 9A, 10A, and 11A, and 7, 9, 10, 11, 12. 7, 9, 10, 11, 12. Okay. So antithrombin is inhibiting thrombin and all these factors. Two A, 7, 9, 10, 11, and 12 A's. All right, so then heparin enhances the activity of antithrombin. Where is antithrombin here? So antithrombin. Heparin enhances the activity of antithrombin. Principal targets of antithrombin are thrombin and factor 10A. So although all of these factors are inhibited, the principal targets are thrombin and factor 10A. Factor 5 laden mutation produces a factor 5, which is resistant to inhibition by activated protein C. So I think this comes up. Factor 5 laden mutation produces a factor 5, which is resistant to inhibition by activated protein C, meaning it's become like a manic factor 5. It's not stopping. So factor 5 laden mutation produces a factor 5, which is resistant to inhibition by activated protein C. TPA is tissue plasminogen activator, is used clinically as a thrombolytic. Okay, so what is happening here? We have antithrombin 3 inhibiting 2A and thrombin, which we said was the main effect, principal target of antithrombin. And then this is further inhibiting conversion of fibrinogen to fibrin. So this is about antithrombin 3. On the other side, we have heparin, low molecular weight heparin, and direct thrombin inhibitors, which are directly inhibiting thrombin, which is nothing but factor 2A. Then, so on this side, we are having 9A, which is activated factor 9A, converting 10 to 10A. 10A converting to factor 2, which is prothrombin. Prothrombin converting to 2A, activated thrombin. So we have activated protein C coming from here, which is inhibiting. This requires its friend protein S, and both of these inhibit factor 8A. What is 8A doing? This is facilitating conversion of 10 to 10A. 9A is also enabling this reaction. 10A are direct factor 10A inhibitors. Okay, so those are the direct 10A, enoxaparin and stuff. Then 10A converting to 2. So this is facilitated by 5A. Okay, any better way to remember? I don't think of
We have a drug, right? MT say, which imitates what is the monoclonal antibody? You said that.
Imitates factor 8.
What's the drug?
Right?
Sorry.
Emicizumab.
Emicizumab. Okay, emicizumab. It functions like factor 8A, right?
Yeah, mimics factor 8.
Mimics factor 8, and the function, if you remember, it factor 9A and factor 10A.
Yeah.
Something like that. So it needs, it functions like factor 8, and it brings together this factor 9 and factor 10A together to, I think, to factor 9 and factor 10 to form activated factor 10A, something like that. If it's in page for monoclonal antibodies. So there it's specifically mentioned the function of that. Yeah, it's emicizumab. So target is factor 9A and factor 10. And it mimics factor 8 used for hemophilia A. So the target is factor 9A and factor 10. So here if you see that on that page.
Okay, so we can remember like that. You're saying nice.
Yes. So yeah, so factor 8 with the help of factor 9 and factor 10, it leads to activation of factor 10A, which is the common pathway, right? And it's with the help of 5A forms prothrombin. And prothrombin further converted into thrombin and all these things for the coagulation cascade. Right, and we need a factor activated protein C requires protein S, and they inhibits the factors factor 5 and factor 8. So on the one hand, protein C will inactivate factor 5, and on the other hand, it will inactivate the factor 8. Is factor 5 mentioned over here?
Yeah.
This book, they made it a little complex. Looks like the older one, it's clearly there. Do you have older version?
Yeah, older one.
Yeah, it clearly says what protein CNS does there. I'm having the older version.
Do you have the page number?
Older version 423.
423. Okay, thank you. Nice.
So I think I'm happy with this picture than the new one.
Yeah, this is much more like visually clearer. Yeah, nice.
Yeah.
Thank you.
Yeah. Just remember 2 pathways from thrombin. So these 2 are 2 different ways. And heparin and protein C pathway, they both are same product, but the way they act is differently. That's all.
So thrombomodulin complex from endothelial cells. This is it's converting protein C to activated protein C. Then C, as you said, requires S. And this, what do? They cleave and inactivate factor 5A and 8A. On the other side, thrombin, we have the antithrombin pathway. So antithrombin comes and sits on the thrombin. And then we also have a heparin-like molecule, which enhances the 83 activity. And then these two together, what do? They inhibit thrombin and 7, 9, 10, 11, and 12. But the main effect, as you said, was thrombin. Okay, nice. Yeah, I think I like this better. Thank you. Thank you. All right. So, yeah. So one more time, the text says, yes, thank you so much. So the text says, antithrombin inhibits So let me just put it side by side. Antithrombin, which is this grayish molecule here, antithrombin inhibits factor 2A and factors all of these 7, 9, 10, 11, and 12. So, but then next they said heparin enhances the activity of antithrombin 3. So this heparin-like molecule or heparin enhances the activity of antithrombin. The principal targets of antithrombin are thrombin, which is this triangle, and factor 10A. So the main targets are thrombin in the triangle and 10A. Okay, then they said factor 5 Leiden mutation. As the doctor said, factor 5 Leiden mutation produces a factor 5 that is resistant to inhibition by activated protein C. So that comes into here. So what is the protein C pathway? We have a thrombin and thrombomodulin complex coming from the endothelial cells. This is the complex, thrombin bound to thrombomodulin, yellow structure. So these will activate protein C to activate protein C. Protein C then needs its friend, which is protein S, and they both together cleave and inactivate factor 5A and 8A. So by inhibiting these factors, they're creating an anticoagulant effect. But factor 5 alone, as doctor said, they can be rowdy. So if there's a mutation, it produces a factor 5 that is resistant to inhibition by protein C. And then, yeah, so then we said TPA is clinically used as a thrombolytic. Okay. All right. And Hamna also brought up, this also is important, emicizumab, which is a monoclonal antibody, imitates factor 8. So this also will inhibit the target. It's also going to target 10A and 9A and 10A, thereby inhibiting coagulation. So anticoagulation. Okay, cool. Thank you. Thank you. Can we look at the UL question for heparin acting on E3?
Yeah, so just two anticoagulants we have to remember, right? One is natural ones, which is protein C and S, right? In fact, protein C, protein S is just a helper. And it cleaves factor 5A and factor 8A. And the other one is antithrombin. Then enhances antithrombin 3. And then antithrombin 3 basically goes and binds with the thrombin and factor 10A. So these are the two main ones.
Yes.
Okay.
So I think if you visually draw 5 and 8, you could just extrapolate C and S from that. Just to remember, C and S is 5 and 8. I don't know if that makes sense. So we have 5 and 8. Yeah, there we go. This popped up. So this is C and S. Just to remember, factor C, protein C and S work specifically on the 5 and 8. Okay.
Nice.
Thank you. Thank you. So then we just wanted to look at the question for heparin acting on 83. This one, right? So heparin's mechanism of action versus low molecular weight heparin. So here we're seeing antithrombin, which is the green one here. Then we have unfractionated heparin, which is having the pentasaccharide sequence. Pentasaccharide is binding to the antithrombin. And then factor 10A comes into the picture, and then this whole complex is formed. When thrombin binds, that's the tertiary complex. So because it's an unfractionated form, it's able to cover both. So it's able to form a ternary complex. Versus low molecular weight, it's having a low molecular weight, so it's having lesser of these saccharide sequence. It still has the pentasaccharide, but then fewer side chains. So antithrombin 3, when it binds, it is only able to block the factor 10A. So I think that was the key difference. LMWA only works for factor 10A versus unfractionated heparin or larger heparin molecules is going to attack both factor 10A as well as thrombin. So the objective
and go back. And it works much better with the thrombin than 10A, much better binding with 2A than 10A. If you read down, you'll see that. Let's read the factor, yeah.
Yeah, so unfractionated and low molecular weight heparins are commonly used for DVT prevention and in inpatient settings. Administration of heparin, which is a negatively charged chemical naturally present in mast cells, as we saw a bit ago, increases the effect of naturally occurring anticoagulant antithrombin 3, AT3. Unfractionated heparin binds to AT3 via a pentasaccharide in the heparin chain. This results in a conformational change of AT3, which subsequently inhibits factor 10A and neutralizes thrombin, promoting anticoagulation. AT3 activated by low molecular weight heparin, which has better bioavailability and does not need lab monitoring when given therapeutically, acts predominantly on factor 10A, not thrombin. Yes, so the objective was heparin is commonly used for the prevention of DVT in non-ambulatory patients or those undergoing elective surgery, especially hip and knee. Heparin increases the effect of naturally occurring anticoagulant antithrombin 3. So it's binding to antithrombin 3.
So, Saya, what's in a nutshell? Sorry, I just lost you. What's in the paragraph you read in simple words?
I think they're just saying the same thing. Heparin is a larger molecule, unfractionated, so it's able to cover both, inhibit both factor 10A and thrombin, versus low molecular weight, or this is only working predominantly on factor 10A.
Okay. Heparin is a negative charged molecule, right?
Yep. Negatively charged chemical naturally present in mast cells as well. It's a large negatively charged molecule, yeah.
Present in mast cells as well as basophils, right?
Yeah, basophils also we saw. H and H. Histamine and heparin. Yep. So moving on, next we have moving on to pathology. We have RBC morphology on this page, and then continued, and then RBC inclusions, and then anemias. Okay, let's see. Any other pointers, add-ons for coagulation, anticoagulation, procoagulation? Are we good? Okay. So next we have moving on to RBC morphology. What are acanthocytes? These are spur cells, and yep, so we're seeing spurs on the cells, liver disease, A beta lipoproteinemia, and vitamin E deficiency. Projections of varying size at irregular intervals. Acanthocytes are asymmetric. This is important versus another cell which is coming up right here. So echinocytes, which are Burr cells, these are seen in liver disease, end-stage renal disease, pyruvate kinase deficiency. These are smaller and more uniform projections than acanthocytes, and echinocytes are even. Acanthocytes asymmetric, yeah. So spur cells, acanthocytes mean the same thing. Echinocytes, Burr cells, they are even. Next, we have dacrocytes or teardrop cells associated with bone marrow infiltration, example, myelofibrosis. So yeah, DACT refers to, for example, dactylitis gland, right? Tear glands. So dacrocytes are teardrop cells. So RBC sheds a tear because it's mechanically squeezed out of its home in the bone marrow. Yep. So RBC is shedding a tear because it's mechanically squeezed out from its home because of myelofibrosis. Next, we have schistocytes, which are helmet cells seen in MAHAs like DIC, TTP, HUS, HELP syndrome, mechanical hemolysis in the case of heart valve prosthesis, and then nodes of fragmented RBCs. Then we have degmacytes or bite cells, this seen in G6PD. This is high yield. It's due to removal of Heinz bodies by splenic macrophages. They deg them out of or bite them off of RBCs, so degmacytes. Okay, nice. Next, we have elliptocytes, hereditary elliptocytosis, so caused by mutation in genes encoding the RBC membrane, like spectrin and ankyrin, which we'll be seeing later. So yeah, acanthocytes.
What is the name for degmacytes? It's not in the, it's a new one.
Say again, sorry. Bite cells are also known as degmacytes.
And what's the mnemonic for that?
Deg them out of or bite them off of RBCs.
Okay.
Splenic macrophages bite the Heinz bodies out of the RBCs as the mnemonic.
Thank you.
You're welcome. So yeah, acanthocytes are asymmetric with the spurs. Echinocytes or Burr cells are even. They also have the spurs, but evenly distributed. Tachycytes or teardrop cells seen in myelofibrosis. Yep, because the bone marrow shedding a tear. Schistocytes, helmet cells seen in Mahas, mechanical hemolysis. These are fragmented RBCs. Degmacytes are bite cells, G6PD seen in G6PD deficiency due to removal of Heinz bodies by splenic macrophages. The bite cells are formed. Elliptocytes, hereditary elliptocytosis, caused by mutation in the genes encoding the membrane. So the membrane stability is lost, so they become oval or elliptical, so elliptocytes. Next, we have spherocytes, hereditary spherocytosis and or IHA. So these cells are small, spherical, without the central pallor, and there's decreased surface area to volume ratio. Macroovalocytes seen in megaloblastic anemia, also hypersegmented PMNs as well. So your macro big cells and they're oval. Then we have target cells, HBC disease. So halt said the hunter to his target. So what is halt? HBC, asplenia, liver disease, and thalassemia. Here there is increased surface area to volume ratio versus spherocytes, decreased surface area to volume ratio versus target cells have increased surface area to volume ratio. This is halt, HBC, asplenia, liver disease, and thalassemia. Sickle cell anemia. Sickling occurs with low oxygen conditions, example, high altitude or acidosis. HBS concentration like dehydration. We saw target sign yesterday. Anyone remembers?
Yeah, it is in that Hirschsprung.
Wasn't it intersusception?
Yes, yes. Isn't it Hirschsprung?
No,
Hirschsprung it's different or the same? I know it is intersusception. Hirschsprung intersusception. Yes, this is the one.
Yeah.
Because
Target sign intersusception.
Yeah. What is Hirschsprung then? Why did I say Hirschsprung?
Hirschsprung was the transitional zone, right? This we see transition.
Right. Oh, I messed it up. Okay, yeah.
No worries. It's okay. We're all learning. So next so target cells are seen in halt. So that's HBC. Where was I? Yeah, HBC, asplenia, liver disease, and thalassemia. So this is target cells. All right, so that's done with the RBC morphology. So next we have RBC inclusion.
Sorry, there is some concept now regarding this in decreased surface area to volume ratio and increased surface area to volume ratio.
Decreased surface area compared to the volume. Here we have increased surface area compared to the volume. It kind of makes sense, right? If you surface area is always what is measurable. So if you open this up and measure it, here it is lesser because it's a smaller cell, versus here it has more surface area but lesser volume. So I mean, yeah, I don't know how to verbalize this, but yeah, okay, we'll see later.
I would recommend listen to Patamagai. He did very well. Yeah.
Yeah, thank you. Yeah, maybe later we can look at his notes maybe. So yeah, so decreased surface area to volume ratio seen in spherocytes and increased surface area to volume ratio seen in target cells. Okay. So next we have RBC inclusions. What are these inclusions? Potential inclusions, we see iron granules in the bone marrow cells. And here peripheral smear, Howell-Jolly bodies, basophilic stippling, Pappenheimer bodies, and Heinz bodies. So first, iron granules, the associated pathology is sideroblastic anemias, example, lead poisoning, myelodysplastic syndromes, and chronic alcohol overuse. Okay, so all sideroblastic anemias, including lead poisoning, myelodysplastic syndromes, chronic alcohol overuse. We have perinuclear mitochondria with excess iron, and excess iron, we also saw it yesterday, iron is always tested with Prussian blue staining to be visualized. So perinuclear mitochondria with excess iron forming ring in the ringed sideroblast. So this requires Prussian blue stain to be visualized. So one more time, perinuclear mitochondria. So it's saying around it, perinuclear mitochondria with excess iron So they forming a ring in ringed sideroblasts. Perinuclear mitochondria with excess iron, and they require Prussian blue stain. Okay. Ringed sideroblasts. I think we have images later on. So next, inclusions which are visualized on peripheral smear. These are Howell-Jolly bodies, basophilic stippling, Pappenheimer and Heinz. So what is Howell-Jolly bodies? These are seen in functional hyposplenia or sickle cell disease, asplenia. Notes, basophilic nuclear remnants. They do not contain iron. They're usually removed by splenic macrophages. So these are basophilic nuclear remnants. So they're remnants, so they don't contain iron, and they're removed by who? By splenic macrophages. Okay, then we have basophilic stippling, seen in sideroblastic anemia and thalassemias. What are these? These are basophilic ribosomal precipitates, and they do not contain iron. Basophilic nuclear remnants for Howell-Jolly bodies, basophilic ribosomal precipitates for basophilic stippling. So this is seen in sideroblastic anemia and thalassemias. Then Pappenheimer bodies is specific for sideroblastic anemia. Here we have basophilic granules and they contain iron. So Pappenheimer bodies. So think hammer, think iron hammer. So Pappenheimer contain iron, basophilic granules containing iron. So all these three, Howell-Jolly, basophilic stippling, and Pappenheimer are basophilic. Howell-Jolly is nuclear remnants. Basophilic stippling is ribosomal precipitates, and this is iron-containing basophilic granules. Then we have Heinz bodies, which are seen in G6PD deficiency. What are these? These are denatured and precipitated hemoglobin, which contain iron. So yeah, HB, so it's in the name, hemoglobin. So denatured and precipitated hemoglobin containing iron. Phagocytic removal of Heinz bodies leads to bite cells, which we saw. They're also known as degmacytes. Then requires supravital stain like crystal violet to be visualized. So we're seeing this Heinz body. If the macrophages punch or dig this out and bite it, then that becomes a bite cell. Okay. So what are the RBC inclusions? We have iron granules seen in sideroblastic anemia, lead poisoning, myelodysplastic syndromes, chronic alcohol overuse, perinuclear mitochondria with excess iron, forming the ring in ringed sideroblast. So with excess iron. So iron granules, ringed sideroblasts, require Prussian blue, Howell-Jolly, basophilic nuclear remnants, basophilic stippling, basophilic ribosomal precipitates, Pappenheimer, basophilic granules containing iron, Heinz bodies, denatured and precipitated hemoglobin. Howell-Jolly seen in functional hyposplenia or asplenia. So anything to do with the spleen, we're going to see Howell-Jolly bodies. Spleen is jolly. Okay. Then sideroblastic anemia, thalassemias, these are seen in basophilic stippling, sideroblastic anemia, Pappenheimer bodies. So sideroblastic anemia pretty much has iron granules, basophilic stippling, and Pappenheimer bodies. So either of these can be used in the question stem. G6PD is for Heinz bodies. G6PD and degmacytes is unique for degmacytes and Heinz bodies are unique for G6PD. All right, so now moving on. Next, we have anemias. Anemias broadly divided.
I have written something. So Howell-Jolly bodies, only one per cell, right? Just to remember. Heinz bodies are multiple. It could be multiple. Ketchup. So yeah. But Howell-Jolly bodies is usually only one per cell. And
what? Meaning?
Means Howell-Jolly bodies, they are usually like one per cell. But Heinz bodies, they can get
one per cell. Okay.
Yeah. So, and these ringed sideroblasts, they are always in the bone marrow. So these are sideroblasts are normal iron granules. Iron granules in the mitochondria of immature nucleated RBC precursors found in the bone marrow. So like sideroblasts are the normal iron containing granules in the mitochondria
of immature nucleated RBC precursors, which are found in the bone marrow. So that is why in the bone marrow we find these when the iron accumulation, so ringed sideroblasts. So normally sideroblasts are there, but they form a just ring of iron around them.
So normally sideroblasts are there. In these conditions, they form a ring in the ringed sideroblast. Okay.
Yes. So these are normal iron granules. Iron containing granules in the mitochondria of immature RBCs, nucleated RBCs.
Okay, immature nucleated RBCs.
But here what happens in sideroblastic anemias, like lead poisoning and myelodysplastic and alcoholism, perinuclear mitochondria with excess iron, so forms a ring around the ring sideroblasts.
Nice, thank you. So difference between sideroblasts versus the sideroblasts seen in sideroblastic anemia. So these are ringed sideroblasts is what we need to remember. Iron granules, form of a ring. Okay.
Yes, thank you.
Thank you for adding.
Yours is actually very nice. I have always very confusion with this Pappenheimer. So what did you say about hammer thing?
It's hammer. I mean, this was your first year mnemonic. Hammer contains iron, right? So just Pappenheimer to remember they contain iron in sideroblastic.
Okay, so this one contains iron and Heinz bodies contain iron because it's denatured hemoglobin, right?
So both contain iron. So to differentiate this, Pappenheimer is for sideroblastic. Heinz is for hemoglobin. So HB also. So this is for G6PD.
Okay. Basophilic stippling, we know that it's a basophilic thing, but no iron.
Yeah.
Precipitates. Okay. Thank you.
No worries.
And it's ribosomal RNA in it.
Yeah, ribosomal RNA. How to remember this? Nuclear remnants, Howell Jolly. Ribosomal precipitates, basophilic stippling. Basophilic granules with iron is Pappenheimer. Okay, that's Pappenheimer sorted. Basophilic stippling is basophilic ribosomal precipitates. Burp.
These are blue things, no? Mostly to ribosomal precipitates, but no iron.
Yep. Burp. Just remember basophilic stippling is burp, which is P for basophilic, R for ribosomal, P for precipitates.
Yeah, but good.
All right, thank you. So next we have anemias, broad classification, microcytic, normocytic, macrocytic. When we say microcytic, what do we mean? MCV less than 80. Normocytic MCV 80 to 100. Macrocytic MCV more than 100. Okay. Then what are the microcytic types? The hemoglobin is affected. So
Excuse me 1 minute, please. Can you go back upstairs? Does it say Pappenheimer contains iron?
the granules
Contains iron. Okay,
Yeah.
the contain iron. This does not contain iron. This also contains. So everybody contains iron except for this guy. Looks like our basophilic stripling. No, this one does not contain also. Howell and basal, they both don't contain. Okay.
Yes.
Python and Hyman have the iron. Okay. There was a NVMe question on this about the iron story. And then 2019 and 20 version had some mistakes also. Now they corrected it. So yeah. Okay. No iron and iron. Thank you. Thank you. You can go back. Yeah, thanks.
All right. Thank you. So yeah, what are the macrocytic anemias? The hemoglobin is affected here. So tail, thalassemias, anemia of chronic disease, iron deficiency, and lead poisoning. So what is the pathology in thalassemias is defective globin chain synthesis. In this AIL, we have defective heme synthesis. So it's anemia of chronic disease, iron deficiency, which is late, and lead poisoning. Contrast with iron deficiency early, which is can be normocytic in the early phases. All right, so this is done. Now coming to macrocytic. Macrocytic is more than 100. So then we further subdivide into megaloblastic and non-megaloblastic. Non-megaloblastic is Diamond-Blackfan anemia, liver disease, and chronic alcohol use. Then megaloblastic, what is the problem here? The DNA is affected. Either there's defective DNA synthesis or defective DNA repair. So under defective DNA synthesis, we have folate deficiency, B12, which we're familiar, as well as orotic aciduria, which we did in biochem. So defective DNA repair, the condition is Fanconi's anemia. So that's macrocytic. Now coming to normocytic, 80 to 100, we further subdivide them into non-hemolytic or hemolytic. So the key difference would be there is a low reticulocyte index in non-hemolytic. Hemolytic, there is high reticulocyte index. So this makes sense. Hemolysis, we're destroying RBCs. So more of the precursors are generated. So there's a high, precursors are the reticulocytes. So high reticulocyte index. All right, so let's finish this. So non-hemolytic, we have a low reticulocyte index, iron deficiency anemia in early phases. Anemia of chronic disease can either be microcytic or normocytic. Aplastic anemia, chronic kidney disease, and acute blood loss like hemorrhage. So yeah, this makes sense, acute blood loss. There's no time for the bone marrow to compensate, so it makes sense that there is a low retic count. Iron deficiency, no matter how much the bone marrow tries, there's no iron, so it doesn't happen. Anemia, same thing. The iron is stored away, stacked away in the macrophages, so it's not available. Aplastic anemia, synthesis problem, I think. Aplastic anemia. Chronic kidney disease, why will there be? Okay, for some reason, there's no compensation, so they have a low retic count. I think we're going to see them in detail. Okay, let's see. So then hemolytic, what are the broad subtypes? We have intrinsic and extrinsic. Extrinsic is either autoimmune, microangiopathic, macroangiopathic, and infections. So normocytic anemia with a high retic count with extrinsic reasons are autoimmune, microangiopathic, macroangiopathic, and infections. So normocytic anemia with a high retic index, but intrinsic issues, intrinsic meaning something to do with the RBC itself. So here we have membrane defects, enzyme deficiencies, or hemoglobinopathies. So these membrane defects are hereditary spherocytosis, paroxysmal nocturnal hemoglobinuria, then enzyme deficiencies, G6PD, and pyruvate kinase. Then we have hemoglobinopathy, sickle cell anemia, and HBC disease. So that's the big picture for the anemias. All right, next moving on to reticulocyte production index. This is also called corrected reticulocyte index, used to correct falsely elevated reticulocyte count in anemia. It measures the appropriate bone marrow response. So what does it measure? This measures the appropriate bone marrow response to anemic conditions, and it checks whether there is effective erythropoiesis going on. So a high RPI index, more than 3, indicates compensatory RBC production. And a low RPI, less than 2, indicates inadequate response to the corrected anemia. Quick memory jog, we saw PNH in immunology. What was the gene defect? Anyone remembers?
Piga
gene. And then yesterday we saw SPINK1 gene was in?
Chronic pancreatitis.
Yes. And then SERPINA, you said, was the alpha thing, right?
Alpha-1 antitrypsin.
Yes, nice. Thank you. And what was a drug used in PNH? Something we had said in immunology.
Eculizumab.
Yes, eculizumab. Yeah, mnemonic thing, cool at night. So cool, nocturnal, eculizumab. All right, so coming back.
For chronic pancreatitis, what was the gene?
SPINK1, SPINK1, right?
Ah, thank you.
Yes, you're welcome. All right, so coming back, reticulocyte production index. This is also called corrected reticulocyte count. It's used to correct falsely elevated retic count in anemia. So we said this measures appropriate bone marrow response to anemic conditions, effective erythropoiesis. A high RPI more than 3 indicates compensatory RBC production is going on. If there is a low RPI, which is less than 2, then that indicates that there's an inadequate response to correct anemia. So what is the formula? We have RPI equals percent reticulocytes into actual hematocrit divided by normal hematocrit divided by maturation time. I haven't seen a formula really on this. It's more like interpretation. Okay, high RPI, compensation occurring, low RPI, inadequate compensation. All right, next we have interpretation of iron studies. This is high yield, super yield. We have serum iron, transferrin or TIBC, ferritin, and percent transferrin saturation, which is serum iron divided by TIBC. Okay. First, we have iron deficiency. So yeah, iron is less. Transferrin or the transport form or TIBC is going to be high. Ferritin, which is storage form, is going to be low. Percentage transferrin saturation is going to be very low because there's no iron available. Then chronic disease, anemia of chronic disease, serum iron is low because it's stacked away. Transferrin or TIBC is low. There's no transfer is happening. So what did they say? Evolutionary reasoning. Okay, we'll get to it. Ferritin is high storage form. So that's the primary disturbance. Yes, this is a primary disturbance. And transferrin percent saturation can be variable. So this is normal or decreased. So what is it saying? Evolutionary reasoning. Pathogens use circulating iron to thrive. The body has adapted a system in which iron is stored within the cells of the body and prevents pathogens from acquiring circulating iron. So that makes sense. So next we have hemochromatosis. We did this yesterday. Here we have serum iron is high, which is the primary problem. We said HFE gene mutation, high hepcidin, yada, yada. So serum iron is high. Transferrin or TIBC, which is a transport form, is going to be less. We said only transferrin and one more thing was less. Okay, ferritin is high. Percent transferrin saturation, there's lots of iron, so saturation is going to be really high. Hamna, you said something other than TIBC or transferrin.
Other than transferrin or TIBC, everything is high, right?
Everything is high. I think hepcidin we said was also low. So hepcidin and transferrin or TIBC is the only thing that is low, right? Correct?
Yeah, hepcidin is low.
Okay. All right, so that was hemochromatosis. Then we have pregnancy or OCP use. Here, serum iron. So the main problem here is transferrin or TIBC is increased and transferrin saturation is less. So transferrin transports iron. So the transferring protein is going to be high. I think it's something to do with the globulin productions, but I'm not sure.
No,
right.
binding protein is
Binding
high.
proteins are high, right? In pregnancy and OCPs, yeah. Okay, thank you. So yeah, so binding proteins are high. So transferrin is a transporter, so that's going to be high, and saturation is going to be less. And this is okay. So TIBC indirectly, as you said, TIBC indirectly measures transferrin. So transferrin TIBC is saying the same thing. Ferritin is the primary storage protein of the body. Yeah, evolutionary reason we did. Okay, cool. So that was anemias, broad picture, reticulocyte index, and interpretation of iron studies. Here, the main thing is increased transferrin and decreased saturation. Okay. All right. So now coming on to individually.
If you look at the pattern, everywhere where ferritin is high, transferrin or TIBC is opposite to that, right?
Nice. So ferritin and transferrin are opposite to each other. Okay. So next, looking individually, first we have microcytic anemias. Then we have Microcytic continued. So yeah, all these things we're elaborating now. What were the microcytic? Tail. So defective globin chain, thalassemias, defective heme synthesis, AIL, anemia of chronic disease, iron deficiency, late stage, and lead poisoning. All right, so let's see. So first we have microcytic anemias. By definition, MCV is less than 80. Iron deficiency is first here. Decreased iron either due to chronic bleeding, like GI blood loss or heavy menstrual bleeding, malnutrition, absorption disorders, GI surgery like gastrectomy, or increased demand as in pregnancy. This is the decreased final step in heme synthesis. What are the labs? We would see decreased iron, increased TIBC, and just we said they're opposite to each other. So if TIBC is high, ferritin is low, increased free erythrocyte protoporphyrin, increased RDW, and decreased retic index. Microcytosis and hypochromasia, which will increase the central pallor. And distribution width is high, meaning there's more distribution. There's different size of cells. Some are smaller, some are larger in size. So increased distribution width. Symptoms. What are the symptoms of iron deficiency anemia? We have fatigue, conjunctival pallor. They have images. I don't know where. Okay, so fatigue, conjunctival pallor, restless leg syndrome. This came up in psych. They have an association with, it has an association with iron deficiency. Pica, also seen, we saw it in psych. So restless leg syndrome, iron deficiency anemia associated. Pica, which is persistent craving and compulsive eating of non-food substances associated with iron deficiency. And spoon nails, which is koilonychia. This may manifest as glossitis, chelosis, and Plummer-Vinson syndrome. What is Plummer-Vinson syndrome? It's a triad of iron deficiency anemia, esophageal webs, and dysphagia. All right, so that's done with iron deficiency. Key points to remember: low iron, high TIBC, low ferritin, increased free erythrocyte protoporphyrin, increased RBC distribution width, decreased retic index. Microcytosis and hypochromasia, so there's increased central pallor.
This is the only condition where we have increased RDW, right?
All right, so as of now, only increased RDW is in iron deficiency. Okay. Yes. All right, so next we have alpha thalassemia. What is alpha thalassemia? There's an alpha globin gene deletions on chromosome 16, leading to decreased alpha globin synthesis. It may have cis deletions, which means deletions occurring on the same chromosome, or transdeletion, deletions occurring on separate chromosomes. Normal is alpha alpha bar alpha alpha. Often there's increased RBC count in contrast to iron deficiency anemia. There's increased RBC count. In the iron deficiency, there will be decreased count. Okay. Increased prevalence in people of Asian and African descent. Target cells are seen on peripheral smear. So central pallor, conjunctival pallor, and target cells. Yeah, so central pallor with IDA, conjunctival pallor with IDA, and target cells with alpha thalassemia. Okay, so back to this. So yeah, number of globin genes deleted, what's the disease, and what's the clinical outcome? So if we have alpha, 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 so there's two different alleles, then beta chains is separate. So the main pathology is alpha thalassemia, is the alpha chain problem. So if one alpha globin gene is deleted, it's causing alpha thalassemia minima, clinically silent. So it's a silent carrier with no anemia. In the second version, there is both the alpha chains on a single, or that would just cis deletion, or in different chromosome, that is trans deletion. So if there's two alpha gone, that's alpha thalassemia minor, presents with mild microcytic hypochromic anemia. Then we are losing three alphas, two on one chromosome, and the another chromosome, we have another alpha gone. So total three alpha defective or mutated. That is HBH disease. We have excess beta globin forms. So moderate to severe microcytic hypochromic anemia. Okay, so then the fourth option is all the four alpha chains are mutated. So that is hemoglobin Bart's disease, no alpha globin synthesis at all, excess gamma forms gamma-4. So this presents with hydroxytalis and incompatible with life. Yeah, and this one was moderate to severe microcytic hypochromic anemia. So in order of severity, first this is silent, then mild. This is moderate to severe microcytic hypochromic. Here it is hydroxytalis and incompatible with life. Okay, so next, so that was alpha thalassemias, iron deficiency anemia, and alpha thal completed. Next, moving on to beta thalassemia. Here we have, sorry, one more time, this was a deletion in the genes. Alpha globin gene deletions on chromosome 16. Versus now we're seeing point mutations in splice sites.
That
Or
is also important. Okay, yeah.
what?
That is also important. Chromosome 16.
I don't know. I think so.
Yes, ma'am. It
They
is.
are
It is.
usually
It
mentioned
is.
in the question stem, right? Chromosomes. This was.
Yes, it is.
Okay. And there's something about the cis and trans. Do you remember? I think in the previous book, they say that the cis deletions may worsen outcome from for the carrier's offspring. So cis deletion, I think, is bad.
Yeah, cis is bad. Cis was bad or cis was better?
No. Trans was bad, I think, because you are affecting both the genes in both the chromosomes, whereas cis is affecting only one chromosome. Let me see. What does
I
it say?
think
Cis
so, because we
deletion may.
used to say cis is okay. Because
Cis is okay.
we like the sister we used to say,
Course
but I
not.
don't remember. Let me see.
No,
Here it
cis
says,
deletion may worsen the outcome. May worsen the outcome because both are in the same gene you're affecting.
no,
Trans
cis,
may help out because one is there, one is not.
yeah, sorry, I was wrong then. Cis deletion worsens outcome for the carrier's offspring. Cis deletion is worsening the outcome. Okay. Because cis is on the same chromosome, so cis is a worse outcome. Okay. Cis worsens outcome. Okay. So alpha globin gene deletions on chromosome 16, decreasing the alpha globin synthesis. So here we have point mutations in splice sites or Kozak consensus sequence promoter on chromosome 11. So this leads to decreased beta globin synthesis or beta plus or absent globin synthesis, beta 0. This is increased prevalence in people of Mediterranean descent. Okay. Okay. So here, what are we seeing? Number of beta globin genes mutated versus the disease versus the outcome. So if it is one beta gone, it's beta thalassemia minor, mild microcytic hemochromic, mild microcytic anemia. So there's increased HbA2. If it's two deletions, so two beta plus, or either it's reduced synthesis in both the copies, or one has having reduced synthesis and one is completely absent, then this is beta thalassemia intermedia, that is variable anemia ranging from mild to asymptomatic to severe transfusion dependent. Then when both the beta is deleted, that is beta thalassemia major, also known as Cooley's anemia. Here there is severe microcytic anemia with target cells and anisopoikilocytosis. So they're not uniform and there's different shapes. So increased anisopoikilocytosis requiring blood transfusion, increased risk of secondary hemochromatosis because of the transfusions. Marrow expansion, crew cut is usually mentioned. Crew cut on cell X-ray, skull X-ray. Crew cut on skull X-ray. I think they've given that image on one of the questions on UWorld. So this leads to marrow expansion. So it's leading to skeletal deformities and extramedullary hematopoiesis. And this will present as hepatosplenomegaly. And this is high yield. It is increased risk of parvovirus B19 induced aplastic crisis in beta thal major. There's increased HbF and increased HbA2. This becomes symptomatic after 6 months when HbF declines, because HbF is protective until that point. Chronic hemolysis can also lead to pigment stones, which we saw yesterday. The thalassemia pigment stones. Okay, then the third variant is when beta, so this is beta plus HbS.
How would you correlate this picture? Sorry, I didn't get it. So beta, and where is 1 and where is 2? What is happening in 1?
This one?
The picture, yeah.
So one of the beta is defective. In the chromosome, we have 2 beta copies. One is completely gone. The second option, they're in both the alleles, this one is reduced synthesis, or both are having reduced synthesis. One is reduced and one is completely absent. That's intermedia. Beta thalassemia major, both the copies are gone in the chromosome. What is this numbering? I don't know if it's, I think one of the gene, there is a combination. Right? 1, 2, then it says 2, 1. So I don't know what that means. So I think 2 copies.
Yeah, so basically it's telling you the amount of defective gene, like the beta globin genes. So the first one is just 1 defective beta globin gene. The second one is 2 defective beta globin genes. Then the third one, 2 defective. Then the fourth one, 1 defective.
Okay, thank you. So that makes sense. The number of beta globin genes that are mutated, here it's only 1, here is both, but variable. Here it is both copies are gone. Here it is 1 copy. On one of the copy, what happens is one is producing less beta chains and the other one is sickled, or one is producing absent beta chains and it is sickled also. So this is a combination of sickle cell and beta thalassemia. Does that make sense, Amna?
Okay, beta, so both are gone in 2. So it's Cooley's anemia, beta thalassemia major. In beta thalassemia minor, it's only 1 is gone, right?
Yes.
Okay, and here it's beta thalassemia intermediate. Okay.
Yes, it's intermediate because there is some production of beta, but not sufficient. So that's intermediate. Here it is a combo, so sickle cell beta thalassemia. Here it's mild to moderate sickle disease, depending on whether there is decreased beta plus HbS or completely absent. If it's completely absent, it will be a moderate sickle cell anemia.
Okay. Okay, so in this case, hemoglobin A2 will be high in both of them.
Sorry?
In this case, hemoglobin A2 will be high, right? Which is alpha 2, delta 2.
Yeah, correct. Yes, correct. Since the beta chains are not there, it's shunting towards A2 production, which has the alpha 2, delta 2 chains. Yes, correct. Okay.
Thank you.
You're welcome.
Then we also see in the first one, minor also has increased A2.
Minor also has increased A2. Yes. Sorry, give me a second.
The first one is minor, then intermediate, and then the major, right? So the first one I'm talking about. Minima.
Yeah, this also has increased HbA2, yes. So the minor and the major, so here also increase HbO2 as well as increase HbA2, sorry. These two are having increased HbA2. I think that would be in all of them though, technically speaking, because there's no beta or less beta chains. They would have upregulated synthesis of HbA2, if I'm not wrong. But anyway, so if you want to stick to the text, beta thalassemia minor and beta thalassemia major both have elevated HbA2, and this one additionally fetal levels also. When it declines is when it starts presenting. So BARTS, which is the gamma, Bart's, think farts, and Grama farts, so that was 4 chains, and Hasib Hussein has 4 betas. So HBH, which is B4, that's the mnemonic I was trying to recall. So yeah, there is all 4 beta chains in that one, this one, HBH disease. Okay. All right, so next we have lead poisoning. So lead inhibits enzymes, 2 enzymes, ferrochelatase and ALA dehydratase, leading to decreased heme synthesis and increased RBC protoporphyrin. Also inhibits rRNA degradation, leading to, which is causing RBCs to retain aggregates of rRNA, as we saw earlier. Basophilic stippling is BERP, which is residual rRNA. So one more time, lead poisoning inhibits ferrochelatase and ALA dehydratase, decreasing heme synthesis and increasing RBC protoporphyrins. Also inhibits rRNA degradation, leading to RBCs retain aggregates of rRNA, and that's presenting as basophilic stippling with lead poisoning. Symptoms of lead poisoning, LLEEAA. So everything is double letters except the D. So lead poisoning. Lead lines on gingiva, which are also known as Burton's lines, and on metaphysis of long bones on X-rays. E for encephalopathy and erythrocyte basophilic stippling. A for abdominal colic and sideroblastic anemia. D for drops, which is wrist and foot drop. How do we treat? We relate with Succimer, EDTA, and dimercaprol, which we saw in the immunology or biochem somewhere, previous page with the antidotes. Exposure risk is increased in old houses built before 1978 with chipped paint, children, and workplace adults. Old houses with chip paint in children's and workplace in adults. Okay. So that's lead poisoning. Next, we have sideroblastic anemia. Causes are genetic or acquired. So this can be genetic, which is X-linked defect in ALA synthase gene, or acquired as in myelodysplastic syndromes. Reversible causes, alcohol most common. Others are lead poisoning, vitamin B6 deficiency, copper deficiency, or drugs like isoniazid and linezolid. So this we saw, they cause sideroblastic anemia. So one more time, causes, broad categories can be genetic, acquired, and reversible. What are the genetic causes? Which is an X-linked defect in ALA synthase gene. Acquired causes, myelodysplastic syndromes. Reversible causes, alcohol most commonly, followed by lead poisoning, B6 deficiency, copper deficiency, and drugs. What are drugs? Isoniazid and linezolid. So what are the lab findings in sideroblastic? We said, we all saw this. So increased iron, normal or decreased TIBC, increased ferritin. Yep, so increased iron, normal or decreased TIBC, and increased ferritin. We have ringed sideroblast, which with iron-laden Prussian blue stain mitochondria. So we saw this when we did the cells. And peripheral blood smear shows basophilic stippling of RBCs. Some acquired variants may be normocytic or macrocytic. Yeah, as Hamna said, the sideroblasts are immature RBCs, which are nucleated. Here, they are specifically ringed sideroblasts with iron-laden Prussian blue stained mitochondria, which are seen in the bone marrow. Ringed, so in the peripheral blood smear, we see basophilic stippling of RBCs. Some acquired variants may be normocytic or macrocytic. How do we treat? We give pyridoxine, which is B6, a cofactor for ALA synthase. So we're upregulating ALA synthase enzyme. So yeah, this was the crew cut or extramedullary, was it? No. These are Burton lines or metaphysis of long bones on X-ray. Crew cut will be in the skull. I think UWorld has a good image on that. So these are lead lines. Okay, also known as Burton lines on the long bones, metaphysis of long bones for lead poisoning. All right, so that's done with this page.
That's the cause for ribosomal RNA, and lead inhibits ribosomal RNA degradation. We saw something, right? Regarding ribosomal RNA and basophilic stippling. We said that
basophilic stippling, we said they are the ones which it's the basophilic ribosomal precipitates. So this is the reason. Lead is inhibiting RNA degradation. So it builds up, and that appears as a basophilic stippling. So yeah, nice.
So that's the reason in both of them, right? Basophilic stippling in lead poisoning and in sideroblastic anemia.
Correct. Yep.
Okay.
So here lead is inhibiting directly. Here, actually, I'm not sure if it's the same reason. Here, it makes sense that the lead is inhibiting RNA degradation. In sideroblastic, lead poisoning secondarily is causing sideroblastic. So that is the overlapping point. But in others, I don't know how. Not sure.
Yeah, lead poisoning causes basophilic stippling, right? So sideroblastic anemia also causes basophilic stippling. Both of them, actually. So 3 causes of basophilic stippling: sideroblastic anemia, lead poisoning, and thalassemias.
Yes, agreed. So stippling is in lead, sideroblastic, thalassemias. Yeah, but the underlying reason, if the sideroblastic is not because of lead, I'm not sure. Anyway, we'll find out. So anyway, here we see ring sideroblast on the bone marrow and peripheral blood smear. There's basophilic stippling of RBCs. So I guess the main cause itself is probably inhibiting RNA degradation. Anyway, I'll find out later. So that's a question. So, all right. So next we have macrocytic anemias. These are by definition MCV more than 100. Megaloblastic anemia is first, secondary to folate and B12, then orotic aciduria. So all can cause megaloblastic. Okay, then we're going to non-megaloblastic anemia, diamond blackfin. Then next page we move on to normocytic. All right, so this is all about macrocytic anemias. By definition, MCV MCV more than 100, and we said non-megaloblastic versus megaloblastic. So when we have megaloblastic, we said, I'm reading from the previous page, we have DNA affected. DNA is affected. It's either defective DNA synthesis or defective DNA repair, which is Fanconi's, which is not here. Okay, I guess we'll see it later. So, all right, so coming to megaloblastic anemia, here there's impaired DNA synthesis. There's maturation of nucleus of precursor cells in bone marrow delayed relative to the maturation of cytoplasm. So maturation of the nucleus of precursor cells in bone marrow is delayed relative to maturation of cytoplasm. So causes are vitamin B12 deficiency, folate deficiency, or medications like hydroxyurea, phenytoin, methotrexate, and sulfa drugs. So findings, we see RBC macrocytosis, so by definition. And then we also see hypersegmented neutrophils and glossitis. Okay, so next is folate deficiency. Here, causes are malnutrition, like chronic alcohol overuse, malabsorption, drugs like methotrexate, trimethoprim, phenytoin. There's increased requirement, example, hemolytic anemia and pregnancy. So either there is malnutrition or there's increased requirement. Malnutrition secondary to chronic alcohol use, malabsorption, or drugs like methotrexate, trimethoprim, and phenytoin, or increased requirement as in the case of hemolytic anemia and pregnancy. What are the findings? There's increased homocysteine. So this is, we've done it before. So increased homocysteine, normal MMA, no neurologic symptoms. Versus B12, here we have increased homocysteine, increased MMA, and neurologic symptoms. So well had 2 numbers, so both is high. And folate deficiency has increased homocysteine only. Okay, anyway, so folate deficiency causes of malnutrition, chronic alcohol overuse, malabsorption, and drugs. What are the drugs? Methotrexate, trimethoprim, and phenytoin, or increased requirement as in the case of hemolytic anemia and pregnancy. So in folate, we only have increased homocysteine, normal methylmalonic, and no neurologic symptoms. Versus B12. So what is B12? Is cobalamin deficiency. What are the causes? Either there is pernicious anemia, malabsorption, like Crohn's disease, or pancreatic insufficiency, gastrectomy, insufficient intake like veganism, or Diphyllobothrum latum, fish tapeworm. So here we see increased homocysteine and increased MMA. Plus, we also see neurologic symptoms. These are reversible dementia, subacute combined degeneration due to involvement of B12. So yeah, why do we see subacute combined degeneration? The reason is it's due to B12, involvement of B12 in fatty acid pathways and myelin synthesis. So yeah, SCD, so spinocerebellar tract, lateral corticospinal tract, and D for dorsal column. It's a mnemonic, I think comes up in neuro. So subacute combined degeneration involves spinocerebellar tract, corticospinal tract, lateral corticospinal, and dorsal column dysfunction. Folate supplementation in B12 deficiency can correct the anemia, but worsens the neurologic symptoms. So this is questions. Folate supplementation, if we give it in B12, it will correct the anemia, but will actually worsen the neurologic symptoms. Historically diagnosed with the Schilling's test, which was a test that determines if the cause is dietary insufficiency versus malabsorption. So what was this Schilling's test used for? It's the test that determines if the cause is dietary versus malabsorption. So next we have, so then it says anemia secondary to insufficient intake may take several years to develop due to liver's ability to store B12 versus folate deficiency, which takes weeks to months. Yeah, this comes up. So anemia secondary to insufficient intake may take several years to develop because the liver is having a storage bank. Liver's ability to store B12 versus folate comes up faster. Folate deficiency takes weeks to months to show up.
Yeah,
Okay.
3 to 4 weeks for folate and 3 to 4 months for folate and 3 to 4 years for vitamin B12. Right?
3 to 4 months for
Folate
and 3 to 4
and
years
for B12. Right. And also in vegan diet, along with B12,
yeah,
we have iron, calcium, B12, and vitamin D deficiency, right?
And zinc.
Yeah, can you repeat, Nilo? How many?
We give zinc too, right?
Yeah, zinc too, but mostly vitamin B12 and B2 also or not?
Yeah, we give B2, B12, vitamin D, calcium, and B2, as you said. And also
Calcium,
B2
iron.
riboflavin is present in foliage. So we don't need to give folate because it's present in green veggies, right? So I think that was the catch in that question, right? It was a UL question. Let me pull it up.
Actually, it's in the side of in a FA, vegan in biochem nutrition.
Yeah, we saw it, right? Somewhere veganism. Maybe if we'll pull it up, veganism. Yeah. So for vegan vegetarian diet, we have to give B12, iron, B12. I'm sorry, yeah, you're right. 2 and 12, iron and vitamin D, although this is commonly deficient in many diets. Okay, yeah. And the catch in that question was we don't need to give folate in the vegetarian diets. Yeah, okay, nice.
and also zinc, right? Do you remember that?
Yeah. I think zinc also. Do I have set this chart?
I guess that was the U word. Zinc.
Someone shared a mnemonic for that. Yeah, zinc, iron, calcium, B12, and vitamin D deficient in vegan diet.
Nice.
So now B2 is also right.
B2 also, yeah. B2 is riboflavin, right? Yeah. It's riboflavin, yes. Okay, nice. So iron, calcium, and vitamin D, B2, B12. So B2, B12, iron, vitamin D, and zinc. Zinc covers the zinc, iron, and calcium. Okay. So one more time, zinc, B2, B12. And vitamin D also. Okay, cool. Thank you. So we are on 426. Okay. This app updated should show up in a sec.
So why do you have to give zinc? I agree with iron, calcium, and vitamin D. I don't know why zinc. But anyway.
Yeah, I don't know the reason, but
Doesn't make any. Zinc is mainly for the skin, the dryness and.
Oh, zinc fingers is all
Yeah,
steroid.
the dermatitis, alopecia, and shit, right?
Yeah. Why is this to link to 12? I don't know. Anyway, if the question comes, I should know the answer.
So vegan diet is causing B12. I think that table I'm looking for. Let's see. This one. Yeah, we do give possibly zinc. Yeah, if yeah, here we go. Here's the answer. If it's children, they have rapid growth, requires higher zinc and iron, and young women because they need higher iron. But yeah, rapidly growing population, we need to supplement with zinc if they are vegan as well. So yeah, this is the one.
Okay.
Oops.
It has to stick. It has to sink in. So we have to ask questions to sink in, so that it doesn't go away like volatile.
Yes.
Do you remember in vitamin E deficiency, we have also cerebral, spinal, and dorsal? What was that? Do you remember? We have something similar to in vitamin B12 and vitamin E, both we have. In B12, we have a spinocerebral, lateral corticospinal, and dorsal column dysfunction. But in vitamin E, we have a spinocerebral and dorsal column, right? Do you remember that, Hannah?
I think spinocerebellar and dorsal columns. I think we don't have lateral corticospinal tract here.
Yes, exactly. That's what I said. Yeah.
Wait, sorry, can you repeat? What are we discussing?
Yeah, next page, Saira. Vitamin E. So here we have hemolytic anemia, acanthocytosis, muscle weakness, demyelination of posterior columns, which are dorsal columns, and spinocerebellar tract. So decreased proprioception, vibration, and spinocerebellar. So it closely mimics.
The C part is not involved here, right?
Yes.
Okay, nice. Thank you.
SD, you can say SD.
SD here. Okay. Vitamin E is SD. Okay.
Yeah, they have written here neurological presentation may appear similar to B12 deficiency, but without megaloblastic anemia, hypersegmented neutrophils, or increased serum methylmalonic acid levels.
So if corticospinal is not involved, what does it mean?
Means no weaknesses on
Pain and temperature.
Focal neurological deficits. No weakness, motor symptoms, corticospinal tracts.
Oh yeah, sorry, corticospinal tract.
No, right?
Yeah, no motor symptoms. Okay, let me. Okay, so SCD is your B12 deficiency, right?
Yes.
SCD, we have three spinocerebellar tracts. So we ataxia is there, corticospinal tract, so movement problem is there, and dorsal columns are gone. So decreased vibration, proprioception, fine touch, but reflexes are intact in this case.
Yes.
Right? In vitamin E deficiency, we have spinocerebellar and dorsal columns involvement. So demyelination of the posterior columns leads to decreased proprioception and vibration sensation and ataxia problem.
Agreed.
Done with two? Yeah, and it closely mimics Frederick ataxia. So Frederick ataxia, same problem.
Correct. S and D, correct.
S and D.
Reflexes will be okay in all of these, right?
Yeah. In Frederick, Yeah,
Mhm.
and you are talking about this tabes dorsalis, which is neurosyphilis, tertiary syphilis, right? There we have a problem with the dorsal columns and dorsal root ganglion. So
Hmm.
reflexes will be decreased in that condition.
Okay, so reflected only in tabes dorsalis. And Frederick,
Saira?
Because the difference is in dorsalis, the addition, other than the columns, roots are also involved, and these roots
Yes.
are responsible for the reflexes.
Can you write tabes dorsalis and it will open the picture of neuro,
Yeah.
where all these pictures are formed. SCD pictures and tabes dorsalis. Yeah, this one. Yeah, if you look SCD picture, so dorsal columns, spine, corticospinal tracts, they have mentioned, but they didn't show the spinocerebellar. Okay, and tabes dorsalis, both are gone. So
This is the
absent blueprint and reflexes. Yeah.
oh yes,
yes.
yes.
Ataxia is on this page here.
Frederick ataxia is SCD or SC?
SCD, I think. So
Yeah.
CS, spinocerebellar, corticospinal, and dorsal column, and the roots, which is why there's lots of DTR. Does that make sense? This is what you were asking actually.
Yeah.
So other than SCD, DRG also, SCD plus DRG for Fredericks. We should make a note of that.
Oh, yeah.
Okay. So in Fredericks, everything is gone, right?
Yes.
SCD plus reflexes. Okay.
She's right. Neelu, you're right. Peripheral nerves also get affected. So there are reflex problems here. Nice.
Uh-huh.
Good memory. MashaAllah.
Thank you.
So yeah, so SCD and no SD plus DRG. So the difference between vitamin E and Fredericks is the corticospinal is also included in Fredericks. Oh, nice. This was a good summary. Sorry, go ahead. You were saying something?
I said in all of them, DTR is low except for vitamin B12.
Wait, what? See again? Reflexes are low in all.
Yeah. In vitamin E, Frederick ataxia, and tabes dorsalis, all of them, DTR is low, reflexes are low, except for normal reflexes in vitamin B12 deficiency, right? That was the conclusion.
Yes. And B12 and folate reflexes are normal. Is it showing up my notes? Yeah. So vitamin E, Friedreich's ataxia, and tabes dorsalis involve the dorsal root ganglion. So they do affect reflexes, causing hyporeflexia. In B12 and folate, dorsal root ganglions are not involved, so normal reflexes. That's the conclusion. Yes, correct?
Yes, thank you.
Saira, why did you just cross the C and corrected S and D? What does it mean?
Corticospinal is not involved in vitamin E. The C is for corticospinal.
Okay. Thank
So
you.
comparing with SCD and the other ones, the B12, which we're doing, yeah.
Thank you.
No problem. Anyone has a page
So
number?
decreased reflexes in vitamin E and Frederick ataxia, but
And
normal in B12.
yes.
Yeah, tabes dorsalis. Yeah.
Normal in B12 and folate.
Yeah. In folate, we don't have any neurological problems, right?
Yeah, folate is no neurological, yeah. You're right.
Finally, one less thing to worry about.
Thank you.
So yeah, like Neelu said, the only thing with normal reflexes is B12. All the other three which we're discussing, vitamin E, Friedreich's, and tabes, are all hyporeflexia. All right, so that was a good summary. Thank you. So moving on. So yeah, we were in the topic of neurologic symptoms, present versus absent. So folate has no neurologic symptoms. B12 has neurologic symptoms, the SCD, contrast with vitamin E, which doesn't have the corticospinal problem, but it does have the dorsal root ganglion. All right, so moving on, next cause of megaloblastic anemia is orotic aciduria. This we saw in biochem. So there's inability to convert orotic acid to UMP. So this de novo pyrimidine synthesis pathway because of a defect in UMP synthase. So UMP synthase is the main defect. There is autosomal, this is autosomal recessive as most enzymes, presence in children as failure to thrive, developmental delay, and megaloblastic anemia, which is the key clue is it's refractory to both refractory to folate and B12. No hyperammonemia. So this is another clinical correlation we saw when we did biochem. No hyperammonemia and orotic aciduria versus ornithine OTC deficiency. There is increased orotic acid with hyperammonemia. So yeah, key thing to remember, orotic aciduria, no hyperammonemia. And yeah, present with failure to thrive, and developmental delay. So there is orotic acid in urine, as the name suggests. Treatment is with, this was the question, I think, uridine monophosphate or uridine triacetate to bypass the mutated enzyme. So one more time, this is orotic aciduria is also a cause of megaloblastic anemia with MCV more than 100. There is an inability to convert orotic acid to UMP via the de novo pyrimidine synthesis pathway. Why? Because of a defect in UMP synthase enzyme, enzyme deficiency, autosomal recessive, presence in child as failure to thrive, developmental delay, and megaloblastic anemia, which is refractory to folate and B12, because it's the third cause. There is no hyperammonemia versus ornithine transcarbamylase deficiency, increased orotic acid with hyperammonemia. There's orotic acid in the urine. Treatment is UMP or uridine triacetate to bypass mutated enzyme. All right, so next we have non-megaloblastic anemia. So what is this? By definition, this is macrocytic anemia in which DNA synthesis is normal. Causes are chronic alcohol use, alcohol overuse, and liver synthesis. So the main problem is DNA synthesis is, macrocytic anemia with normal DNA synthesis. So causes, chronic alcohol use, liver disease. Here we see RBC macrocytosis without hypersegmented neutrophils. Versus these, we see both RBC macrocytosis and hypersegmented in megaloblastic. So this is for megaloblastic versus non-megaloblastic. We don't see the we don't see hypersegmentation. So then Diamond-Blackfan anemia is the cause of non-megaloblastic anemia. Here what's happening, this is a congenital form of pure red cell aplasia versus Fanconi's anemia, which causes pancytopenia. So here, what is the problem? Here it is pure red cell aplasia, congenital form, rapid onset anemia within first year of life due to intrinsic defect in erythroid progenitor cells. So yeah, this Diamond-Blackfan anemia is a congenital form of pure red cell aplasia versus Fanconi's anemia, which causes pancytopenia. Rapid onset anemia within the first year of life due to intrinsic defect in erythroid progenitor cells. So there's increased HbF, but decreased total hemoglobin. Increased fetal hemoglobin, but decreased total hemoglobin. Other presentations are short stature, craniofacial abnormalities, and upper extremity malformations like triphalangeal thumbs. What's going on here? A congenital form of pure red cell aplasia, contrast with Fanconi's anemia. Here, Fanconi's anemia causes pancytopenia. So all levels are dropped versus here it's just pure red cell aplasia. Here there is rapid onset anemia within the first year of life due to intrinsic defect in erythroid progenitor cells. There is increased fetal hemoglobin, but decreased total hemoglobin is less. Presentation, short stature, craniofacial abnormalities, and upper extremity malformations, triphalangeal thumbs in up to 50% of cases. Another link, normal, I don't know if you saw it yet, but normal orientation of thumbs is, what is the gene responsible for it? Hrithik Roshan, something is said.
Hox genes?
Hox genes.
Yes, nice. Hox genes. Okay. So next we have
Saira, another correlation, Fanconi anemia. What's the defect? DNA repair defect, right? What kind of DNA repair defect?
Non-homologous, right?
Yeah, non-homologous and joining defect. Good.
Non-homologous. Yeah. We saw it in right? Yeah.
Homologous, we have ataxia telangiectasia. Non-homologous, we have BRCA1, BRCA2, and this Fanconi anemia.
Yeah, nice. Biochem recall, nice. So homologous recombination defect is in Fanconi's anemia. Yep. DNA repair is absent, yes, which makes sense because this also is DNA repair. No, this is DNA synthesis is normal. Here it's a DNA repair problem. What's the exact problem? Which is homologous recombination is repaired. Okay, nice.
Hey, it's non-homologous recombination, I thought, right?
Yeah,
Homologous.
Yeah. I think you're writing it down reverse, Saira.
Homologous for Fanconi's, right?
No. Homologous for
Let me check.
ataxia telangiectasia, non-homologous and joining.
Oh no.
No. We are
The
doing
other
wrong.
way.
Yeah, you are right, Saira. Non-homologous and joining for ataxia telangiectasia, homologous and joining for DNA repair defect. Yeah, sorry. Yeah.
No
Okay.
worries. No worries. It's okay. Non-homologous is ataxia. Homologous is BRCA1, BRCA2, and Fanconi's anemia. This one.
One question, what was Fanconi something related to RTA?
It's
Right.
Fanconi syndrome, not Fanconi anemia. It's Fanconi syndrome.
Correct. Yeah. She's just reconnecting the words. So Fanconi's anemia, we went over.
Type 2.
Fanconi
So
syndrome.
it's type 2. Okay, type 2.
Type 2. Nice. Thank you. So yeah, we recall Fanconi's anemia. What's the problem? Fanconi syndrome. What's the problem? RTA type 2. And now we're talking about, we're contrasting it with diamond black fan. All right, nice.
Okay, again, non-homologous is ataxia. Okay.
Correct. Non-homologous is ataxia. Homologous is BRCA and this one, Fanconi's anemia. All right, we good? Any other pointers, mnemonics, add-ons? All right, so next we have normocytic normochromic anemias. All right, so we're done with this page. Next we have normocytic normochromic anemias. Normocytic normochromic anemias are defined as non-hemolytic and hemolytic. So yeah, from a big picture, we're normocytic normochromic anemias. So it's either non-hemolytic or hemolytic. The hemolytic anemias are further classified according to the cause of the hemolysis. It could be either intrinsic versus extrinsic to the RBCs, and by the location of hemolysis, intravascular versus extravascular. Yeah, we saw this at some point in biochem, I think. So hemolysis can lead to increase in, so yeah, these are key features. Hemolysis can lead to increase in LDH, reticulocytes, unconjugated bilirubin, pigmented gallstones, and urobilinogen in urine. So it makes sense. LDH is normally stored inside the RBCs. If they're destroyed, it leaks out. Reticulocytes are high because these are the precursors. Unconjugated bilirubin is high because the body is not able to, there's too much going on, so it's overwhelmed, not able to conjugate. So unconjugated goes high. Pigmented gallstones make sense because this unconjugated is precipitating into pigment stones. We saw it yesterday. And this urobilinogen is coming to the urine. Yes. Right, so let's see the difference between intravascular hemolysis and extravascular hemolysis. So intra within the blood vessels versus extra in the other lymphoid tissues, I believe. What did we call it? Reticuloendothelial system. So yeah, intravascular hemolysis, the findings are decreased haptoglobulin, increased schistocytes on blood smear. That's characteristic hemoglobinuria, hemosideruria, and urobilinogen in urine. Notable causes are mechanical hemolysis, like a prosthetic valve, paroxysmal nocturnal hemoglobinuria, we said we got gene defect, causing breakdown or destruction of RBCs. Microangiopathic hemolytic anemias or MAHAs. So these are all intravascular hemolysis causes. Extravascular hemolysis, the mechanism is the macrophages in spleen clear the RBCs. So findings are splenomegaly, spherocytes in peripheral smear, which is most commonly due to hereditary spherocytosis, and IHA, autoimmune hemolytic anemia. The difference is key difference, no hemoglobinuria or hemosideриnuria and can present with urobilinogen in urine. So yeah. So in intravascular, 3 things come out in the urine: hemoglobin, hemosiderin, and urobilinogen. This is page number 427. Versus in extravascular, only one thing comes out, which is urobilinogen can potentially be in the urine. And the image, what are we seeing? Extravascular hemolysis. Here there's RBC cell, the splenic macrophages are destroying it. So it leads to unconjugated bilirubin, which is conjugated in the liver. It's going to the gut. And you convert it to urobilinogen, which is excreted in feces as sterco. Some of it undergoes intrahepatic. We saw this all yesterday. Goes to the liver and recycled. Then some of it goes to the kidney and excreted in the urine as urobilinogen. So that is extravascular hemolysis. Now coming to intravascular, there's destruction going on in the blood vessel. So intravascular, inside the vessel. So we're seeing a blood vessel, RBC is getting destroyed, releases the hemoglobin. So hemoglobin is circulated to kidneys if haptoglobulin capacity is exceeded. So then it's now leaking out in the urine. So hemoglobinuria. So then the other pathway is hemoglobin. There it breaks down into dimers. These dimers bind the haptoglobulin. If haptoglobulin capacity is exceeded, it's going to pour into the kidney and come out in the urine. So yeah, hemoglobin, hemosiderin, and urobilinogen is increased in intravascular versus extravascular. We only have extra urobilinogen coming into the urine.
Okay, so 3 differences. Sorry, main differences between these two. Can you highlight?
Between extra and intra?
Yeah, other than these hemoglobinuria, hemosideриnuria, and urobilinogen. Urobilinogen actually both in both conditions, right?
So the other difference is intravascular, there is all the haptoglobulin gets occupied. So there's decreased haptoglobulin levels and the RBCs are being destroyed. So there will be schistocytes on the blood smear. So anything mechanically, let's say they have to pass through a valve, they will get destroyed. PNH because of the PIGA gene or microangiopathic hemolytic anemia. So there's destruction over here. Here because in extravascular, because the spleen is clearing all this damaged RBCs, spleen will be enlarged. So splenomegaly, spirocytes will be seen over here. If it is the case of hereditary spherocytosis or IHA.
Why spirocytes?
Because one reason is hereditary spherocytosis, right? The actin spectrin anchorin defect, so they are spherical. In autoimmune, why spherocytes? Autoimmune hemolytic.
Okay. Maybe because okay, got it. So it's bind with the RBCs, right? So antibodies bound to the RBCs. So they make it more susceptible for the splenic macrophages.
Yeah, the platelets mediated death or something?
Sorry?
Platelet mediated death, PF4, remember? That's how the autoimmune hemolytic anemia happens? I'm not sure. Okay.
No,
Actually,
but what you're saying,
antibodies,
because there's autoimmune antibodies, yes, but that's increasing spherocyte production.
yeah, because they go to the when they pass through the splenic spleen, so the splenic macrophages recognize them as abnormal, so just clear them out. Right? In spherocytosis, it's a membrane problem. Right? So they are abnormal, so splenic macrophages clear them. And in autoimmune hemolytic anemia, because they are bound with the autoantibodies, right?
Correct. So that's cleared by the spleen. No, I understood that part. I'm asking spherocytosis in IHA, why? Okay, something to do with the antibodies on the structure makes it spherical, I guess. Not sure.
Autoimmune hemolytic anemia, yeah.
Can you talk about this one in that picture, how this hemoglobin dimers, they're binding to haptoglobin? This part is a little not clear for me, yeah.
So basically hemoglobin, when it breaks down, it's going to like 2-alpha, 2B, 4, it's tetrameric, right? So they're just splitting into the dimers, alpha chains, beta chains, or whatever it is, depending on the type of hemoglobin. So these by structural reasons. I don't know exactly, but haptoglobin is a carrier molecule again. So haptoglobin is just what do you call, like sex hormone binding globulin. They are like transporters or carriers. So this haptoglobin will bind to, it's a scavenger of sorts. So it's looking for all the free hemoglobin and binding to it. So when these dimers are there, haptoglobin is binding to it. So all the haptoglobin is busy. So there's no free haptoglobin. So if I do a blood test and measure haptoglobin levels, they're going to be low.
Yeah, that got it. And how is this tetramer and the kidney related, circulated to kidneys if haptoglobin capacity exceeded? Okay,
Yeah, so
there's
now
some more
all
flow.
all the available haptoglobin is blocked or booked with this hemoglobin. So there's no more haptoglobin to scavenge and keep them bound.
Right.
So these naughty ones, where are they going now? They overflow into the go into the
Urine.
kidney and excrete in the urine. So
Yeah, great. Thanks for the rejob. Yeah.
Thank you. All right. So yeah, that's the key difference. So we saw hemoglobin, hemosiderin, and urobilinogen seen high in the urine in intravascular versus extravascular. We only see elevated urobilinogen in the blood. Other key differences: intravascular has decreased haptoglobin, increased schistocytes, because this is happening in the vessel, which we just said. Versus in extravascular, we see splenomegaly and spherocytes. So yeah, now we finished all this. Now going to normocytic, but non-hemolytic, I guess. Let me see. So yeah, normocytic are classified as non-hemolytic and hemolytic. Yes, non-hemolytic and hemolytic. Hemolytic anemias are further classified into intrinsic and extrinsic to the RBCs, and by the location of hemolysis further into intravascular and extravascular. So we saw the difference between intravascular and extravascular. Okay. So now we're going into non-hemolytic normocytic. So this one. So first we have iron anemia of chronic disease. So what comes under this category is iron deficiency, which we covered, anemia of chronic disease, aplastic anemia, CKD, and acute blood loss. Okay, let's see. So anemia of chronic disease, what is this? Inflammation, example, increased IL-6, which was the K in the acute phase reactant, right? Hot T-bone stick. Yeah, I think so. So increased IL-6, and that leads to increased hepcidin released by the liver. It binds ferroportin on the intestinal mucosal cells and macrophages, thus inhibiting, focus. Okay, so anemia of chronic disease, inflammation is increased IL-6, leading to increased hepcidin, which is released by the liver, which hepcidin binds ferroportin on intestinal mucosal cells and macrophages, thus inhibiting iron transport. This we saw yesterday in the context of hemochromatosis. So net effect is decreased release of iron from macrophages and decreased iron absorption from the gut. So decreased release of iron from macrophages and decreased absorption as well. So associated with conditions such as chronic infections, neoplastic disorders, chronic kidney disease, and autoimmune disease. So as we saw earlier, it is an evolutionary system. It's trying to prevent the infection or the cancer or the kidney disease or autoimmune diseases from taking away the resources of the body. So what are the findings? We have decreased iron, decreased TIBC, and increased ferritin. So ferritin is a storage form, so it makes sense that that's high. Normocytic, but they can become microcytic. So what's the treatment? Address the underlying cause of inflammation, judicious use of blood transfusion, consider erythropoiesis-stimulating agents like EPO, example in chronic kidney disease. All right, that makes sense. So next we have aplastic anemia. Here there is a failure.
That's your question's answers. I'm sorry. In CKD, because of we don't have erythropoietin now, so that leads to low retic count.
Yeah, thank you. Yeah, that makes sense now. I was asking earlier, right? Yeah. CKD. So repeat again, sorry. Low retic count because?
Because we don't have erythropoietin, so that is why we have low retic count.
Yeah, correct. Yeah, I was asking when we did the charts. Yeah. So there's no erythropoietin. So even if the body tries, it cannot synthesize more RBCs. Yes, thank you so much. So there's my answer. Yep. So consider giving EPO in the case of chronic kidney disease. Okay, thank you. So next we have aplastic anemia.
So how do you, excuse me one second. So like, how do you, there are questions in this, the way they put it is hepcidin and all those things. So anemia of chronic disease in general, how do you want to relate to the, in a normal disease state?
I didn't follow your question. In the case of
I'm not
infection,
putting
you
it
mean?
right. It's okay. Go ahead. I think
if the body is undergoing an infection, again,
yes.
it wants to conserve its resources because it doesn't want the viral or the bacterial stuff to use the body's resources. So it's protecting it and it's hiding everything away. So
Into
it's putting
ferritin.
everything in storage. So increase ferritin. How does it do that? By hepcidin.
Hepcidin is increased. Yeah.
So hepcidin is like the, I think Hamna used to say, it's like the traffic policeman. It's like guiding, okay, where should iron go? Should it get absorbed or should it not get absorbed, right?
So hepcidin is the one that inhibits basically ferroportin. So in hemochromatosis, we don't have hepcidin, right?
Yes.
So
correct.
it leads to more and more, so unregulated ferroportin. So it leads to more and more iron absorption from in the gut, right? And as well as these ferroportin are present on the macrophages.
Yes.
Yeah, here we go. So yeah, so in this hemochromatosis, we have HFE mutation. So we have decreased hepcidin release. So it no longer inhibits this ferroportin. So it leads to more and more iron absorption from the gut. So that leads to iron overload state, and these iron will go and accumulate in the hepatocytes so hemocytine accumulation is there.
Correct.
Right?
On the contrary, correct, exactly, absolutely. So on the
And
contrary,
these,
go ahead.
Sorry, go ahead, please. And I just said that saying that these ferroportin are also present on the macrophages as well.
Correct. Yeah, this one, this image, yes.
Hepcidin is down there. That's what I'm seeing in the picture.
So that's what I was going to say, that if on the contrary, if there's an infectious process going on, this hepcidin is on full alert. It's like, okay, I'm not, and this is going to be high. So it's going to inhibit the absorption of iron and it's going to kind of allow storage. Let me pull up the other image that will make more sense.
I'll tell you, NBME has so many questions in this concept. So I really want to make it solid.
Yeah.
Yeah.
So hepcidin, as you see here, normal function is to inhibit ferroportin so that iron can be free and do whatever it needs to do. If hepcidin is high, it's going to inhibit the release of ferritin into the blood, which is where we're seeing this. One side is enterocyte, the other side is in the macrophage. So if hepcidin levels are high, it's going to prevent the ferritin or the iron in the ferritin to go outside. So that's why it is elevated, right? So it's going to conserve basically. Increased hepcidin is conserving the iron inside the macrophage.
Okay.
Okay.
Thank you so much. Yeah.
You're welcome. So yeah, that was in context to infections. Okay. All right. So yeah, interleukin-6 is increasing the hepcidin. That's because it's an acute phase reactant, it's stimulating increased hepcidin levels. All right, moving on. Next, we have aplastic anemia. Here, there is failure or destruction of the hematopoietic stem cells. Causes are reducing volume from inside diaphysis. Reducing volume from inside diaphysis, standing for radiation, viral agents, Fanconi's anemia, idiopathic causes, and drugs. So radiation, viral agents, reducing volume from inside the diaphysis. So radiation makes sense. Viral agents, EBV, HIV, and hepatitis viruses. Fanconi's anemia, as we just discussed, this is autosomal recessive DNA repair defect causing bone marrow failure. Normocytosis or macrocytosis on CBC. Common associated findings include short stature, Café au lait spots, thumb or radial defects, and predisposition to malignancy. Yep. Unilateral cafe au lait spots were seen in memory jog.
Neurofibromatosis, or what is that?
Unilateral. Unilateral. Yes, of course.
Yeah.
NF has cafe au lait spots. That's right. But
And one
unilateral
more.
was specific for.
Yes, specific for one more. What is that? Neuro, the same.
McCune Albright.
McCune, yes.
All right. So yeah. So here also Fanconi's anemia we're also seeing. So 3 places, cafe au lait. NF, which we all remember, Fanconi's anemia second, third is McCune Albright. McCune Albright specifically unilateral. All right. So common findings include short stature, cafe au lait spots, thumb or radial defects, and predisposition to malignancy. Next, we have idiopathic causes. It could be immune-mediated or primary stem cell defect, and it may follow acute hepatitis. What are the drugs that cause aplastic anemia? Benzene, chloramphenicol, alkylating agents, and antimetabolites. All right, so findings we see here in decreased reticulocyte count, which makes sense because the stem cells itself are not working, so they cannot produce precursors. Increased erythropoietin because the kidney is desperately trying to make up for the decreased cells and it's trying to stimulate, but nothing is working out. So yeah, aplastic anemia, decreased retic count, increased erythropoietin. There is pancytopenia, so all cell levels are down. Makes sense because the stem cells are not working. So it's characterized by anemia, leukopenia, and thrombocytopenia versus aplastic crisis, which causes anemia only. We saw this recently. Aplastic crisis, which causes anemia only. Okay. Normal cell morphology, but hypocellular bone marrow with fatty infiltration. So whenever we say fat, it's usually they don't take up stain, so they are clear cells. So yeah, normal cell morphology with hypocellular bone marrow with fatty infiltration. Symptoms: fatigue, malaise, pallor, purpura, mucosal bleeding, petechian infection. So yeah, all cell lines are down, so everything is happening. Malaise, pallor, purpura, mucosal bleeding, petechian infections. Treatment: withdrawal of offending agent in the case of the drugs, immunosuppressive regimens like anti-thymocyte globulin and cyclosporin, bone marrow allograft, RBC or platelet transfusion, bone marrow stimulation with GM-CSF. As we said, this was an important NBME question. Granulocyte, monocyte, colony stimulating factor, or GCSF was the question about. But okay. So that's done with anemia of chronic disease and aplastic anemia. Next,
And
we have
salgramostim, right? GM-CSF.
Sorry?
The drug is salgramostim, right? GM-CSF.
Sargramostim, granulocyte monocyte stimulating factor. Yeah, sargramostim. Yes. Yes, that's the synthetic
Agents,
one.
alkylating agents, which are anti-metabolites, they inhibit, they do cross-linking, right? If I'm not wrong.
Anti-metabolites.
Yes, yes, yes.
Remember. See again, please.
Cisplatin and all those things. Yeah, cross-linkers.
Alkylating agents are cross-linkers. Anti-metabolites, I think they work on the S phase, if I'm not wrong.
Yeah,
Methotrexate.
Yeah, you're right. Anti-metabolite should be different. Yes, great said.
Okay, thank you.
Yeah,
Sorry.
anti-metabolites are, yes,
Later today.
cladribine,
Yeah, if you
and all those
today,
things.
I think we'll be seeing in platinum compounds cross-link. Platinum cross-link. Think platinum ring, platinum cross-link, or platinum chain. It has
Anyone
links,
has
right?
a mnemonics for that, please, drugs, please kindly share today.
Yeah.
Those are very dangerous kind of things.
Yes. So platinum chain has links, so it's cross-linking inhibitor. Mechanism is cross-linked DNA. All right, yeah, hopefully we get to it. So we'll see farm later. Anyone has any mnemonics, please share. All right, so your treatment, GM-CSF, the name of the drug is sargramostim and filgrastim, I think, yes.
Sorry, one more thing. I'm sorry. Anti-thymocyte globulin, what is this?
This is anti-thymocyte globulin. Is an infusion of horse or rabbit-derived antibodies against human T cells and their precursors, which is used in the prevention and treatment of acute rejection. Yeah, I think that's why we saw it. Prevention of treatment of acute rejection in organ transplantation, and therapy of aplastic, which we're seeing now. Yeah. I think we searched this before at some point, but I've forgotten it.
Thank you so much.
Tell me something that is related to anti-thymocyte globulin.
Say again, sorry.
Immuno-related relation between anti-thymocyte and something in immunology.
Yeah, it rings a bell, but I don't know exactly. Immunology, we saw it somewhere.
I guess it's caused R2 reaction. I'm not sure, but it's related.
Yeah, this one, anti-IL-2 receptor antibodies are increasingly being used. No. So they are alternates, they're saying, but yeah, okay. Status in graft versus host disease. So I guess they're doing trials to use it in graft versus host disease, and that's probably where it came up. Okay, so what is anti-thymocyte globulin? This is an anti-thymocyte globulin, which is an infusion of horse or rabbit-derived antibodies. So we're taking antibodies against T cells. So antibodies from the horse or rabbit, so lab animals, I guess. So they're producing antibodies against human T cells and the precursors. So precursors of T cells are the thymocytes, which are used in the prevention and treatment of acute rejection. So because T cells are the ones that are going to come into play in the acute rejection, so we are preventing those cells. What are thymocytes? It's an immune cell present in the thymus. That's the one. That's where we saw it. Stem cells in the bone marrow. Before this selection and everything, when we saw it, came up there, I believe. Let me see thymocyte if it's present. Thymocyte. Nope. But anyway.
Thank you. Yeah, that's enough. Thank you so much. So these are basically, okay, got it.
Anti-T cell antibodies, synthetic production, synthesized in the lab.
Okay, thank you.
Okay, thank you. Sorry, I'm just catching up with chat. Carbamazepine is also a cause of aplastic. Okay, nice. Thank you. What is maturation time? I don't know at what point this was asked, but okay, cool. All right, so next, moving on to intrinsic hemolytic anemias. We'll try to finish this page and then before lunch. Okay, so intrinsic hemolytic anemias, we have hereditary spherocytosis. So now we're going to the intrinsic category of normocytic, non-hemolytic intrinsic category, which is hereditary spherocytosis, PNH, G6PD, pyruvate kinase, hemoglobinopathy, sickle cell, and HBC. I think we finished. All right. So intrinsic hemolytic anemia, what are these? Intrinsic meaning something to do with the RBC itself. So hereditary spherocytosis, PNH, G6PD, pyruvate kinase, and sickle cell anemia, as well as HBC. This is okay, it's coming up now. All right, so hereditary spherocytosis, this is an autosomal dominant condition. It's due to a defect in proteins interacting with RBC membrane, skeleton, and the plasma membrane. These are questions: ankyrin, band 3, protein 4.2, and spectrin. So what happens? We see small round RBCs with no central pallor. There's decreased surface area to dehydration ratio. Decreased surface area, no, sorry. Decreased surface area / dehydration. So they mean decreased surface area and dehydration. Increase MCHC. Mean corpuscular hemoglobin concentration is less because of decreased surface area. No, it's increased. Because the cells are small, the corpuscular hemoglobin concentration appears to be high. Okay. There's premature removal by spleen, so this leads to extravascular hemolysis. So findings: splenomegaly, pigmented gallstones, aplastic crisis. This is high yield. Parvovirus B19 infection. Labs, we're seeing decreased mean fluorescence of RBCs in eosine in EMA binding test. What is EMA binding test? Eosine 5-melamide binding test. Increased fragility, which is usually mentioned in question stem. Osmotic, increased fragility on osmotic fragility test. RBC hemolyze when exposed to hypotonic solution. Hypotonic. Yes, it makes sense. Okay, yeah. Normal to decrease MCV with abundance of RBCs. So normal to decrease mean corpuscular volume with abundance of RBCs. Treatment is splenectomy. Okay, so hereditary spherocytosis is done. Main defect, it's an autosomal dominant, anchorin band 3 protein 4.2 with spectrin defects. What do we see? Small round RBCs, no central pallor, decreased surface area and dehydration, increased MCHC, and extravascular hemolysis because of removal by spleen. So treatment is splenectomy. What do we see? Findings, splenomegaly, pigmented gallstones. That makes sense because lots of hemolysis going on. Aplastic crisis precipitated by parvovirus B19 infection. What are the labs? EMA binding test, decrease mean fluorescence, increased fragility and osmotic fragility test. Normal to decrease MC with abundance of RBCs. What did we see? Another fluorescence thing that was the G6PD, right? Okay, it's coming up later. Okay.
Sorry, it's RDW. RDW is also increased here in this condition. I have written it.
Okay, so RDW we saw in iron deficiency anemia and hereditary spherocytosis. Okay, thank you.
Yeah. So
428.
increased MCHC and increased RDW here.
Actually, I remember you were said normal or increased RDW. I think I vaguely remember, but yep. Okay, I will check that. So next we have PNH, which is paroxysmal nocturnal hemoglobinuria. Here there's hematopoietic stem cell mutation. Hematopoietic stem cell mutation, increased complement-mediated intravascular hemolysis, complement-mediated, so complement levels will probably drop. Okay, so it's complement-mediated intravascular, so within the blood vessel hemolysis, especially at night. It's an acquired PIGA gene mutation, can also lead to impaired GPI. So acquired PIGA mutation can lead to an impaired GPI anchor. So another anchor problem. So impaired GPI anchor synthesis for DAF, decay accelerating factor, also known as CD55, and MERL, which is the membrane inhibitor of reactive lysis, MERL, or also known as CD59, which normally these protect the RBC membrane from complement. So these factors are lost. Complement is now able to attack the RBCs. I think they had a good image on UWorld. Does anyone have it? Let me put it up. PNH.
Sarah, you said it's onco problem?
Sorry?
You said PNH is onco problem?
ANCA meaning ANCA?
Yeah.
No,
So,
no.
oh, okay. Sorry.
I don't know what I said.
No. She meant anchoring. This anchoring, the
Anchor, yeah.
spirocytes.
Okay.
When they lose
Anchor.
that, they cannot anchor. Yeah.
I said anchor, yeah. Sorry.
Okay. Thank you.
No worries. Paroxysmal nocturnal. Yeah, here we go. So, sorry. So normal RBCs have these GPI anchors, which are CD55 and CD59, which are also known as MERL and DAF. So they are anchored to the RBCs, which protects the complement, protects them from complement attack. So GPI anchors CD55 and CD59 to the RBC membrane. So these are the GPI. GPI anchors CD55 and CD59 to the RBC membrane, inhibiting complement deposition. So this PIGA gene destroys the GPI anchors. So what happens now? Complement components. So we're seeing complement is able to attack the RBC and they cause lysis and release of free hemoglobin. So absence of CD55 and CD59 protein allows terminal MACs to form. membrane attack complex is formed, and destruction of RBCs is occurring. So what is this GPI? Glycosyl phosphatidyl inositol. Iositol. Okay. Okay. So back to this. So yeah, now it makes sense, right? It's a hematopoietic stem cell mutation, increased complement-mediated intravascular hemolysis, especially at night, and acquired PIGA mutation causes impaired GPI anchor synthesis. What are the anchors for? For DAF, which is also known as CD55, and for MERL, which is also known as CD59, which protect the RBC membrane from complement destruction. So what do we see clinically? We see a triad of lots of triads. So triad of Coombs negative hemolytic anemia, mainly intravascular. Then we have pancytopenia and venous thrombosis. So three things: Coombs negative hemolytic anemia, so hemolytic anemia, pancytopenia, Coombs negative because there's no antibodies involved here. So Coombs negative hemolytic anemia. So this is mainly intravascular hemolysis. Next is pancytopenia. All cell lines are destroyed. Venous thrombosis. It's a hypercoagulable state. So that makes sense. And example, Budd-Chiari syndrome, which we saw yesterday. What happens to the JVD in or JV?
No,
I
no
answered.
JVD. Absence of JVD. I
Yes.
was also thinking the same thing.
Yes, great minds think alike. Yes. So Budd-Chiari is the only very rare situation where we have no JV distension. Okay, so pink or red urine in the morning associated with aplastic anemia and acute leukemias. So associated with anemia, aplastic anemia, as well as acute leukemias. Labs, CD55, CD59, RBCs on flow cytometry. Treatment, as we said, eculizumab targets the terminal complement protein C5. So C5, we are destroying the complement so that the RBCs cannot be attacked. All right, so next we have G6PD deficiency. This is a X-linked recessive defect. So because it's an enzyme, yeah, this is an exception to the rule. Most enzyme deficiencies are autosomal recessive, but G6PD is X-linked recessive. So there's a G6PD defect leading to decreased NADPH, reduced glutathione. We saw this in biochem. So yeah, decreased NADPH, reduced glutathione, increased RBC susceptibility to oxidative stress. What are the stress factors? Sulfa drugs, antimalarials, and fava beans. So what happens? It leads to hemolysis. It causes both extravascular and intravascular hemolysis. Presentation, we have back pain, hemoglobinuria in a few days after an oxidant stress. Labs, we see decreased G6PD activity, which may be falsely normal during acute hemolysis. Blood smear shows RBCs with Heinz bodies and bite cells. So we said these two are specific for G6PD. Stress makes me eat bites of fava beans with Heinz ketchup. So to remind us that stress-induced, bite cells, fava beans trigger it, and Heinz ketchup, Heinz bodies. Okay, Heinz bodies, we said the blue things, they contain iron, right?
Heinz bodies contain iron because they are oxidized, denatured and oxidized hemoglobin. So
Hemoglobin,
it's a
correct.
contains
Denatured
iron.
and precipitated hemoglobin, HB, HP. HB for hemoglobin, HP for Heinz bodies. And hemoglobin contains iron, so they are iron-containing cells.
What's the other name of white cells?
Degmacytes.
Yeah.
Dig into the cell, so
And
degmacytes.
Howell Jolly bodies are what?
Howell Jolly are Jolly, so they are single
Sickle
person.
cell. Sickle cell.
Yeah, jolly persons are single. Sorry.
Ah, okay. Singular jolly. Okay.
Something else you mentioned.
Yeah, these are nuclear remnants, right?
Yeah, that's the one with the nuclear remnants. Because Burp was the basophilic, nuclear remnants was the Jolly. Basophilic nuclear remnants. Okay. Okay. So next we have pyruvate kinase deficiency follows the rule. So autosomal recessive enzyme deficiency, pyruvate kinase defect leads to decreased ATP. decrease ATP, so there is rigid RBCs and extravascular hemolysis. Rigid RBCs because of decreased ATP. Okay. Extravascular hemolysis, there's increased levels of 2,3-BPG, which causes decreased hemoglobin. Yeah, this is high yield fact. We saw this in the context of hemoglobin F. So in pyruvate kinase, we have increases because of the defect, it increases levels of 2,3-BPG. So therefore, there is decreased hemoglobin affinity for oxygen. Whereas hemoglobin F intrinsically has increased 2,3-BPG. No, decreased affinity for 2,3-BPG, but binds strongly for oxygen. So this is the opposite, right? For HbF, we saw it in the first few pages today. This is page 428. Anyone?
Yeah, HbF, no affinity for 2,3-BPG, right?
Correct. Less binding of 2,3-BPG, so that it's able to attract or bind to oxygen more. So in pyruvate kinase is the opposite. It produces increased 2,3-BPG, so less binding to oxygen. So yeah, it's the opposite. So just correlating it like that. Okay. Sorry about that. Lost my page. Okay. So here pyruvate kinase deficiency increases levels of 2,3-BPG, thereby it is decreasing hemoglobin affinity for oxygen. So presentation, there's a hemolytic anemia in newborn and blood smear shows Burr cells. So yeah, we said Burr cell was specific for pyruvate kinase. Echinocytes, yeah. Echinocytes, which are even distribution of the Burr cells. Nice. So next we have sickle cell anemia. What here we have point mutation of the beta globin gene, single amino acid substitution, glutamic acid converted to valine. Valine is villainous, as we've seen before. It alters the hydrophobic region on the beta globin chain, causing aggregation of hemoglobin. So these words they put in the question, they say alters hydrophobic region on the beta globin chain, causing the aggregation of hemoglobin. Causes extra and intravascular hemolysis. The pathogenesis is low oxygen, high altitude, or acidosis will precipitate sickling. Deoxygenated hemoglobin S polymerizes, and this can cause a vaso-occlusive disease. Newborns are initially asymptomatic because of increased HbF and decreased HbS. Heterozygotes, sickle cell trait, have resistance to malaria because malaria targets RBCs. So this is comes up in questions. Sickle cells are crescent-shaped RBCs seen here, crew cut on skull X-ray due to marrow expansion from increased erythropoiesis, which is also seen in thalassemias. We saw this a little bit ago. So next, complications of sickle cell anemia, we have aplastic crisis, autosplenectomy, splenic infarct or sequestration crisis, painful vaso-occlusive crises, and sickling in the renal medulla. So what is aplastic crisis? Here it's the transient arrest of erythropoiesis due to parvovirus B19 infection. Then we have autosplenectomy, Howell-Jolly bodies, increased risk of infection by encapsulated organisms. So this comes up, microcorrelate, specifically Salmonella osteomyelitis. Then we have splenic infarct or sequestration crisis. Yeah, because it's vaso-occlusive, it's going to clog the spleen. Painful vaso-occlusive crisis, dactylitis, which is painful swelling of hands and feet, priapism occurring in the penis, acute chest syndrome, respiratory distress, and new pulmonary infiltration on chest X-ray, common cause of death, avascular necrosis, and stroke.
And
any hypercoagulable state can precipitate AVN. So here it's vaso-occlusive, it's going and blocking those main vessels. So because there's no blood supply, the bone starts getting necrosed. Sorry, were you saying something?
There is something in the skull in the Paget also, no? Is it a osteolytic or something? I mean, there is very specific picture of the skull. I'm not sure. I'm just asking. Like,
Yeah, I know what you mean. There's a specific finding. The increased hat size because of the bone. There's a word they use. Hold on, let me find it. Skull thickening. So here the skull thickening versus now we're seeing crew cut appearance. So there's little extramedullary erythropoiesis. So that's crew cut appearance on X-ray. This is skull thickening on X-ray.
Yeah, this is crew cut.
So yeah, crew cut appearance, thalassemia as well in this one. Which is a hair on end appearance.
this one, yeah, cotton. Yeah.
Cotton wool appearance. Yeah, you're right. Nice.
This
Cotton wool fluffy appearance because, as you said, some areas are lytic, some are sclerotic. So yeah, nice. Thank you. Cotton wool appearance for Pagets. Crew cut appearance for this one. Okay. Yep. So yeah. So crew cut appearance in skull X-ray due to marrow expansion from increased erythropoiesis. This we're seeing in sickle cell anemia and thalassemias because of increased erythropoiesis, and contrast with cotton wool appearance on skull X-ray because of Paget's disease. Nice, thank you. So yeah, fever and avascular necrosis and stroke. Sickling in the renal medulla decreases PO2. So that causes renal papillary necrosis. This is a renal correlate, and hematuria, leading to hematuria, which is also seen in sickle cell trait. Hemoglobin electrophoresis will show very low HbA, increased HbF, and very high sickled hemoglobin. Treatment, we treat with hydroxyurea, so which will increase the fetal hemoglobin, and hydration. HBC disease, here it is glutamic. So yeah, here it was glutamic acid to valine, single amino acid substitution. Here is glutamic acid to lysine mutation. So C4C in the beta globin. This is also both in beta globin. This causes extravascular hemolysis. Sickle cell contrast, extra and intra. This is only extra. So HBSC version, which is one of each mutant gene, which is milder than HBSS. Blood smear in homozygotes will show hemoglobin crystals inside the RBCs and target cells. So crystals, C4C, and target cells. Okay, it's time for break, or should we go on? We have extrinsic, and then
that's important. Two are the bad things most here, right? G6PD and sickle cell. And both have extravascular and intravascular hemolysis, right?
Correct. So we have to correlate G6PD and sickle cell are having both extravascular and intravascular hemolysis. Versus this was only intra. This is only extra. So extra, intra, extra and intra. Here is only extra. I need to make a list for this also. So these two are the main ones which have both extra as well as intravascular hemolysis, and this one is again only extravascular. Okay.
So all are extravascular hemolysis except this PNH, right? This is
PNH is intravascular, correct. Actually, we had that mentioned right here.
Complement mediated intravascular hemolysis, something like that.
Yeah, here. So PNH was the main thing. Actually, the other thing is the prosthetic valve also for intravascular and the MAHAs. So these are the three main causes. All the other heme stuff is pretty much extravascular hemolysis. Extra. So extra and intra overlapping ones is G6PD and sickle cell, which are the terrible ones, as you said. All right, so extrinsic hemolytic anemias, we have IHA. Okay, cool, thank you. So extrinsic hemolytic anemias, this we have IHA, drug-induced hemolytic anemia, DHA, IHA, DHA, MAHA, another MAHA, which is macroangiopathic and hemolytic anemia due to infection. Then we go to leukopenias. Okay. So autoimmune hemolytic anemia, this is a normocytic anemia that is usually idiopathic with Coombs positive. Makes sense. Antibodies are present. It's autoimmune. So Coombs positive. Two types, warm IHA and cold IHA. So warm, we've seen this before, I think in immunology. So warm IHA, chronic anemia in which primarily IgG causes extravascular hemolysis, which is seen in SLE and CLL with certain drugs, like what are the drugs? Beta-lactams and alpha-methyl-dopa. Warm weather is good to remind us that these are IgG type antibodies. So seen in SLE and CLL, and then cold IHA, these are acute. So this is chronic IgG, warm IHA. Cold IHA is acute anemia in which the primary IgM plus the complement cause RBC agglutination and extravascular hemolysis upon exposure to cold. So there's painful blue fingers and toes. This is seen in CLL. So CLL is overlapping Mycoplasma pneumonia infections and mononucleosis. So cold is IgM type, IgM, M for mycoplasma, M for mononucleosis. All right, so that's warm and cold IHA. I think the other image which we had was good. So, okay, so what are the findings? Spherocytes and agglutinated RBCs on peripheral blood smear. So we're seeing this agglutination, warm IHA treatment. We give steroids, rituximab, and splenectomy if it is refractory. Steroids, rituximab, CD20 inhibitor, and splenectomy if refractory. For cold IHA, treatment is cold avoidance, and again rituximab for both. Okay. Next, we have drug-induced hemolytic anemia. This is most commonly due to antibody-mediated immune destruction of RBCs or oxidant injury via free radical damage, which may be exacerbated in G6PD deficiency. Yep. So most commonly due to antibody-mediated immune destruction of RBCs or oxidant injury via free radical damage, and it may be exacerbated in G6PD deficiency. Common causes include antibiotics, example penicillins and cephalosporins, as well as NSAIDs, immunotherapy, chemotherapy. So it's drug-induced. So main thing are antibiotics, which are penicillins, cephalosporins, NSAIDs. Any immunotherapy and chemotherapy can induce this problem. So spherocytes suggest immune hemolysis. Bite cells suggest oxidative hemolysis. So spherocytes suggest immune problem, immune hemolysis. Bite cells suggest oxidative hemolysis because this can be due to either immune destruction or oxidant. So this is helping us differentiate. Okay. And it can cause both extra as well as intravascular hemolysis.
Sorry, Saira, it was bite cells in the G6PD, right? So bite cells extravascular hemolysis. Sorry,
Yeah,
what are
bite
you saying?
cells was G6PD. Now also drug induced was also there. Let me pull it up. Ligma sites. Sorry, what's this page now? 429. So here we saw G6PD only, but we should add drug induced hemolytic anemia, DHA.
So drug-induced, we also have bite cells.
Yes.
And bite cells show oxidative stress, right?
Correct. Bite cells for oxidative hemolysis. So because they're saying drug-induced hemolytic most commonly caused due to two branches, antibody-mediated immune destruction, immune problem. So we'll see spherocytes, or oxidant injury via free radical damage, which will be exacerbated in G6PD. So it's kind of clubbed together. Oxidant stress, bite cells. Oxidant stress usually occurs in G6PD, but free radical due to either chemo or immunotherapy also makes sense. So bite cells in any oxidative stress to the RBCs, secondary to either G6PD or any drug. Okay, cool, makes sense. So common causes are antibiotics like penicillin, cephalosporins, NSAIDs, immunotherapy, and chemo. Then we have MAHA, which is microangiopathic hemolytic anemia. MIHA, microangiopathic hemolytic anemia. RBCs are damaged when passing through obstructed or narrowed vessels. Causes include intravascular hemolysis seen in DIC, TTP-HUS, SLE, and HELP, as well as hypertensive emergency. What is happening here? RBCs are damaged when passing through obstructive or narrowed vessels. So causes intravascular hemolysis. So that's MIHA. Schistocytes or helmet cells are seen on peripheral blood smear due to mechanical destruction of RBCs. Schistocytes are helmet cells which are seen on peripheral blood smear due to mechanical destruction. Schisto means to split of RBC, so it makes sense. Helmet cells. How did they look like? Forgotten. This one? Fragmented RBCs.
Yeah.
I think this is not a helmet cell. This is just a fragmented RBC. Helmet cell, good image on view world. 428. Okay, next we have MAHA, which is microangiopathic hemolytic anemia. Here it is prosthetic valves and aortic stenosis may cause hemolytic anemia, secondary to mechanical destruction. Schistocytes on peripheral smear here as well. So microangiopathic means small vessels, so narrowed vessels. Macroangiopathic, the vessels are okay, but it's either due to prosthetic valves or aortic stenosis. Okay, then we have hemolytic anemia due to infection. Here we have increased destruction of RBCs, secondary to malaria or babesia. How do we differentiate these two? Anyone? Ring forms are
some Maltese. Was there?
Maltese cross. Yes, nice. Maltese cross in babesia. Malaria is only the ring forms. Babesia has both Maltese and the ringed form.
Schaffner stippling is where? In which kind of malaria? Vivax or?
Falciparum, right? I don't remember.
Falciparum has gamete like banana-shaped gametocyte.
What was your question? What was your question?
Schaffner stippling, I guess, where we get it.
Schnuffner stippling. Helmet was falciparum, okay.
Yeah, Vivax and OVAD.
Yeah. Nice. I had forgotten this. Plus, we have trophozoite and Schnuffner stippling, which is small red granules. So this is another granules. Within RBC is Vivax and ovale. Headphone shape is falciparum and crescent-shaped gametocytes. This babesia was Maltese cross. Malaria was trophozoite ring. Yeah, so that covers all. Nice. Okay. Schnuffners for Vivax and ovale. Schnuffner for Vivax and ovale.
What are you saying last?
No, I'm just repeating. Schnuffners for Vivax and ovale. I'm just repeating.
Yeah.
Okay, so yep, so that's in malaria and babesia. Okay. Next is so one more time, MIHA is DIC, TTP, HUS, SLE, HELP, hypertensive emergency. Same thing as MIHA. Okay, so leukopenias, these are neutropenia, lymphopenia.
Sorry, before you go, can you just correlate with the causes of warm and cold? So cold is other than IgM, it's complement mediated, right?
Correct.
And both causes extravascular hemolysis?
Both cause extravascular, yes, because it's happening outside the blood vessel, either in the spleen, which is why treatment is removal of the spleen, right? So this is extravascular.
Okay, so this is extravascular, and cold is IgM and complement mediated, but warm is chronic anemia, only IgG mediated, no complement involvement here, right?
Yeah, no complement involved in warm. Yes, correct.
Okay, and G causes.
Sorry?
Sorry?
Where did we see this before in immuno? I'm just trying to pull up that image. No, I had it somewhere. Coombs, maybe, no.
Coombs positive, I think type 2 hypersensitivity, I think.
Yeah, type 2. sorry, go ahead. You were saying causes?
Yeah, no, just correlating CLL and SLE with warm, and beta-lactams and alpha-methyl dopa with warm, and cold we have infectious mononucleosis, mycoplasma pneumonia. CLL actually both, in both.
CLL was in both.
Thank you.
Thank you.
And your Ritu is on treatment for both of them.
Why Ritu? No.
Rituximab.
Rituximab, yeah. I'm bored of that mnemonic notes too many times. Yep. Rituximab CD20, yeah. With no home, non-Hodgkin's lymphoma, yeah. So this was the image I was saying.
Yes, this one is.
Yeah. So this gives a visual that this is extravascular and versus intravascular and cold. Actually, it's not matching with the first aid. It says both is
Both
extravascular.
extravascular.
We just said both is extravascular. Here, okay. I don't know what to follow. I guess this makes sense because it's intravascular, it's complement mediated. So yeah, I think we should stick to this UWorld one. Extravascular, here there's destruction, the antibody is bound and then they're cleared out by the splenic macrophages. So these are extravascular. So here, actually here also they're complementary. So yeah, this is clashing. Right? Or am I misreading?
Yeah, you are right.
So this is warm with extravascular, warm with extravascular, cold with extra, it says. Here cold is showing intravascular. Okay. But I think then they might not test where is the location. What we need to know, focus is IgG for warm, whether it's good. Cold is IgM type. Yeah, let's not stress about the intra versus extra because they won't test that. If anything, there'll be splenomegaly in both. So, all right, cool.
See, if you go to the table that you read, Saira, before, it says that autoimmune hemolytic anemia is for extravascular hemolysis. Whereas when you have mechanical hemolysis, prosthetic valve or something, only then it is intracellular along with PNH as well as microangiopathy. That fits the picture actually that you presented now.
Yeah, nice.
That here. That makes perfect sense actually. Yeah. This is microangiopathic hemolytic anemia, you see, and here you see down autohemolytic anemia in the extravascular. Yes. So that is matching with the picture which says both are autoimmune and both are extracellular.
This is actually matching the first aid. Both are autoimmune, both are extravascular. So yeah, it matches what you were saying. Yeah. Thank you. Yeah, that makes sense. So both end up with extravascular hemolysis because it's autoimmune. Okay. Okay. Thank you. Oh yeah. So here it matches with what it says. Both are autoimmune. So both are causing extravascular hemolysis. Okay, yeah, let's stick to that. All right, cool. So next we have leukopenias. What are leukopenias? Subtypes are neutropenias, lymphopenias, eosinopenia. Neutropenia is absolute neutrophil count less than 1500 cells per cubic millimeter. Severe infections are typical when it's less than 500. This is high yield for UWorld and NBMEs because they expect us to calculate the absolute neutrophil count, neutropenic fever, blah, blah, blah. So it's high yield. Absolute neutrophil count less than 1500. Severe infections typically when it's less than 500. So causes are sepsis, post-infection, drugs including chemo, aplastic anemia, SLE, radiation, and congenital. So sepsis or post-infection, drugs including chemo, aplastic anemia, SLE, radiation, and congenital causes. Next is lymphopenia. Here it's absolute lymphocyte count less than 1500 cells per cubic millimeter, seen in HIV, DeGeorge. What was the defect in DeGeorge? 22q11
Microdeletion.
microdeletion. Thank you. Then SCID, SLE, glucocorticoids, radiation, sepsis, and postoperative. So glucocorticoids, they gave a note. Yeah, this was high yield, right? We spoke about this earlier. Glucocorticoids cause neutrophilia. Despite causing eosinopenia and lymphopenia, glucocorticoids decrease the activation of neutrophil adhesion molecules and impairing migration out of the vasculature to the sites of inflammation. In contrast, glucocorticoids sequester eosinophils in lymph nodes, sequester eosinophils in lymph nodes and cause apoptosis of lymphocytes. So neutrophilia plus eosinopenia and lymphopenia each has its different reasons. Neutrophilia, why? Because of decreased activation of neutrophil adhesion molecules, impairing their migration out of vasculature to the sites of inflammation. Why eosinopenia? Because of sequestration. And why lymphopenia? Because they're apoptosing those cells. So 3 different reasons, 3 things. Okay, then eosinopenia, when absolute eosinophil count is less than 30 cells, causes are Cushing syndromes and glucocorticoids. So yeah, glucocorticoids comes in each one of it. So Cushing syndrome, eosinopenia. Don't remember seeing that when we did Cushing's, but okay. So adrenal insufficiency was extra, like Addison's we said was eosinophilia, so increased. So the opposite Cushing syndromes, no, that is adrenal insufficiency. This is Cushing syndrome is eosinopenia. Okay. All right, so let's take a break. Whew, this was intense, right? Okay, we got this. So let's take lunch.
Okay, so yeah. So just
adding any add-ons? Go ahead.
No, just quick. We have G6PD, extravascular, intravascular hemolysis, PNH intravascular, sickle cell extravascular, intravascular, and all others are extravascular, right?
Yes, I think so.
In IHA, we have extravascular mostly. I don't know the
according to First Aid, both extravascular, yes.
extravascular, yeah. IgG or IgM mediated drug induced, we have both. Drug induced, we have both, right?
Drug induced, both.
Yeah, both.
See here.
Drug induced both, and spherocytes suggest immune problems. Immune hemolysis and bite cell suggest oxidative stress, oxidative hemolysis. And these are due to oxidative injury or via free radical damage, may be exacerbated in G6PD and most commonly antibody-mediated immune destruction of RBCs.
Yes.
Okay, and MAHA, and hemolytic infections, these malaria, babesia. MAHA, these are
MIHA is like think of all autoimmune situations.
And these are intravascular hemolysis, both of them, right? Like PNH.
Both intravascular, yeah.
Okay, MAHA, prosthetic heart valve aortic stenosis, MIHA like DIC, DTPHUS, SLE, HELP, emergency. Okay.
So these are all extrinsic hemolytic, meaning factors outside of the RBC. So autoimmune problem, drug problem. MIHA is by narrow vessels, MAHA is the valves and stenosis. Infection, other causes. So all outside the RBC control.
So MIHA, MAHA both are in the vessel. So definitely it's intravascular, right? So
nice. Makes sense, yeah.
And you said no, eosinopenia. Sorry, what was that? So remember yesterday we were reading cortisol, and cortisol directly causes the eosinopenia. That's the direct function of the cortisol. In lymphopenia.
Cortisol function. Yeah. Cortisol and physio, right? Endocrine physio, it came up.
Neutrophilia is
so
there.
This is demonetization. This eosinopenia, lymphopenia. Yeah. Now it makes sense why. Okay, nice.
Sarah, can I interject here and then like go back to the page number 1 when you talked about anti-kale? Kale, I don't know, that question is popping up everywhere. So can you summarize in just a couple of sentences on what do you understand that anti-kale thing? If you go to the page, but
Anti-kale, it's removed from the new book. So
I know it. No, it's there.
hopefully
This
you
one
don't
is
ask.
there.
Yeah, this one, right?
Yeah,
So here,
tell me what do you understand about this?
I don't fully understand it, but let me try.
But there is a
So here
question
there's
here. There is a question. I think somebody told me, somebody's recall they showed up, looks like.
Yeah,
Okay.
it was initially, but now I think they have removed it. So maybe I think
I'll be happy. Yes. So
So
this is a
anti-kel antibodies of a kel-positive pregnant patient. So this pregnant patient has anti-kel antibodies in her bloodstream. So this will cause hemolytic disease of the newborn when produced following previous sensitization to the kel antigen transferred through the placenta. So kel antigen is getting transferred to the placenta, coming into this. My understanding is that it comes into her body, but then I think I was wrong. I think Nida used to say something else, right? Let me pull up an image maybe. So let me just read first. So anti-kel antibodies of a kel-positive pregnant patient may cause hemolytic disease of the newborn when produced following previous sensitization to the kel antigen and transferred through the placenta. It targets fetal RBC precursors. So I guess it is actually happening in the fetus. So it's targeting fetal RBC precursors, decreasing RBC production, and mature RBCs, increasing hemolysis, resulting in severe fetal anemia. Anti-kel antibodies may also be associated with hemolytic transfusion reactions.
Yeah, it looks like RH factor thing.
Isn't
Yeah.
it look like RH mostly?
Yeah, that's always I thought about it like that. Okay, fine. Thank you so much for I stepped out when you guys did this page. So yeah, okay, thanks.
No worries. So yeah, the common antigens are RH and ABO. This is a minor antigen. So it's similar to, so you guys said it's similar to RH disease, right?
Something a little severe than the RH, I guess. RH incompatibility thing. Less, but yeah, almost like similar. Isn't it? Like that's what I understood even.
Yeah, I'm not fully clear. Let me see. So here it says K negative mother. In first pregnancy, the K positive child is exposing her to the antigens. K positive child with normal pregnancy with developing anti-K antibodies in the mother. So this is her sensitization. If K negative child, then normal pregnancy. So everything goes smoothly. The only difference is if K positive, now she's sensitized. In subsequent pregnancy, if the child is K positive, so she already has the pre-built anti-K antibodies. So complications in which the anti-K antibodies from the mother will go and destroy the child's RBCs, and this could be lethal to the child. Yeah, it sounds very much like the hemolytic disease. I mean, RH, right? Okay.
yeah, here it looks similar to erythroblastosis vitalis, right?
So here also
Exactly.
first pregnancy is exposure, second pregnancy is the crossing and attack. So it's like
exactly
RH.
RH. Yeah. So I don't know
How are
why they
these
make it
two
fancy.
different? Yeah.
Make it fancy.
The antigen is alone is different. So this is RH negative, this is RH. Existing pregnant RT. So only difference between RH and ABO here, there is no need for pre-sensitization. This she already has by definition. So yeah.
But she'll have some jaundice and all those things, which is
little minor than little milder than the
phototherapy for the child. I think you have to give exchange transfusion.
Which is milder? ABO.
Yeah.
Okay.
Yeah, I remember you just give them phototherapy for the babies. Yeah. All right. Anyway, yeah.
Okay. Thank you so much. So I think we are good to go for lunch break, and we'll come back for porphyrias, I think is next. Hi everyone, welcome back from break. So continuing on page 430, we're getting into heme synthesis, porphyrias, and lead poisoning. All right, so let's go. So what are porphyrias? These are hereditary and acquired conditions of defective heme synthesis that lead to the accumulation of heme precursors. What are these porphyrias? These are hereditary or acquired conditions of defective heme synthesis that lead to accumulation of heme precursors. Lead inhibits specific enzymes that are needed in heme synthesis, leading to a similar condition. So first we have lead poisoning, AIP, and PCT. All right, let's see. So what is the affected enzyme in lead poisoning? Ferrochelatase and ALA dehydratase. As we know, these are tested in UL questions. Accumulated substrate is protoporphyrin and ALA. Presenting symptoms are microcytic anemia. Basophilic stippling is seen in peripheral smear. As we saw earlier, there's ringed sideroblast in the bone marrow. So microcytic anemia, GI, and kidney disease are the presentations. Microcytic anemia with presentation is basophilic stippling in the peripheral smear, as well as ringed sideroblast in the bone marrow. In children, exposure to lead paint and mental deterioration can lead to mental deterioration. In adults, it's environmental exposure like batteries or ammunition can lead to headache, memory loss, and demyelination, peripheral neuropathy. All right, so then we have acute intermittent porphyria. What are the affected enzymes here? It's porphobilinogen deaminase. This is an autosomal dominant mutation. Accumulated substrate is porphobilinogen and ALA. So here's protoporphyrin and ALA. Here it is porphobilinogen and ALA. Symptoms are the 5 Ps. So yeah. P for porphobilinogen deaminase deficiency. Accumulation is also porphobilinogen. Symptoms are painful abdomen, port wine colored pee, polyneuropathy, psychologic disturbances, and precipitated by factors that increase ALA synthase. What are these factors? Cytochrome P450, alcohol, and starvation. How do we treat these patients? We give hemin and glucose. Next, we have PCT, which is porphyria cutaneous tarda. What's the defective enzyme here? We have uroporphyrinogen decarboxylase. Accumulated substrate is uroporphyrin, which causes the tea-colored urine. Presentation, this is cutaneous tarda, so cutaneous photosensitivity and hyperpigmentation. So there is blistering, cutaneous photosensitivity, and hyperpigmentation, as seen here. Most common porphyria exacerbated with alcohol consumption. Causes are familial and hep C. So C, we have PCT, P for photosensitivity, C for cutaneous, and T for tea-colored urine. Treatment is phlebotomy and sun avoidance, as well as antimalarials like hydroxychloroquine helps patients with PCT. Okay. So yeah, this comes up a lot. So PPP stuff is the acute intermittent porphyria versus the blistering stuff is porphyria cutaneous tarda. So this is photosensitivity, C for hep C association, and T for tea-colored urine. So what's the pathway we have in the mitochondria and the cytoplasm? So we have succinyl-CoA plus glycine converting to aminolevulinic acid. Aminolevulinic acid converts to porphobilinogen and so on. So what is happening? The first step in the mitochondria, succinyl-CoA combines with glycine to form ALA in the presence of B6. Enzyme is ALA synthase, which is a rate-limiting step. This is glucose, hemin, and sideroblastic anemia inhibit this step. So yeah, glucose, when there's hemin kind of, when there's enough heme, it's a feedback inhibition. So glucose, hemin, and sideroblastic anemia, which is X-linked, inhibits this in this step, which is ALA synthase. Then ALA to porphobilinogen, the enzyme is ALA dehydratase, which is inhibited by lead poisoning. And we said 2 enzymes, so yeah, we'll see. Then we have porphobilinogen converting to hydroxymethylbilane. This is by an enzyme porphobilinogen deaminase, which is which is deficient in acute intermittent porphyria. What's the enzyme? Porphobilinogen deaminase. So porphobilinogen accumulates. Then hydroxymethylbilane converts to uroporphyrinogen 3. So nothing here. Uroporphyrinogen 3 converts to coproporphyrinogen 3 by the enzyme uroporphyrinogen decarboxylase inhibited by porphyria tarda. Coproporphyrinogen 3 is shuttled back into the mitochondria and converted to protoporphyrin. Protoporphyrin combines with Fe2 plus to form heme. This is with the enzyme ferrochelatase, and lead poisoning is inhibiting this enzyme. So lead poisoning, as we saw, two enzymes, ferrochelatase as well as ALA dehydratase. And this one was autosomal dominant. Porphobilinogen deaminase and uroporphyrogen decarboxylase is for PCT. And Shruti has shared a very nice mnemonic. Thank you for sharing. So PG degree, Shruti, you wanna read this or elaborate this, please?
Sure. This side, the first mnemonic is about the enzymes. So PG degree, you study, you dedicate, completely postponing Facebook. That's the mnemonic for the enzymes deficiency in the porphyria. So PG, so it is the PBG deaminase. Okay. You study, that is the porphyrinogens 3 synthase. So we don't need to remember everything. U and S, that is the euro we get to know, and the synthase is the one thing. Then second is you dedicate. So you dedicate is the uroporphyrinogen decarboxylase. Only two things need to remember. Euro decarboxy is coming the third one. Completely copro porphyrinogens 3. Okay, so CO is the copro, CO. Postponing, that is the PO, that is protoporphyrinogen, and the Facebook is the ferrochelates. Then this side is like simultaneously which disease deficient in which disease these enzymes are deficient. So here the mnemonic is a corrupt politician hides very easily. So, I mean, it may take like once or twice to really, repetition may help this mnemonic to memorize whole the thing. So A is the AIP, that is the acute intermittent porphyria, corrupt. Okay, so uroporphyrinogen 3 synthase is deficient in what? CEP. So corrupt CEP, that is the congenital erythropoietic porphyrias. Then politician PCT. Okay, that is the porphyria cutanea tarda. So again, the corresponding enzyme which is deficient. Yes, exactly. Deficient is uroporphyro UD, right? So this one is the third. Then heights is the HCP, that is hereditary corporopporphyria. I don't mug hole the name even, I just go with the H. So this is the one in which the CO is the coproporphyrinogen is deficient, yes. Then very is the VP, that is the vegeta porphyria, which is again protoporphyrinogen is deficient in that. And easily is the EPP, that is again for the, what was the full name? I don't remember exactly. But yeah, I'll this full name something I don't remember this one, but this is basically the protoporphyria, we say it. So yeah, EPP is the one. I don't remember what was that. There is some name is there.
Essential. I'm just guessing. I don't know.
No, even I'm not able to recall that. But there is the name, which is. I'll check and let you know about this one.
Erythropoietic, I think. I just googled it.
Erythropoietic protoporphyria. Yeah. So that is the one. So yeah. I don't know. It is more complex or what, but some way it hits me. So,
No, this is good. This actually has all of the porphyrias, and even if they're the ones, some of them are not mentioned on First Aid. I think this was on UWorld though. Yeah, I like it. Thank you. PG degree, you study, you dedicate, completely postponing Facebook. Nice. Thank you for sharing. This is a good one. So this is the one that is autosomal recessive. These are all autosomal dominant. A corrupt politician hides very easily. Okay.
Yeah. Thank you.
Okay. All right. So that's done with this page. Cool. So next we have iron.
Sorry, uroporphyrinogen 3 is between hydroxymethylbilane and uroporphyrinogen 3, right?
Say again. Yeah. What did you ask? Sorry, I didn't follow.
Hydroxymethylbilane to uroporphyrinogen 3 is uroporphyrinogen synthase, right?
This enzyme here. Yeah. Uroporphyrinogen.
Okay. And deficiency leads to hereditary something hereditary.
It was, she said, congenital erythropoietic porphyria. For UP, you're talking about this step, right? Hydroxymethyl
Yeah.
equivalent to UP3. So if this step is in enzyme is inhibited, it's actually
CEP.
EP, I think, which is congenital erythroporphyria.
Congenital erythroporphyria. Okay. So PCT and then coproporphyrinogen to protoporphyrinogen, then it's HCP, right?
Yeah.
Okay. And the final one, which is between furochelatase inhibition. What is it? So furochelatase is
Was it erythrogenic? What did I say? Erythropoietic porphyria. So other than lead poisoning, the diagnosis would be erythropoietic protoporphyria.
erythropoietic protoporphyria. Okay. So CEP, HCP, and EPP. Okay. Thank you.
You're welcome.
Thank you, Shruti.
So lead poisoning also ferrochelatase, and if it's an autosomal dominant disorder, then it is erythropoietic. This one, erythropoietic protoporphyria. If the ferrochelatase is the problem. Okay, nice. Okay.
I shared one more this thing you can like see from my handwriting is not that great, so maybe that helps.
Don't worry, it's good. So this enzyme, yeah. Okay, so this you made into the mnemonic. Okay, nice. So UP3 to CP3 is uroporphyrinogen decarboxylase, which is PCT is a deficiency. Yes. Did we say it correctly? Did I say it correctly? Yeah, UP3 to CP3 is UP decarboxylase, which is PCT. Actually, I might have made a mistake. No, yeah. Before we were talking about hydroxymethylbilane to UP3, which is this step. So synthase, and yeah, that's right. Congenital erythropoietic porphyria. Yes. Thank you. Is this from?
I checked it in Google and sent it now.
Okay. No, I was wondering if this was a pathoma, but yeah. Okay. Thank you so much.
Thank you.
Okay. Okay.
I hope these are not high yield, all of them.
No, I think these three are the main thing: lead poisoning, AIP, PCT.
The questions are
AIP
from
is all the stuff. Yeah. Then lead poisoning is the ferrochelatase and ALA dehydratase, and PCT is uroporphyrinogen decarboxylase. We're preparing ourselves for anything. So that's why. Anyway, just kidding. So moving on, iron poisoning, we have acute and chronic. So findings are a high mortality rate associated with accidental ingestion by children. Adult iron tablets may look like candy. So mechanism here that we have cell deaths due to formation of free radicals and peroxidation of membranes. So accidental ingestion is the main cause. And symptoms and signs are abdominal pain, vomiting, GI bleeding, radiopaque pill, which is seen on X-ray, may progress to anion gap metabolic acidosis and multi-organ failure. It leads to scarring with GI obstruction. Treatment escalation, this we saw in our antitoxicity page, antidote page. We chelate with this deferoxamine, deferasirox, And there's another one, but it has deferro something in its name. And then we also do gastric lavage. So for chronic, findings are seen in patients with primary, which is hereditary, or secondary chronic blood transfusions for thalassemia, or for sickle cell disease and hemochromatosis. So primary, it's a hereditary problem, or secondary to blood transfusions for thalassemia or sickle cell disease and hemochromatosis. Secondary hemochromatosis, actually. Secondary hemochromatosis is because of the blood transfusion for thalassemia and sickle cell disease. Okay, yeah, so then here symptoms and signs are arthropathy, cirrhosis, cardiomyopathy, diabetes mellitus, and skin pigmentation, which is known as bronze diabetes, and also hypogonadism. Treatment is phlebotomy, patients without anemia or chelation. Okay, so that's iron poisoning. Acute occurs by accidental ingestion. Mechanism is cell death due to formation of free radicals and peroxidation of lipid membranes. This peroxidation of lipid membranes comes up actually. Symptoms and signs are abdominal pain, vomiting, GI bleeding. Radiopaque pill is seen on X-ray, may progress to anion gap metabolic acidosis. Yeah, one of the mud piles causes is iron tablets, yeah. And multi-organ failure, so it leads to scarring with obstruction, GI obstruction. Treatment is chelation and gastric lavage. For chronic, seen in patients with primary, hereditary, or secondary hemochromatosis. Symptoms and signs: arthropathy, cirrhosis, cardiomyopathy, diabetes mellitus, and skin pigmentation, hypogonadism. So next we have coagulation disorders. So yeah, PT. So yeah, this we saw briefly. PT tests function of the common and intrinsic pathway factors, common and extrinsic pathway factors, which are 1, 2, 5, 7, and 10. So defect is, if there's a defect in any of these, it'll be increased PT, play tennis outside, it's extrinsic pathway. INR is the international normalized ratio. Patient PT divided by control PT. That's INR. So patient's PT divided by control PT. If it's 1, it's normal. If it's more than 1, it's prolonged. Most common tests used to follow patients on warfarin, which prolongs INR. So follow-up for patients on warfarin, which prolongs INR. PTT tests the function of the common and intrinsic pathway, all factors except 7 and 13. Defect, if they're defective, then it increases VTT, play table tennis inside. So common and intrinsic pathway except 7 and 13. TT measures the rate of conversion of fibrinogen to fibrin. Prolonged by anticoagulants, hypofibrinogenemia, DIC, and liver disease. This is what thrombin time. So it measures the rate of conversion of fibrinogen to fibrin. Prolonged by anticoagulants, hypofibrinogenemia. So if this is not there, DIC and liver disease. So coagulation disorders can be due to clotting factor deficiencies or acquired factor inhibitors. Clotting factor deficiencies or acquired factor inhibitors, most commonly against factor 8. Against factor 8. Diagnosed with a mixing study in which normal plasma is added to patient's plasma. Clotting factor deficiencies should correct the PT or should correct, meaning the PT or PTT returns to within the appropriate normal range, whereas factor inhibitors will not correct. Okay.
What does it mean?
It means like if you do a mixing study, you're putting the normal plasma, which has the factors, along with the patient's plasma. So if it corrects, you know that the factors are deficient. Whereas if the factor inhibitors are present, no matter you add with the normal plasma containing the anticoagulant factors, it will not correct because there's factor inhibitors in that serum, right? Does that make sense?
Is it something like you're talking about thalassemia, or hemophilia A and B? 9 and 8 factors. Okay, when a patient doesn't have 8, you can give them 9 because 8 is normal, something like that. Mix and match.
That's deficiency of the factors. Here they're talking about mixing study where you find out if there are factor antibodies. So because here they're saying, right, coagulation factor disorders can be either due to clotting factor deficiency, so that's different, as in hemophilias, or acquired factor inhibitors. So most commonly against factor 8. It's kind of like think of it as an antibody or factor inhibitor, right? Antibody against factor 8 is most common. So how do you diagnose if it's an acquired factor inhibitor problem is with a mixing study. So you take the normal plasma should have all the factors, right? So a normal plasma with the factors, and we're adding it to the patient's plasma. So if the patient, so now if there is clotting factor deficiency is corrected, because this patient is now getting the orange one from the donor plasma, so they're okay. So it's just a deficiency, like in hemophilia, versus if they have something like the patient is having an factor inhibitor. So even if you give normal plasma, that inhibitor will go and block even the donor factors. So that's what they're saying to how to differentiate. Mixing study. We mix normal plasma to the patient's plasma. Clotting factor deficiency should improve because it's a deficiency. And you're giving normal plasma, which has the factors. So that's resolved. But if with factor inhibitors, it will not correct because there are inhibitors, or think of them as antibodies present. So no matter how much normal plasma or factors you're adding, it still won't help. So it won't correct. Does that make sense?
Yeah. Yeah.
So it
thank
helps
you.
to differentiate between deficiency versus factor inhibitors.
Sorry, Saira, I have a confusion. Extrinsic pathway is only 7 and 3, right? If I'm not wrong.
13.
Sorry, intrinsic pathway is
Let me check. Hold on. Let me give you
extrinsic
correct.
pathway is 7 and 3. No. Intrinsic pathway is all these like.
Extrinsic pathway is 7 and the tissue factor, which you said 3A. Intrinsic factor is 12, 11, 10, 12, 12, 11, 9, 8.
And then why they have written a PT function, test function of common and extrinsic pathway factors 1, 2, 5, 7, and 10.
That's the common pathway, right? Common pathway is
Oh, okay.
1,
Sorry.
2,
Sorry, I just lost it.
yeah. 1, 2, 5, 10. This is part of the common. So this common is testing. And then extrinsic, we only have 7, wala.
Yeah.
All the rest are for common pathway, yeah. Okay. All right, so next we have hemophilia A, B, or C. Here, PT is not changed. PTT is elevated because with PTT, we are checking the intrinsic pathway. Yeah, and intrinsic. So in hemophilia, okay, let me read this first, then it makes sense. So intrinsic pathway coagulation defect. So that's increasing PTT, table tennis. So what is the deficiency? If it's hemophilia A, there's a deficiency of factor 8. Factor 8 is part of the intrinsic pathway. So this is X-linked recessive, pronounce hemophilia 8 to remember hemophilia 8. Hemophilia A is 8. Then hemophilia B, there's deficiency of factor 9. Hemophilia C, deficiency of factor 11. So what is another genetically important here? This is X-linked recessive. Hemophilia B is X-linked recessive. This is autosomal recessive. Hemorrhage and hemophilia causes hematolosis, bleeding into joints and knee. Easy bruising, bleeding after trauma or surgery, like dental procedures. So hematolosis is usually the main clue for hemophilia and questions. Easy bruising and bleeding after trauma or surgery, like dental procedures. Treatment, we treat with desmopressin, factor 8 concentrate, emicizumab, which we said imitates factor 8. So emicizumab for hemophilia A, factor 9 concentrate for hemophilia B, and factor 11 concentrate for hemophilia C. So individually factors we're giving factor concentrates. Additionally, for hemophilia A, we should remember the monoclonal antibody emicizumab. So yeah, PTT is elevated because these factors are involved in the intrinsic pathway. Then vitamin K deficiency, both PT and PTT is elevated. This is a general coagulation defect. Bleeding time is normal. Coagulation is the problem. Bleeding time is normal. Decreased activity of factors 2, 7, 9, 10, protein C and S, which are all vitamin K dependent for coagulation. Okay, so that's done. So we did iron poisoning, acute and chronic coagulation disorders, and hemophilia A, B, C, and vitamin K deficiency. So next we have platelet disorders. What are the platelet disorders? So all platelet disorders have increased bleeding time. So that makes sense. Platelets are responsible to form the initial plug. So they'll increase bleeding time, mucous membrane bleeding, and microhemorrhages like petechiae and epistaxis. So platelet count is usually low, but may be normal in qualitative disorders. So platelet count is usually low, but may be normal in qualitative disorders. This is actually high yield. So what are the disorders? Bernard-Soulier syndrome, Glanzmann thrombocythemia, immune thrombocytopenia, ITP, and uremic platelet dysfunction. So Bernard-Soulier, this is an autosomal recessive defect. So is Glanzmann. Okay, so these are both autosomal recessive defects. So defect problem here is in adhesion. So here we have decreased GP1B, causing decreased platelet to von Willebrand factor adhesion. Labs, there's decreased platelet aggregation, and we have big platelets. So this is the clue in the questions as well. Bernard-Soulier, B for big platelets. Yes. Thank you. Okay, thank you for sharing, Vinay. So yeah, we have a platelet plug formation. So Bernard-Soulier, we have decreased GP1B. So that leads to decreased platelet to von Willebrand factor adhesion, because that's what's needed for this adhesion between the platelets and the endothelium. So this is Bernard-Soulier. Next, we have Glanzmann's thrombocythemia. Here, okay, so yeah, labs. In Bernard-Soulier, there's increased bleeding time as in all platelet disorders. So that's common. Here, platelet count is normal or decreased. Because the platelets are aggregating, platelet count can go down. Glanzmann's thrombocythemia, this is autosomal recessive defect in aggregation. So this is an aggregation problem. There's decreased so yeah, this is a defect in aggregation. Here we have decreased GP2B3A, which is otherwise known as decreased integrin A alpha 2B beta 3. So GP2B3A, also known as decreased integrin alpha 2B beta 3. So it leads to decreased platelet to platelet aggregation and defective platelet plug formation. So we're seeing two platelets here, and GP2B3A is binding the fibrinogen into both platelets, causing platelet aggregation. So if we have no GP2B3A, no platelet to platelet aggregation and defective plug formation. So labs blood smear shows no platelet clumping. In labs over here, there's decreased platelet aggregation and big platelets. For this one, labs blood smear shows no platelet clumping. Then we have immune thrombocytopenia. Here there's destruction of platelets in the spleen. Anti-GP2B3A antibodies are present. So there's splenic macrophages phagocytose platelets. This may be idiopathic or secondary to autoimmune disorders like SLE, viral illness, malignancy like CLL, or drug reactions. So yeah, what is the main problem here? There is immune destruction. So destruction of platelets in spleen. So it's an immune issue. So there are antibodies involved. What are the antibodies? GP2B3A. And then these are, so splenic macrophages will clear everything. So splenic macrophages are phagocytosing the platelets. So this can be idiopathic, unknown cause, or secondary to autoimmune disorders like SLE, viral illness, HIV, HCV, malignancy, CLL, or drug reactions. What do we see in labs? There's increased megakaryocytes on bone marrow biopsy and decreased platelet count. So treatment, how do we treat immune ITP? We give glucocorticoids, IVIG, rituximab TPO receptor agonist like L-trombopag, romiplostim, or splenectomy for refractory ITP. So how do we treat ITP? We give glucocorticoids, IVIG, rituximab, or TPO receptor antagonists. TPO receptor agonists like L-trombopag and romiplostim, or splenectomy for refractory ITP. L-trombopag. I think this comes up later in pharm. Okay. So then next we have uremic platelet dysfunction. Here we have increased bleeding time. So are we done with this? Yes. So PGI2 and NO is inhibiting the fibrinogen. Thromboxane and E2 are stimulating the platelet activation and aggregation. Yes, this was very useful. Thank you for sharing. Okay, so next, uremic platelet dysfunctions, very sneaky in questions. They'll give a scenario of renal failure patients. Uremic toxins accumulate and interfere with platelet aggregation. So yeah, you just have a platelet. It's coated with this urea and uremic products so that they interfere with platelet adhesion. So yeah, patients with renal failure, uremic toxins accumulate and interfere with platelet adhesion. So bleeding time is increased. Platelets are completely normal. Platelet count is normal. So that's the platelet disorders.
Sorry.
So next we have.
Sorry,
Coach, saying something. Go ahead, Fez.
May I go back to the page? Sorry, I couldn't talk earlier. So the Bernard-Soulier and Glanzmann, easy way to remember, or even understanding, it's an adhesion problem, right? So the issue with adhesion is done by what? The complex protein, right? The glycocomplex protein, GP1BX something. It's a whole protein, right? So if it doesn't bind, it falls off. It's a normal platelet. So if it doesn't bind, it falls off. That's why the platelet counts decrease. Whereas Glanzmann thrombocytopenia, there's no adhesion issue. It's just that the platelets are bad. They can't aggregate. They can't attach. Platelet cannot attach to another platelet. So easy way to remember, Soulier, I think of soldier. So soldiers are always first line, GP1B. 1B, they're always first line. They can't go to the enemy's front line. So if they can't attach to the enemy's front line, they get shot, whatever, they get decrease in number. Platelet count decrease in number. Whereas Glanzmann starts with G, general are second line. They stay behind. They are second line, so they're GP2B3A. And they never get shot or anything. If the war finishes or whatever, they just run away. So their platelet count remains normal. So just to differentiate between those two, if you got what I'm saying.
Nice. What did you say? Sorry, Glanzmann was what was the
general?
medicine?
G for general. So generals are always second line, right?
Nice, gotcha. Nice, thank you. So that makes sense. So just soldier gets killed off, so they go down. So you said because they're
and it's an adhesion problem. It's a complex, the whole complex that binds to the GP1B, right? So the platelets are completely fine. It's just that they can't attach. That's it. So if they can't attach, the count goes down. Whereas Glanzmann, they complete the GP2B3A. They attach on the top. They have nothing to do with the what is it called? To the damaged blood vessels. They go on top. If you look at the picture, it will show that it's on the top. You see, GP1B binds to the exposed collagen on the bottom to the enemy front line, whereas GP23BA, they are on top, platelet to platelet aggregation.
Nice.
Yeah.
So because these are not binding, they just fall off. So think of it as just falling off and the platelet count dropping. Okay, nice.
But if you can't remember, just remember the soldier in general.
Yeah,
Yeah, very nice. Thank you so much, guys.
thank you. Okay, so just to clarify the platelet disorders again. So all platelet disorders have increased bleeding time, mucous membrane bleeding, and microhemorrhages like petechiae and epistaxis. Platelet count is usually low, but may be normal in qualitative disorders. So we have Bernard-Soulier, Glanzmann, immune thrombocytopenia, and uremic platelet dysfunction. So what is this bleeding time, first of all? So bleeding time, if you recall from med school physio or clinical skills, we used to do this test on our own self. We prick our finger with the lancet, and then we time ourselves, right? Like how long it takes for that bleeding to stop. So pretty much bleeding time is the time that elapses between the puncture of the skin and the stoppage of blood oozing using a lancet. So what is this trying to assess is platelet function, because if we recall, yes, so if we recall, even before the coagulation cascade comes into play, the first step that's just involved is platelet plug formation, which is known as primary hemostasis. So after endothelial damage or injury occurs, and all these steps takes place, there's a temporary plug is what is responsible for stopping the bleeding. And for this temporary plug to be formed, we know that platelets need to aggregate. So by doing a bleeding time test, we are assessing if there is a proper platelet plug has formed or not. So which is why if we look at our platelet disorders, here something is wrong with the platelets, right? Something is an issue with the platelets, which is why there's no proper primary temporary platelet plug. So because that plug is not formed, we have an increased bleeding time. So all of these disorders, whether it's Bernard-Soulier or Glanzmann, ITP, or uremic platelet dysfunction, bleeding time is prolonged because for some reason or the other, there is no temporary plug forming. There's no proper primary hemostasis. So let's see what happens. So we have Bernard-Soulier syndrome, which is an autosomal recessive defect in adhesion. There's decreased GP1B, decreased platelet to 1 milligram factor adhesion. Labs there's decreased platelet aggregation, and there's big platelets. So this is the buzzword, big platelets. And as Fez has told us, the mnemonic, remember, soldier is first line. So GP1B, first line for reminding us is 1B. And also to remember that they are at the front line, at the border with the enemy, right? So GP1B is going to bind to the von Willebrand factor. This green one here is going to bind to the von Willebrand factor in the exposed collagen area in the subendothelium. So that's Bernard-Soulier, autosomal recessive defect in adhesion, decreased GP1B, decreased platelet to von Willebrand factor adhesion. Labs will show decreased platelet aggregation. Of course, it makes sense because this is not going to be binding to the von Willebrand factor. So there will not be aggregation. This whole step, the cascade will not start. So there is decreased platelet aggregation. And because of something to do with the surface, there are big platelets. So the confusion was, why is the platelet count normal or low? So to solve that, I was looking up online on NCBI, National Library of Medicine. So here, if you look at the pathophys, it says that GP1B, number 95, that's the extra name. So GP1B complex is expressed on the platelet surface. By facilitating platelet adhesion to the subendothelium, the GP1B complex leads to clot formation whenever the vascular subendothelium is exposed or a plaque ruptures. Hence, the activity of GP1 complex is also critical in DVT. The most important function of the GP1 1b complex is to bind with von Willebrand factor and initiate a signaling cascade that would activate the platelet integrant GP2B3A, leading to platelet aggregation. Although von Willebrand factor is also a weak agonist, blah, blah, blah. So all this is extra info. So to answer our question, GP1B also plays a role in maintaining platelet shape by linking the platelet surface to a submembranous network of actin filaments, the platelet membrane skeleton. This involves the central portion of the cytoplasmic tail of GP1B alpha, particularly phenylalanine and tryptophan, some type of proteins, which provides a binding site for the actin-associated protein filament A. So considering all the functions of GP1B95 complex, one can understand that a mutation in the encoding genes could lead to reduced activation of platelets, defective adhesion, and subsequently inadequate clot-forming capability. In addition to this, the defects in the complex can also explain the giant platelets in patients with BSS. So considering all the functions of GP1B complex, one can understand that a mutation in the encoding genes could lead to reduced activation of the platelets. 1, reduced activation of platelets. 2, defective adhesion. 3, subsequently inadequate clot forming capability. In addition to this, number 4, the defects in the complex can also explain the giant platelets in patients with BSS. So here I go on to read that in terms of diagnosis, it's characterized by prolonged bleeding time, thrombocytopenia, increased megakaryocytes, and enlarged platelets. Bernard-Solier is associated with quantitative or qualitative defects of the platelet glycoprotein GP1B. The degree of thrombocytopenia may be estimated incorrectly due to the possibility that when the platelet count is performed with automatic counters, giant platelets may reach the size of RBCs. The large platelets and low platelet count in BSS are seemingly due to the absence of GP1BA alpha and the filament A binding site that links the complex to the platelet membrane skeleton. Dysfunctional platelets are rapidly cleared from the circulation, leading to a decreased platelet count or thrombocytopenia. So we know that from this article that this GP1B is also responsible for the proper shape of the platelets. And the defects in the complex can explain the giant platelets. So here it says the role in maintaining platelet shape. So we know now that they have giant platelets in Bernard, big platelets. So they are going to be eventually cleared by the immune system. So which is why the platelet count may be normal or low. Normal potentially because of the large size, they are incorrectly detected by the lab tests to be normal, or potentially they're not destroyed enough at this point so that platelet count can come back as normal. But they may also undergo immune destruction because of their massive size. And that could be one of the reasons that the platelet count drops. So big platelet count can be normal or low. So the key thing to remember is GP1B, first line soldiers. So big platelets and potentially getting destroyed. Versus Glanzmann thrombocythemia, according to Stat Pearls, here, this is a platelet disorder, where we have GP2B3A problem. But the platelets are identified, in generally, the platelets of a patient with GT appear normal. And very rarely there may be mutations that can result in any unequal sized platelets. But in most cases of Glanzmann thrombocythemia, the platelet is normal. Platelet shape is normal. Platelet count is also normal. So which is why here the platelet count is normal. Versus here they have big platelets, so they're potentially going to get destroyed by the spleen or the immune system. So platelet count can drop over here. As Faiz said, the nice mnemonic, it's G for general. General is always in the background. They're not going to the front line. They're standing in the background and watching what's going on. So GP2B3A is in the background. So this Glanzmann thrombocythemia is a defect in an autosomal recessive defect in aggregation. So decreased GP2B3A. So there's decreased platelet to platelet aggregation and a defective platelet plug formation. So labs, the blood smears show no platelet clumping. clumping. And in line with our mnemonic, because the general is in the background, they don't get destroyed. Even if the war is over, the soldiers are the one that drop dead, versus the platelet count will be normal in Klansmen. So I'm also thinking potentially the shape is not as altered as with the Bernard Solier, so which is why they don't get destroyed. So the lab's platelet count comes back a normal. Bleeding time is of course going to be prolonged because there's no primary platelet plug formed.
And anyone remember a von Willebrand factor we studied yesterday associated with which condition of gastro? Von Willebrand factor, aortic stenosis, and I think
Yeah, it's a
renal disease.
ischemia, acute ischemia. No,
No.
I don't know that.
I think below acute mesenteric ischemia. What was that?
Chronic, no, the little condition in the middle,
which causing right-sided colonic bleeding.
Right. That is the atherosclerotic something. Oh no. Yeah. I'm going to copy. How's that?
angiodysplasia.
Yeah.
Sorry.
Yeah.
So 3 conditions, right? Von Willebrand, aortic stenosis,
Associated with ESRD, aortic stenosis, and VWF, von Willebrand disease. Yes. Nice. Angiodysplasia is associated with end-stage renal disease, von Willebrand disease, and aortic stenosis. Nice correlation. Thanks. Okay, next is thrombotic microangiopathies. Disorders overlap significantly in symptomatology, may resemble DIC, but do not exhibit the lab findings of consumptive coagulopathy, as etiology does not involve widespread clotting factor activation. So we have TTP and HUS are both thrombotic microangiopathies, So etiology is typically females for TTP and typically children for HUS. Pathophys, here there's inhibition or deficiency of Adams TS13, which is a von Willebrand factor metalloprotease. It causes decreased degradation of von Willebrand factor multimers. So there's increased number of large VWF multimers. That causes increased platelet adhesion and aggregation and microthrombi formation. So microthrombi angiopathy. So microthrombi going and blocking the vessels. So microangiopathy. So it makes sense. So the main thing to remember, this is Adams TS13 problem. Either it's inhibited or there's deficiency. Then versus HUS, here it's predominantly caused by the Shiga toxin, producing E. coli STEC infection, serotype O15787, as we've seen in micro, which causes profound endothelial dysfunction. So endothelial dysfunction is the main underlying pathophys. So presentation, they both present with the triad of thrombocytopenia. So that's decreased platelets, MAHA, microangiopathic hemolytic anemia, or actually you should say MIHA, and decreased hemoglobin in schistocytes. So yeah, whenever there's hemolysis of the RBCs, they're going to leak out. So hemolysis is happening, so decreased hemoglobin. Schistocytes, we saw increased LDH because RBC usually contain the LDH inside the cells. If it gets destroyed, then they're going to leak the LDH out. So there's increased LDH levels in the serum, and acute kidney injury, which will cause increased creatinine levels. Differentiating symptoms. Here there's a triad plus fever and neurologic symptoms. So yeah, DTP will have fever and neurologic symptoms. Here there's triad plus bloody diarrhea. Labs, normal PT and PTT helps distinguish TTP and HUS. Coagulation pathway is not activated from DIC. So yeah, the main key difference, both resemble DIC, but here there'll be normal PT and PTT. So that helps distinguish TTP and HUS versus DIC. How do we treat? We give plasma exchange, glucocorticoids and rituximab, and supportive care. Right. So disorders overlap. Yeah. So I think Yeah, we got the gist. So TTP versus HUS, main things, TTP is females, HUS is children. Pathophys in TTP is either inhibition or deficiency of ADAMTS13, which is a von Willebrand factor metalloprotease. Protease, so it should destroy or cleave something, so it should cause cleavage of the multimers. So there's decreased degradation of the multimers. So net effect is we have lots of large multimers floating around. These increase platelet aggregation, adhesion, as well as aggregation and microthrombi formation. Versus in HUS, predominantly caused by Shiga toxin producing E. coli, STEC infection, serotype O157H7, which causes profound endothelial dysfunction. So both have thrombocytopenia, which is decreased platelets, MIHA, which is microangiopathic hemolytic anemia, and acute kidney injury. So that's the triad. How do we see the MIHA in the labs? There'll be decreased hemoglobin, schistocytes on the smear, and increased LDH in the labs. Acute kidney injury will also cause increased creat levels. Differentiating symptoms, triad plus fever plus neurologic symptoms is TTP, triad plus bloody diarrhea because it's Shiga toxin. That will be HUS. Labs, normal PT and PTT for both versus compared to DSC where there will be increased PTT and decrease in fibrinogen because of consumption. Treatment, plasma exchange, glucocorticoids, and rituximab. Supportive care for HUS. All right, so that's done with platelet disorders and thrombotic microangiopathies. So next we have mixed platelet and coagulation disorders. This is von Willebrand disease, which we said now was associated with angiodysplasia. So they didn't mention it here. Okay. So mixed platelet and coagulation disorders. So this is von Willebrand disease and DIC. So platelets as well as coagulation issues are there. So von Willebrand disease, what happens, there's an intrinsic pathway collagen defect. So decreased von Willebrand factor, which leads to increased PTT. Von Willebrand factor, we said the other function is to carry and protect factor 8. So defect in platelet, so that's one problem. Then we have defect in platelet plug formation. So there's decreased VWF. So there's a decreased defect. So there is a defect in platelet 2 von Willebrand factor adhesion. So most of these are autosomal dominant cases. They're mild, but most common inherited bleeding disorder. Commonly present with menorrhagia or epistaxis. Treat with desmopressin, which will release the von Willebrand factor stored in endothelium. So because the intrinsic pathway is affected, PTT is normal or elevated. Because there's a defect in platelet plug formation, bleeding time will go up. And there's no change in PT, which was extrinsic pathway, and platelet count is still normal or unchanged. So yeah, PTT and BT both go up. Then next we have DIC. So this is widespread clotting factor activation, leads to a thromboembolic state with excessive clotting factor consumption. So increased thromboses, increased hemorrhages, example, blood oozing from puncture sites, which is usually a clue in questions. Blood oozing from puncture site is increased hemorrhages. Maybe acute if life-threatening, or chronic if clotting factor production can compensate for consumption. One more time, it can be acute, which is life-threatening, or chronic if clotting factor production can compensate for the consumption. So what are the causes? It can be because of heat stroke, snake bites, sepsis, gram-negative sepsis, trauma. So stop making new thrombi. So heat stroke, snake bites, sepsis, specifically gram-negative, trauma, obstetric complications, acute pancreatitis. So we saw this yesterday, malignancy, nephrotic syndrome, transfusion. So stop making new thrombi. Labs, we see schistocytes, yes, because there's destruction. Increased fibrin degradation products like D-dimers. Yeah, D-dimers usually mentioned in the question. Decreased fibrinogen because of consumption again, and decreased factors 5 and 8. So because the factors are less, 5 and 8 is part of 5. Okay, 8. Yeah, both are part of
Common.
Yeah, 8 actually comes in intrinsic.
5 common.
5 is common, yeah. 5 is common. So common means both will be affected. 8 means intrinsic. So intrinsic is table tennis. So that's the both are elevated. Platelets are also getting destroyed. So bleeding time is high. Now platelets, what's happening? Platelet count is dropping. They're getting consumed. Yeah, okay. Bleeding time is high because clotting factors are low. So yeah, decreased platelet count, increased bleeding time, PT and PTT both elevated. Fibrinogen will also be low and decrease factor 5 and 8. So Black Widow we said for myocarditis. Yesterday we saw scorpion sting for anyone?
Pancreatitis?
Yes, it was pancreatitis. Acute pancreatitis, if I'm not wrong. And now we're seeing snake bite for DIC. And DIC, they usually mention the scenario of snake bite. All right, so yeah, just to recall, snake bites is for DIC. Black Widow spider was myocarditis, and this scorpion was acute pancreatitis. Okay, cool. So next we have hereditary thrombophilias. These are autosomal dominant disorders resulting in a hypercoagulable state. Hypercoagulable means increased tendency to develop thrombosis. What are these? We have antithrombin deficiency, factor 5 laden, protein CRS deficiency, prothrombin G2021 0A mutation. Okay. So what is antithrombin deficiency? This has no direct effect on the PT, PTT or thrombin time, but diminishes the increase in PTT following standard heparin dosing. So this can also be acquired. So most are autosomal dominant, but this can be acquired. As in the case of renal failure or nephrotic syndrome, antithrombin is lost in the urine and there's decreased inhibition of factors 2A and 10. So antithrombin will inhibit normally 2A and 10A. So if you don't have this, there's decreased inhibition of factors 2A and 10A. Okay. All right, then next is factor 5 laden. This is a production of a mutant factor 5.
Sorry, Saira. What is the first line meaning? It has no direct effect on PT, PTT or thrombin time.
So no direct effect on the PT, PTT or thrombin time. So they mean to say directly there's no effect, but it diminishes PTT only if it is followed by standard heparin dosing. So when heparin has done its job, what is, so heparin enhances the active of antithrombin 3. We saw it in the previous page, right? What does normal heparin do?
Yes, you're
Enhances
correct.
antithrombin 3.
Yeah, yes, you're correct.
So heparin heparin enhances antithrombin's effect. And if you remember the UWorld image, antithrombin was the green square, heparin will bind all around it and stuff. So here they're saying normally directly it doesn't have a effect any on the PT or PTT or the thrombin time, but it diminishes the increase in PTT.
Okay, and by giving heparin, actually we measure the PTT pathway, right? So if we give heparin, so normally after giving heparin, PTT should go up, right? Because coagulation factors are consumed. Coagulation factors go down, so that's why PTT goes up. But if we don't have antithrombin 3, which is antithrombin deficiency, so after giving heparin, PTT is not going up properly. That's what they're trying to say.
Yes, exactly. And that was an MBME question.
This is a question that after giving heparin dose, normally if we give heparin someone, so we monitor heparin with PTT, right? PTT should go up in a normal person. But in antithrombin deficiency patients, after giving heparin, the PTT levels are not going up. it diminishes the increase in PTT. Is it so?
Yeah, I think so.
Yeah,
You're
yeah.
saying it exactly.
Yeah, makes sense what you're saying.
And the question was in a patient, we used heparin, but PTT doesn't increase. What was the answer? What is the problem? So the patient has antithrombin deficiency.
Makes sense. Yep.
Nice.
Yeah. Thank you so much.
Thank you. Thank you, Nino. Thank you, everyone.
Thank you. No, you answered your own question, so I didn't do anything.
You answered, yeah.
Okay. Thank you. Yeah, so the let me see if I understood correctly. So normally by giving heparin, we are creating anticoagulation, correct? So PTT should rise. After giving heparin, if there is an antithrombin deficiency, PTT will not rise. Is that correct?
Yeah. Yeah, in those patients who have antithrombin deficiency, after giving heparin, PTT is not increased to that much extent. You can say that.
Okay, cool. All right, so yeah, no direct effect on PTT or thrombin time, but it diminishes the increase in PTT following standard heparin dosing. So it can also be acquired where there's a renal failure or nephrotic syndrome where we lose this antithrombin in the urine and causes decreased inhibition of factors 2A and 10A. Okay, cool. Next, we have factor 5 laden. There's a production of mutant factor 5 where guanine is converted to adenine by a DNA point mutation. So ARG506 GLN mutation near the cleavage site. So this factor, mutant factor 5, is resistant to degradation by activated protein C. Complications include DVT, cerebral vein thrombosis, and recurrent pregnancy loss. DVT, cerebral vein thrombosis, and recurrent pregnancy loss. So yeah, we discussed this briefly earlier. So factor 5, what is it? It's the production of a mutant factor 5. How is it mutated? Guanine is converted to adenine by a DNA point mutation. The net result is an arginine 506 GLN mutation near the cleavage site. So now we have this factor that is resistant to degradation by activated protein C. So complications include DVT, cerebral vein thrombosis, and recurrent pregnancy loss. So next you have protein C or S deficiency. Here there is decreased ability to inactivate factors 5A and 8A. So factors 5A and 8A are now notorious. So they increase the risk of warfarin-induced skin necrosis in these patients. This comes up in questions. Together, protein C cancels and protein S stops coagulation. So if there's no stopping, then there's too much. It's going to be procoagulant. Then prothrombin G20210A mutation. This is a point mutation in the 3' untranslated region. So there's increased production of prothrombin, so increased plasma levels and venous clots. Point mutation in 3' untranslated region. So there's increased production of prothrombin. And there's increased prothrombin and increased plasma levels and venous clots. Increased plasma levels of prothrombin and increased venous clots. So this is a gain of function mutation that occurs as a result of substitution of an adenine for guanine. Yeah, adenine for guanine at position 20210 of the prothrombin gene results in increased circulating concentrations of prothrombin, which predisposes to venous thromboembolism. Okay. Okay. Are we good? Hereditary thrombophilias. Okay. So next we have blood transfusion therapy. We transfuse with either packed RBCs, platelets, FFP, or prothrombin complex concentrate, cryoprecipitate, and albumin. So dosage effect by giving packed RBCs increase hemoglobin and oxygen binding or carrying capacity. increase hemoglobin 1 grams per deciliter per unit, and increase hematocrit of at least approximately 3% per unit. Where do we use this? In acute blood loss and severe anemia. So it's increasing hemoglobin and thereby increased oxygen carrying capacity, increase hemoglobin levels, and increasing hematocrit, which is approximately 3% per unit. The next we have platelets. What is the dosage effect? It increases platelet count by approximately 30,000 microliters per unit. So approximately 5,000 per millimeter cubic per unit. So use is stop significant bleeding. So in the case of thrombocytopenia and qualitative platelet defects. Then FFP and PCC, this comes up. So it increases coagulation factor levels. FFP contains all coagulation factors and plasma proteins. PCC generally contains factors, this is important. PCC contains factor 2, 7, 9, and 10, as well as protein CNS. So concentrate, so it's concentrated factors specifically for 2, 7, 9, and 10, as well as protein CNS. A clinical use used in cirrhosis and for when immediate anticoagulation reversal. Okay. Then next is cryoprecipitate. This contains fibrinogen, factor 8, 13, VWF, and fibronectin. So yeah, fibrinogen, factor 8, factor 13, von Willebrand factor, and fibronectin. Clinical use, coagulation factor deficiencies involving, so used specifically for coagulation factors deficiencies involving fibrinogen and factor 8. Okay, next we have albumin. Albumin dose effect is increased intravascular volume and oncotic pressure. So where would we use this? In post-paracentesis and therapeutic plasmapheresis. So blood transfusion risks include infection transmission, which is low, transfusion reactions, transfusion-associated circulatory overload, transfusion-associated circulatory overload, okay, so which is known as TACO, volume overload causing pulmonary edema and hypertension. Then TRALI, which is transfusion-related acute lung injury. There's hypoxia and inflammation leading to non-cardiogenic, makes sense, pulmonary edema and hypotension. Can also cause iron overload and can lead to secondary hemochromatosis. Yep. And then hypocalcemia, because citrate is a calcium chelator. I think you all had a question on this. Hypocalcemia, because citrate is a calcium chelator, and hyperkalemia, RBCs may lyse in old blood units. Yeah, I think we saw this somewhere before, right? Stored blood, hyperkalemia.
Was
Is it another condition? We saw it before in general for a system, before we did systems.
in immuno, I guess, stored blood cause producing cytokine and some hypersensitivity reaction, something.
Let me see. So it's stored blood. They said they use some words, stored. I don't know what to search. It's not pulling it up. Stored blood products.
Local reduction of blood product. Yeah, it's 112.
Nice. So we have to do leukoreduction. What was it? IgA?
That was no febrile non-hemolytic transfusion reaction because of cytokine.
Okay, nice. This one, right? Febrile non-hemolytic reaction because of cytokines are accumulating in storage of blood products. Okay. Nice. Thank you.
Welcome.
So this now we saw what we saw was hyperkalemia because of stored blood will accumulate potassium, causing hyperkalemia after reaction. This is febrile non-hemolytic transfusion reaction because of cytokines which are in the stored. Okay. All right.
Yeah, sorry, and this is the new para. Can you go with the thing last paragraph after albumin?
So it says blood transfusion risks include infection transmission, which is low, transfusion reactions, which all the transfusions we saw in immunology, transfusion associated circulatory overload, which is TACO, then TRALI, which is transfusion related acute lung injury, then iron overload, hypocalcemia, and hyperkalemia. So then it says, what is TACO? Transfusion associated circulatory overload. So we have a volume overload causing pulmonary edema and hypertension. TRALI, which is transfusion related acute lung injury causing hypoxia and inflammation, leading to non-cardiogenic pulmonary edema and hypotension. Iron overload causing secondary hemochromatosis, hypocalcemia because citrate is a calcium chelator. And then hyperkalemia, why? Because RBCs may lyse in old blood units and cause hyperkalemia.
Okay, thank you.
You're welcome. So next we have leukemia versus lymphoma. What is leukemia? This is lymphoid or myeloid neoplasm with widespread involvement of bone marrow. Tumor cells are usually found in peripheral blood. Lymphoma is a discrete tumor mass arising from lymph nodes itself. So that's a lymphoma. Lymph nodes, so lymphoma. Variable clinical presentation arising in atypical sites and leukemic presentation can be there. So leukemia is for bone marrow, lymphoma is from the lymph nodes. Then we have Hodgkin's versus non-Hodgkin's. Hodgkin's, both may have constitutional B signs. Yeah, common to both. Both may have B signs. This comes up in questions. So what they give it in the stem. So what are the B signs? Low-grade fever, night sweats, and weight loss. So Hodgkin's, this is localized single group of nodes with contiguous spread. Strongest stage is the strongest predictor of prognosis. So this is localized and single group of nodes with contiguous spread, and it has better prognosis. Here we have multiple nodes involved. Extranodal involvement is common and non-contiguous spread, which means it's not next to each other. It can go anywhere. So multiple lymph nodes are involved. Extranodal involvement is common, non-contiguous spread, and worse prognosis. So this is worse. Then characterized by Reed-Sternberg cells. Non-Hodgkin's may involve B cells and rarely of T cell lineage. Bimodal distribution, we saw it in statistics. So there's young adults and then more than 55 years of age. This can occur in children as well as adults. Hodgkin's is associated with EBV. This may be associated with autoimmune diseases and viral infections like EBV, HIV, and HTLV. So EBVs can cause either Hodgkin's or non-Hodgkin's. So now first specifically for Hodgkin's, this contains Reed-Sternberg cells, which are, what are these? These are distinctive tumor giant cells with the bilobe nucleus, with the two halves as mirror images, so the owl-eye appearance. So we're seeing two over here, so that's owl-eye appearance. RS cells are CD15, this comes up in questions, high yield. These are CD15 positive and CD30 positive B cell origin, two owl eyes, so 15 into 2, 30. To remind us, CD15 positive and CD30 positive. So subtype, we have 4 subtypes. This is nodular sclerosis, mixed cellularity, lymphocyte rich, and lymphocyte depleted. Nodular sclerosis is most common. Mixed cellularity, we have eosinophilia, which is seen in immunocompromised patients. Lymphocyte rich is best prognosis. The rich have better bank accounts, so best prognosis. Lymphocyte depleted, worst prognosis. The poor have worse bank accounts, seen in immunocompromised patients. So that's Hodgkin's lymphoma. So next we have non-Hodgkin's.
I'm sorry, can you repeat the types, the subtypes of Hodgkin's?
Sure, it's nodular sclerosis, mixed cellularity, lymphocyte rich, and lymphocyte depleted. Nodular sclerosis is most common. Mixed cellularity, we see eosinophilia, seen in immunocompromised patients. Lymphocyte rich, best prognosis, the rich have better bank accounts, and lymphocyte depleted, worse prognosis because the poor have worse bank accounts. And this is seen in immunocompromised patients as well. So mixed cellularity and lymphocyte depleted in immunocompromised patients. Nodular sclerosis is most common overall. Lymphocyte rich, best prognosis. Okay.
Thank you.
You're welcome. So next we have non-Hodgkin's lymphoma. Subtypes here, we have neoplasms of mature B cells. So as we saw in the main table, it can be B cells or T cell lineage. Most commonly, majority is B cells, rarely T cells. So here we're seeing neoplasm of mature B cells and neoplasm of T cells. So B cells, we have Burkitt's, diffuse large B cell lymphoma, follicular, mantle cell, marginal, and primary CNS lymphoma. T cells is ATC, adult T cell lymphoma, and mycosis fungoides or Sézary syndrome. And these are rare. Okay, so let's see these. Burkitt's lymphoma occurs in adolescents or young adults. Burkitt lymphoma, to remind us, is more common in kids. Genetics 8-14, translocation of c-MYC8 with the heavy chain IgG 14. Yeah, these I find it hard to stick. So if anyone has any mnemonics, I think this we can say Burkitt looks like an 8, so 8-14.
Or you could actually just pronounce it as Burkitt, not Burkitt.
Ah, nice. Thank you. Burkitt and Burkitt. So to remind us, it's in 8-14, and kid, it's more in common in kids. Nice, thank you. So this is a translocation of c-MYC and HIV. I'm sorry. Not what I was thinking. So c-MYC and heavy chain IgG. So common starry sky appearance, star burst, sheets of lymphocytes with interspersed tingible body macrophages. Yep. So they usually won't say starry sky appearance. They say sheets of lymphocytes with interspersed tingible body macrophages, which is seen here. Very blurry. Okay. Associated with EBV. Burkitt's EBV. Jaw lesion, which is an endemic form in Africa. Pelvis or abdomen in sporadic form. Jaw lesion which is an endemic form in Africa, and pelvis or abdomen in the sporadic form. So this is in the jaw. So this is endemic form. Okay, next we have diffuse large B cell lymphoma. So Burkitt's or Burkitt lymphoma. This is diffuse large B cell lymphoma, usually in older adults and 20% in children. Here there's mutations in BCL2 and BCL6. BCL2, not helpful because it's B cell. Anyway, BCL2 and BCL6. Most common type of non-Hodgkin's lymphoma in adults. Diffuse large B cell lymphoma. We saw this in some other context, right? Diffuse large B cell lymphoma in micro or something. Anyone?
Yesterday, we saw T cell lymphoma in celiac disease, and diffuse large B cell lymphoma is associated with, I think, EBV.
Crohn's or something. Let me see.
No, a celiac disease, we have T cell lymphoma.
Celiac disease associated with TCLB. Okay, T cell lymphoma. Diffuse large B cell lymphoma.
Hashimoto thyroiditis also, right?
Yeah, that's why we saw it day before yesterday. Yes, nice. That's why we saw it. Thank you. Hashimoto's thyroiditis is associated with increased risk of primary thyroid lymphoma, typically diffuse large B cell lymphoma. Did they mention it here? No, they didn't. Okay.
Sorry, can you take that again? I didn't hear you.
So we were just recalling, we think we saw it day before yesterday, Hashimoto's thyroiditis. They have increased risk of primary thyroid lymphomas. And over there, they said typically diffuse large B cell lymphomas. So that's yep. So over here, it says Hashimoto's is a chronic autoimmune thyroiditis, HLA-DR3, and increased risk of primary thyroid lymphomas, typically diffuse large B cell lymphoma. You're You're welcome. So what else? Where else did we see it? Diffuse large cell. Okay, this is just doing individual searches now. Okay, never mind. Okay. So here I would add Hashimoto's. All right, so next we have follicular lymphoma. This occurs in adults. T14, 18 translocation of heavy chain IgG on 14 with BCL2 18, 14, 18, 14, 18. F for follicular, F for 14. So that's a start, but any mnemonics? Okay, so there's an this indolent course.
I think we can just relate the fact that diffuse B-cell lymphoma and follicular lymphoma are related to thyroid diseases, and we know that both have an issue with BCL2. So since the follicular starts with an F, you can think of the 14 being the first. That's the same one. We can link that one with the same one that has the effects in Burkitt's. So it will be T14 with the BCL2 because follicular lymphoma and B-cell lymphoma have issues with BCL2.
Nice. So follicular and diffuse both have BCL2 in commonality, and both are associated with thyroid. So to recall, follicular carcinoma of thyroid, and this is Hashimoto's association. Okay, nice. Okay, so follicular lymphoma seen in adults, T14, 18 translocation of the heavy chain IgG14 and BCL2, 18, which is common to both. Okay, thank you, Doc. So a presentation, there's an indolent course with painless waxing and waning lymphadenopathy. BCL2 normally inhibits apoptosis. So yeah, it's an anti-apoptotic factor, so it makes sense it's affected in both of these. So waxing and waning is usually mentioned in questions. So that is the buzzword for follicular lymphoma. And BCL2 normally inhibits apoptosis, so it makes sense that whenever there's BCL2 issue, there's mutations. I mean, there's lymphomas. Next, we have...
Sarah, may I?
Yes, sure.
Another one. Fall, so fall, the school starts, right?
Mm-hmm.
So high school starts, so usually around 14, and then the 18 seniors, leave. Age
Nice.
14 and age 18. And most kids are wearing heavy chains, right?
Nice.
And they think they will never die, so anti-apoptotic. You're young and you just think you'll never die. And waxing and waning, you just low free, you just go around here, there, right?
Nice.
So, yeah.
Loafering, so here and there, so waxing and waning. Yes, that's nice. Thank you so much. That's really good. So fall, think fall, follicular, think fall. So reminders of school. So teenagers, 14 to 18. Teens wear heavy chains in the neck. They think they never die. So apoptosis to remind us. And they loafer around. So waxing and waning. Nice. Thank you. So next we have mantle cell lymphoma. So this is adult males. So man. So it's more common in males. Here we have 11, 14 translocation. So translocation of cyclin D1 on the 11 and heavy chain IgG on 14. So heavy chain IgG is common to the Burkitt's, this one and this one. Okay. So here it is cyclin D1, 11. So these are very aggressive. Patients typically present with late stage disease. So yeah, heavy chain IgG 14 as well as CD5 positive. Mantle cell lymphoma. 11.
Yeah, the age is around 11 to 14 now. So kids are, very mental at this age.
Okay, yeah. 11, 14 kids are mental.
Oh, it never stops. It's further too.
11:14. So just to remind us, mantle. I used to have lots of mnemonics, but I don't remember anymore. 14. So this is the T. I don't know. Anyway. All right. So then we have marginal zone lymphoma. This is in adults. So this is T1118. Associated with chronic inflammation. So with Sjogren syndrome, chronic gastritis, malt lymphoma, and may
Sorry, can I say something? I don't know if that's gonna work for the mantle. We already know this is the mantle cell lymphoma. We already know that it's adult males over females, and then men have 3 legs, their dick and their 2 legs. So we know this is T111 is left to the 4. I don't know.
Okay, nice. Thank you. Yeah, that makes sense. So remember 11, 11 and 11, 11, 1 and 4. Okay. Okay, cool.
Can you repeat Sarah's?
This is a little adulterated, so we're all adults, so it's okay. So we're saying mantle cell lymphoma. So men, so we're talking about man, right? Males. So they have 2 legs and their penis. So there's 3. Think of that. So that should remind us that it's 11:14.
Okay.
So this 3, which is 3 legs in man. So just to trigger a memory that this is 1114.
Oh, okay. Nice. Thank you.
No problem. Okay, so next we have marginal zone lymphoma. So adults, so T1118. And so this also man. So I guess marginal starts with A. So it starts with 111, but then here it is 8. Okay, so associated with chronic inflammation and example Sjogren syndrome, chronic gastritis like malt lymphoma may regress with H. pylori eradication. So once the H. pylori is eradicated, it actually regresses and goes away. It's a lymphoma though, so that's pretty cool. So next we have primary CNS lymphoma. So this is also seen in adults. This is EBV related, associated with HIV and AIDS. So this is considered an AIDS defining illness. We've seen this when we did micro. So primary CNS lymphoma is an AIDS defining illness, variable presentation with confusion, memory loss, seizures, CNS mass, which is often single ring enhancing lesion on MRI in immunocompromised patients. Single ring enhancing lesion, which needs to be contrasted with toxoplasmosis because that is multiple, right? Multiple ring enhancing lesions. But it still needs to be distinguished from toxo by a CSF analysis or other lab results. Okay, then we have neoplasms of mature cells, which is adult T cell lymphoma in adults caused by HTLV associated with IV drug use. Adults present with cutaneous lesions common in Japan, so T cell T for Tokyo, and West Africa as well as the Caribbeans. So lytic bone lesions and hypercalcemia. Lytic bone lesions, hypercalcemia, and cutaneous lesions. So then we have mycosis fungoides or Sézary syndrome. This is also in adults. So what is mycosis fungoides? It's skin patches and plaques, cutaneous version of this T cell lymphoma, characterized by atypical CD4 plus cells with cerebriform nuclei and intraepidermal neoplastic cell aggregates, which are Potter's microabscesses. One more time, these are skin patches and plaques. Cutaneous T cell lymphoma, it's characterized by atypical CD4 plus cells with cerebriform nuclei and intraepidermal neoplastic cell aggregates. So fungoids looks like fungal infection, but it's not. So skin patches and plaques, cutaneous T cell, yeah. CD4 cells are involved. They have cerebriform nuclei and intraepidermal neoplastic cell aggregates, meaning inside the epidermis, the cell aggregate, and these are known as Pottier microabscesses. It can progress to Sézary syndrome, which is T cell leukemia. So when from the skin it goes to becomes a bone marrow issue, that's T-cell leukemia. So mycosis fungoides starting with the skin, cutaneous version. Then if it goes to the bone marrow, now it's become Sézary syndrome. So these are mature T-cell issues. Okay.
Can you do top quiz on this page, please? It's so.
Which one?
Quickly. Can you do top quiz on this page?
Top quiz?
Yes, on this page. Just on this page. It's very hard.
Oh, you mean pop quiz? Okay, yeah. All right. So Burkitt's lymphoma. Okay. Do you want to see, or I'm just asking? Ready?
Ready.
All right. So let's start with primary CNS lymphoma is related to what? Which viruses?
HIV.
EBV.
Yes, nice. HIV and EBV. What about the virus associated with adult T-cell lymphoma?
That's it.
HTLV.
HTLV.
Yes, nice. What's the translocation found in follicular lymphoma?
1418.
1418.
Nice. So translocation of what occurs?
Heavy chain wearing in neck, thinking
and
of
BCL2.
Nice. Heavy chain IgG 14 and BCL2 on 18. What about the translocation on diffuse large B-cell lymphoma?
1118.
Nope.
BCL
1114.
Nope.
Mutations in BCL2 and
BCL2,
Oh, BCL2, BCL2.
That's a trick question. There's no translocation. There's a mutation in BCL2 and BCL2.
Diffuse.
Oh yeah, that's the one with the thyroid. Yeah.
Yes. Yes. So it's a
Hashimoto.
B-cell in BCL2. Okay. Next, what's the translocation in Burkitt's lymphoma?
It looks
That's
it's right.
Burkitt's 814.
Yes. Translocation of what things?
Simic
Simic and IgG.
14, yeah.
Nice. What's the non-Hodgkin's lymphoma you would most commonly see in a child?
Non-Hodgkin's Burkitt's.
Burkitt's, nice. What is the most common type of non-Hodgkin's lymphoma in adults?
Diffuse large B-cell lymphoma.
Nice.
What is this? I didn't hear. What was that? What's that?
It's the diffuse large B-cell is the most common overall in adults.
Okay. Yeah.
Okay, what's the thyroid association with diffuse large B-cell lymphoma?
Hashimoto.
Nice. What's the histology in Burkitt's lymphoma?
Starry sign.
Site with interspersed tangible body macrophages.
Wow. Excellent.
With EBV.
Yes. Starry sky appearance, starburst, so sheets of lymphocytes interspersed with tangible body macrophages and associated with EBV. The pelvis or abdomen is seen in the endemic form in Africa. True or false?
Yeah.
False.
Yes. So what's the true fact?
Jaw.
Yes.
Jaw.
Nice.
What is the true fact?
Jaw lesion for endemic form, pelvis and abdomen in sporadic form.
Okay. Thank you.
Waxing and waning presentation is seen in which lymphoma?
Follicular lymphoma.
Follicular.
Nice. Malt lymphoma is associated with?
Sjogren's syndrome, Malt lymphoma, and one other. Chronic gastritis.
Yep. Associated with which lymphoma?
Marginal zone lymphoma.
Marginal zone.
Malt lymphoma.
Yes.
Malt lymphoma.
Yes. Marginal zone lymphoma is associated with malt lymphoma. What's a lymphoma that will regress with eradication of a particular infection? So dash lymphoma.
Same thing. Malt lymphoma.
Dash eradication.
Malt lymphoma.
H. pylori eradication, right?
Yes. Marginal zone lymphoma. Yes. Okay, so patient had a very aggressive presentation and presented at the late stage with a non-Hodgkin's lymphoma. Which type of lymphoma do you think it is?
Mental.
Mantle cell.
Mantle is mental, so it's like very aggressive.
Okay.
What's the other thing we said with mental? Anyone remembers? You said yesterday or in the morning something. Mental lymph nodes, submental are associated with or seen in first
Tongue.
Tongue cancer,
tongue.
submental.
Yes, tongue cancer. It's not on this page, it was just tangent question. Yes. Tongue carcinoma, squamous cell tongue spreads to the submental.
The mnemonic was like, who is outspoken, they are mental, right?
Yeah, exactly. Speak too much with that tongue, so it goes to the submental. It becomes a carcinoma and it goes to that submental. Talk too much, then it's appear mental. Yeah, that was the mnemonic. We said in Urdu. Yep. Okay. What are the 4 types of Hodgkin's lymphoma? Subtypes.
The
Nodular sclerosis, lymphocyte rich, lymphocyte depleted, and mixed cellular.
Yes. Nodular sclerosis, mixed cellularity, lymphocyte rich, lymphocyte depleted. Which has the worst prognosis?
The depleted one.
Lymphocyte
Depleted.
Yes. Eosinophilia is seen in nodular sclerosis. True or false?
False.
Seen in where?
Mixed.
Yes. What are the markers of Reed-Sternberg cells?
The CD15, CD30.
Yes, nice. Actually, no, let me ask a few more about the mature T cells. So what are the mature T cell lymphomas?
The what?
Which are rare. T cell
STLV.
non-Hodgkin's lymphomas.
And this
STLV,
mycosis
adult T lymphoma.
Yes, adult T cell lymphomas and mycosis.
Okay,
Mycosis and Sézary syndrome.
Yes. What are Potter's microabscesses?
What are what?
Potter's microabscesses.
Oh,
The mycosis fungoides or something.
yeah.
correct. Something intraepidermal. What is
Remember
that?
the description.
Yes. So we see 3 things: atypical CD4 plus cells, cerebriform nuclei, intraepidermal neoplastic aggregates.
Right.
Yeah, I think we're done. All right, we're ready for exam.
Thank you.
All right, thank you. That was fun. Moving on, next we have plasma cell dyscrasias, a group of disorders characterized by proliferation of a single plasma cell clone, typically overproducing a monoclonal immunoglobulin, also called a paraprotein. So these are a group of disorders characterized by proliferation of single cell plasma cell clone, typically overproducing a monoclonal, so single clone of immunoglobulins, which are also known as paraproteins. Seen in older adults, so screen with the serum protein electrophoresis. It shows M spike. I think this we're familiar, M spike for overproduction of monoclonal IgG, serum immunofixation, and serum free light chain assay. I think this is an NBME question. They gave this thing and they asked for the diagnosis. Okay. So seen in older adults, how do we screen? We screen with protein electrophoresis, which will show an M spike, serum immunofixation test, or serum free light chain assay. Urine protein electrophoresis and immunofixation are required to confirm urinary involvement. So a urinary dipstick only tests albumin. So urine protein electrophoresis and immunofixation is required to confirm urinary involvement. Diagnostic confirmation is with bone marrow biopsy. So screening, we have 3 tests: serum protein electrophoresis, serum immunofixation, and serum free light chain assay. For urine test, urine confirmation or urine involvement, we have 2 options: urine protein electrophoresis and urine immunofixation. Then for confirmation, we need to do bone marrow biopsy. So peripheral blood smear may show rouleau formation, which is seen here, which is a stack of coins. And yeah, RBC stacked like a poker chips. Okay, so then multiple myeloma. So the subtypes we have, or the different plasma cell dyscrasias are multiple myeloma, Waldenstrom's macroglobulinemia, monoclonal gammopathy of undetermined significance, and then we go to the next one, which is myelodysplastic. All right, so let's see what are these dyscrasias. Multiple myeloma, we have overproduction of IgG, which is the most common, followed by IgA and IgG light chains. Clinical features are CRAB. What is CRAB? C for hypercalcemia. Okay, no worries. So yeah, CRAB, so hypercalcemia, increased cytokine secretion, which is IL-1, TNF-alpha, rank L by the malignant plasma cells. And if rank L is excessive, then that's going to cause increased osteoclastic activity, which explains the hypercalcemia. R for renal insufficiency, A for anemia, and D for bone lytic lesions, which are punched out on X-ray, and these cause back pain. What are the complications? We see increased infection risk and primary amyloidosis, AL. Urinalysis may show IgG light chains, Bence-Jones proteinuria with a negative urine dipstick. Yeah, because as we said, urine dipstick will only detect albumin. Bone marrow biopsy shows more than 10% monoclonal plasma cells with clock phase chromatin and intracytoplasmic inclusions containing IgG. Clock phase chromatin we also saw somewhere else today. Does anyone remember?
Yeah, the plasma cells, right? B cells.
Yeah, plasma cells actually. All plasma cells have clock phase chromatin. We saw it when we did just the general anatomy, the cells. Yes. So it's for this one actually. So plasma cells have clock phase chromatin. So multiple myeloma shows more than 10% monoclonal plasma cells with clock phase chromatin and intracytoplasmic inclusions containing IgG. So these. Okay. Then next we have Waldenstrom's.
I don't know. Can anybody remember how there was a question on UWorld that the way the clock face was described, something about close to the nucleus there's some is it
Golgi clearing, I think you're talking about?
Yeah, that stuff, yeah.
So that was a perinuclear clearing, I think they mentioned. Let me pull it up. We saw it earlier today. So either they gave us the cells, perinuclear clearing with Golgi apparatus, or they said, or they gave us the histo picture. Here they described no, they didn't give the histo on this question. I'll get back to the explanation. Okay, this is E-wings. Okay. So large, they would probably describe it as if they don't give us the histo image, they will be distinguished by the abundant basophilic cytoplasm, perinuclear paleness, and nuclei with a clock face, or they would say peripheral chromatin. So abundant basophilics, so if they want to avoid all the buzzwords, they would use abundant basophilic cytoplasm, perinuclear paleness with peripheral nuclei. Does that answer your question?
Yes.
Cool. Thank you. That was a good question, actually. Basophilic cytoplasm, perinuclear paleness, peripheral nuclei, peripheral chromatin, nuclei with peripheral chromatin. Okay, cool. All right, so that was describing the clock phase chromatin in a multiple myeloma plasma cell. So next we have Waldenstrom's macroglobulinemia. This is overproduction of IgM. So M for macroglobulinemia because IM is the largest IgG. Clinical features include anemia, constitutional B symptoms. What are the B symptoms?
Low-grade fever, night sweats.
Yes.
And something else. One more thing I can't remember. Fatigue.
Fever, night sweats, and weight loss.
Weight loss, yeah.
Fever, night sweats, and weight loss. Okay. So, yeah. So clinical features include anemia, constitutional B signs and symptoms, lymphadenopathy, hepatosplenomegaly, and hyperviscosity. So 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 this can lead to headache, blurry bleeding, blurry vision, and ataxia, and also peripheral neuropathy. Fundoscopy will show dilated, segmented, tortuous retinal veins, sausage link appearance. Dilated, segmented, sausage link, tortuous retinal veins, sausage link appearance. So bone marrow biopsy shows more than 10% monoclonal B lymphocytes with plasma cell features. So lymphoplasmacytic lymphoma and intranuclear pseudo-inclusions containing IgM. So the difference here, they also show more than 10% monoclonal B lymphocytes. This will show plasma cells. This is B lymphocytes with plasma cell features. Lymphoplasmacytic lymphoma and intranuclear pseudo-inclusions containing IgM. So basically intranuclear pseudo-inclusions containing IgM. Okay. Then monoclonal gammopathy of undetermined significance. This is overproduction of any IgG type. M spike is less than 3. I think this came up in an NBME question or somewhere. I remember we saw this before. So if the M spike is less than 3 grams, that is MGUS. Asymptomatic, no CRAB findings, 1 to 2% risk per year of progressing to multiple myeloma. So this is the baby of multiple myeloma, monoclonal gammopathy of undetermined significance. So M spike is there, but less than 3. Here M spike was really high. Okay, so asymptomatic, 1 to 2% risk of progressing to multiple myeloma. Bone marrow biopsy shows less than 10, yeah. So more than 10 is multiple myeloma, less than 10 monoclonal plasma cells. Okay, so what are we seeing here in B was the punched out lytic lesions, I believe, yeah. Punched out lytic lesions in multiple myeloma. This was clock phase chromatin with the plasma cells, and A was rouleau formation seen in common to all actually. Okay.
Rolex formation in multiple myeloma, no?
Sorry?
Rolex formation in multiple myeloma only, right?
Oh, it says over here, right? So I think it's common to all.
Mm-hmm.
Yeah, it's kind of like sticky RBC, so they stack. Okay, so main things, single plasma cell clone, typically overproduction of monoclonal immunoglobulin called paraprotein, seen in older adults, so all older. Again, we said screening tests are 3, serum protein electrophoresis, serum immunofixation, and serum free light chain assay. Urine tests are urine electrophoresis, urine protein electrophoresis, or urine immunofixation for urinary involvement, confirmation with biopsy. Peripheral smear shows rouleau formation, which is RBC stacked like poker chips. Multiple myeloma, there's overproduction of IgG, Waldenstrom overproduction of IgM, and monoclonal gammopathy is IgG type, any IgG type, any immunoglobulin, okay. So here features are CRAB, which is hypercalcemia, renal insufficiency, anemia, bone lytic lesions. Complications, increased infection, that makes sense, and primary amyloidosis. Benz-Jones proteinuria and negative urine dipstick. Bone marrow, more than 10% monoclonal plasma cells. And then Waldenstrom. So another key difference is this is intracytoplasmic inclusions containing the IgG. This is intranuclear. So yeah, here we're seeing intracytoplasmic inclusions with immunoglobulin is multiple myeloma. Intranuclear pseudo-inclusions containing IgM is Waldenstrom. So yeah, here, what are the symptoms? Anemia, constitutional B symptoms, lymphadenopathy, hypersplenomegaly, hyperviscosity syndromes, symptoms, and peripheral neuropathy. So this unique feature is fundoscopy, dilated segmented tortuous retinal veins, sausage link appearance. And then this is probably just to rule out less than 3 M spike and no CRAB. Then there's a risk of progressing to multiple myeloma. Okay, next we have myelodysplasia.
So in both conditions, we have 10 greater than 10%. But what is in MGUS
is
greater
less
than
than
10%? Less than 10% monoclonal plasma cells.
Yeah.
Multiple myeloma greater than 10% monoclonal plasma cells. And
Mhm.
Waldenstrom, we have greater than 10% monoclonal B lymphocytes with
Lymphocytes
plasma
with
cells.
plasma cell features.
Okay, so these are not monoclonal plasma cells, right? These are B cells.
Yeah, they're not fully formed plasma cells as much as multiple myeloma, I think.
There was an
Yes.
NBG question. If you go up, based on the peaks, you know, they had asked in
Yeah.
the gamma, which one was which one in M spike? They asked which is the particular protein you find.
Yeah. Yes.
So
They
the
gave the
answer is
spike
gamma.
and they asked which protein. It is gamma. Yes. Yep. This is a gamma globinopathy. Yes.
Thank you.
Thank you. So next we have myelodysplastic syndromes. These are stem cell disorders involving ineffective hematopoiesis, leading to defects in cell maturation of non-lymphoid lineages, bone marrow blasts, which are less than 20% versus more than 20% in AML, caused by de novo mutations or environmental exposure. What is the environmental exposure? Radiation, benzene, and chemotherapy. Risk of transformation is high to AML. More common in older adults. One more time, stem cell disorders involving ineffective hematopoiesis. So if hematopoiesis is ineffective, it leads to defects in cell maturation of non-lymphoid. So because this is myeloid, by definition, non-lymphoid lineages, bone marrow blasts are less than 20%. Less than 20% to differentiate from AML, where we have more than 20% blasts. Caused by de novo mutations or environmental exposure like radiation, benzene, chemo. Risk of transmission to AML, more common in older adults. What's important to note here is the pseudo-Pelger-Hewitt anomaly. Neutrophils with bilobe nuclei. Yeah, neutrophils are usually more than 3 to 5 lobes. So when we see bilobe nuclei, that's an anomaly. So these are pseudo-Pelger-Hewitt anomaly, bilobed or duet nuclei. Hewitt has a duet. So associated with myelodysplastic syndromes or drugs which are immunosuppressants. So yeah, showing the bilobe nuclei. Pseudo-Pelger-Hewitt anomaly. Okay. Moving on, now we have leukemias. Overview, leukemias are lymphoid and myeloid. And then we go into myeloproliferative, and so on. All right, so let's see. What are leukemias? So we said they can be lymphoid or myeloid. Leukemia, we said bone marrow problem, right? So unregulated growth and differentiation of WBCs in the bone marrow lead to marrow failure. So that can lead to anemia, decreased RBCs, infections because of decreased mature WBCs, hemorrhage, decreased platelets, usually presents with increased circulating WBCs, which are malignant leukocytes in blood, although some cases present with normal or decreased WBCs. So one more time, usually presents with increased circulating WBCs, which are malignant leukocytes in blood, although some cases present with normal to decreased WBCs. Usual presentation is increased circulating WBCs, which are malignant leukocytes. So they won't kill the infections or they won't kill the organisms, but they're just malignant leukocytes floating around. Okay, so that's the common features for leukemia. Leukemic cell infiltration of liver, spleen, lymph nodes, and skin. Leukemia cutis is possible. So liver, spleen, lymph nodes, and skin. Leukemic infiltration. Okay, so broad categories, we have lymphoid and myeloid. Lymphoid and myeloid. So lymphoid, we have ALL or lymphoma, CLL or SLL, and hairy cell leukemia. In myeloid, we have AML and CML. Some more, okay. So these are myeloproliferative. So that's the next category, okay. So leukemias are, okay, lymphoid versus myeloid. What are the lymphoid? Now ALL first, ALL or lymphoma. This most frequently occurs in children and less commonly in adults. Adults have worse prognosis. T-cell ALL can present as a mediastinal mass presenting like an SVC-like syndrome. Mediastinal mass, so presenting like an SVC-like syndrome. Pop quiz, SVC syndrome versus brachiocephalic syndrome, which is unilateral, which is bilateral.
SVC is bilateral.
Nice. Yes. SVC is bilateral because it's before the branching. Brachiocephalic will be unilateral. Is that on the book? We didn't do it yet. It was just a recall from a question.
It's in the respiratory. Last page.
Okay, this is what we're doing now. I should back it out. So this lymphoma can present as SVC syndrome.
Especially ALL. SVC here.
Yep. So this will be bilateral. Unilateral is if it occurs after the branching. So I think that was not on first aid. Was it here mentioned here? Yeah, brachiocephalic is unilateral versus SVC is bilateral. So yeah, this can malignancy as like a mediastinal mass and pancreas tumor can present as SVC. So that's our correlation we're making. Lymphoma or ALL can cause a mediastinal mass and present as SVC syndrome. Okay. So yeah. T cell ALL can present as a mediastinal mass presenting as SVC syndrome, which will be bilateral flushing and everything. So it's associated with Down syndrome. Downs, we saw this connection before. Downs with ALL. Yep. Then peripheral blood and bone marrow, which have super high lymphoblasts, which is seen here. So lots of large cells. So they're immature and they are lymphoblasts. TDT positive, which is a pre-marker, which is a marker of pre-T and pre-B cells. So TDT, this they usually mention in the STEM. TDT positive and CD10 plus positive, which are marker of pre-B cells. Most responsive to therapy may spread to CNS and testes. T1221, another 1221 has better prognosis versus T922, which is the Philadelphia chromosome with the worst prognosis. So 1221 has better prognosis. So 1221, better prognosis. 922 is Philadelphia chromosome, which is the worst prognosis. Okay.
Are associated with this. If B cells are involved, then it's CD10 positive, like TDT positive and CD10, 11, 19, 13. These are more than 10. And if it's pre-T cells, then it's TDT positive and CD like 2, 3, 4, something like before then.
Single digits.
Single digits, right?
Yes, single digits for T cells, double digit for B cells. Yes. Nice. So, so that's ALL. Next, we have CLL, which is also SLL. I think SLL, we had some weird question. I don't know if you guys made a note.
No, here 922, isn't it that is a CML? It's put here. It's I understand 1221 is about your ALL, but this is CLL, I thought.
Yes, CLL, 922 occurs in both CLL and ALL.
Yeah. Okay, both. Oh, okay. No, you come down. It's
No,
there.
no.
Just
I know,
From
I'm
the
just
same
recalling the
page.
numbers. 8, 14, 14, 18, 11, 14, 11, 18. So yeah, now we have 12, 21 and 922.
922.
Yeah.
It's below
So this
that.
is 922 is seen in both because Philadelphia chromosome is classic for CML, but here ALL can also have a 922. So this is chronic myelogenous. This is acute lymphoblastic leukemia or lymphoma. So 922 is overlapping. All right. So
One
CLL,
thing
which
is, one thing is Down syndrome is association with if children are greater than 5 years of age. If the children are less than 5 years of age, then they are associated with AML.
Less than 5 years. So Downs, so classified further by age. If they are less than 4, you said?
Less than 5, then AML. If greater than 5 years of age, then ALL.
Okay, nice. Thank you. So that could be a clue in the questions. If they are more than 5 years, that's ALL. If it's less than 5 years, that's AML. So this is in the Down syndrome patient population. Okay. Then next we have CLL. So yeah, this is age more than 60 years, chronic. So it is an older population, most common adult leukemia, CD20 positive, 23 positive, and CD5 plus B cell neoplasm. So yeah, we know CD19, 20, 21 is B cell marker. So this has CD20, 23, 5 positive B cell neoplasm. Okay. Often asymptomatic, may progress slowly, and we see smudge cells in peripheral blood smear, autoimmune hemolytic anemia. So IHA. CLL is, to remind us, crushed little lymphocytes, which are smudge cells. Richter transformation, CLL or SLL transformation into an aggressive lymphoma, most commonly diffuse large B cell lymphoma. Yeah, this was the Richter, something we said about it. We found out. Did I post it? No. Okay, so chronic, so what is Richter transformation? CLL or SLL transformation into an aggressive lymphoma, most commonly a diffuse large B cell lymphoma. CLL, SLL converting into DLBCL. Okay. CLL, SLL converted to DLBCL. All right. So next we have hairy cell leukemia. This is seen in adult males. Mature B cell tumors, cells have filamentous. So why are they called hairy? Because they have filamentous hair-like projections, fuzzy appearing on the light microscopy as seen here. So they have these hair-like projections, fuzzy hair, filamentous hair-like projections, which are fuzzy appearing on light microscopy. Peripheral lymphadenopathy is uncommon, causes marrow fibrosis and leading to a dry tap on aspiration. So marrow fibrosis, dry tap, hairy cell leukemia. Patients usually present with massive splenomegaly and pancytopenia. So present with massive splenomegaly and pancytopenia. Stains TRAP positive. So TRAP positive is tartrate-resistant acid phosphatase positive marker, and trapped in a hairy situation. Okay, TRAP stain is largely replaced with flow cytometry associated with BRAF mutations. Treatment purine analogs like cladribine and pentostatin. So you're associated with BRAF mutations. Okay, so let's review lymphoid neoplasms. So all these are leukemias, unregulated growth and differentiation of WBCs in bone marrow. So lead to bone marrow failure, anemia, because of decreased RBCs, infections, decreased mature WBCs, and hemorrhage, decreased platelets, usually present with increased circulating WBCs, malignant leukocytes in blood, although some cases present with normal to low WBCs. Leukemic cell infiltration of the liver, spleens, lymph nodes, skin, and leukemia cutis is possible. So ALL key points, fun facts, this occur in children, not so fun. T cell ALL. So T cell ALL or TALL can present as a mediastinal mass and present as SVC syndrome. Associated with Downs, peripheral blood and bone marrow will have super high lymphoblasts. So acute lymphoblastic has lymphoblasts. Then TDT positive, CD10 positive, response to therapy and may spread to the CNS and testes. So we spoke about how this can infiltrate all these organs. Here they also go to CNS and testes. T1221 better, 922 worse. So next we have CLL, SLL, age more than 60 years. Most common adult T-cell leukemia, CD20 positive, 2023 5 plus 5 positive B-cell neoplasm. Asymptomatic progresses more slowly, so smudge cells crush little lymphocytes, and can precipitate IHA. Richter transformation, so CLL, SLL, so call cell DLBCL. Call cell converting to DLBCL. Then hairy cell, adult males, so they have, this is a mature B cell tumor. Oh, this is T cell ALL. This is the B cell neoplasm. This is again a mature B cell tumor. So can have filamentous hair-like projections. Peripheral lymphadenopathy is uncommon. Marrow fibrosis leading to dry tap, massive splenomegaly and pancytopenia, TRAP positive, BRAF mutation positive or associated. Treatment is purine analogs like fladribine and pentostatin. Okay, so now myeloid, we have AML and CML. AML is median onset is 65. So age review, this is children, this is more than 60, this is adult males. This is median onset 65, this is 45 to 85 years, median age 64. So both are around 65.
Mnemonic with BRAF, BRAF meets NPH, right? So BRAF is associated with, which Atul mentioned, it's hairy cell leukemia, NPH. And for non-Hodgkin lymphoma, do you remember, Saya?
What's the mnemonic? I don't know.
BRAF meets NPH. Atul shared.
What BRAF? I don't even know this mnemonic. BRAF meets NPH. NPH.
Yeah, when we did the tumor oncogenes, he shared, right?
I don't remember.
With NPH, hairy cell leukemia, and for I think non-Hodgkin lymphoma. No.
Melanoma, non-Hodgkin lymphoma, colorectal carcinoma, papillary thyroid, hairy cell leukemia.
Do you remember the mnemonic, Nilo, which you mentioned?
No, that is new to me.
Okay, let me.
It's right here, right? Meets for melanoma, NPH is non-Hodgkin's, P for papillary, H for hairy cell. So meets NPH is covering everything. Colorectal is also there. Okay. So maybe
he clearly told.
So BRAF meets NPH. So you have all your explanation for NPH. Now, what is your question? I didn't hear you.
Yeah. Brain BRAF. He said brain meets NPH. So meets for melanoma. S he mentioned serine threonine kinase, and NPH, N for non-Hodgkin lymphoma, P for papillary thyroid cancer, and H for hairy cell leukemia.
Okay. Brain
meets NPH.
Normal pressure hydrocephalus, is it?
Yes.
So to remember these BRAF things. Okay. Nice.
Yes. So brain meets for melanoma, and TS he said serine threonine kinase, and N for non-Hodgkin lymphoma, papillary thyroid cancer, and hairy cell leukemia.
So brain meets NPH, B for BRAF, or BRA for BRAF, M for the melanoma, N for non-Hodgkin's, P for papillary thyroid, H for hairy cell
leukemia. And TS, he said that correlate with the serine threonine kinase thing.
TS, this TS, okay. So in the meets, the TS is for the serine threonine. Okay. Brain meets NPH. CRC को तो थोड़ा छूट गया, yeah, okay.
Where is the CS? Where is serine? What was the mnemonic? Brain meets
NPH, normal pressure hydrocephalus. So BRAF, the BRA in the brain is the BRAF mutation. M for melanoma, EEETS, right? Meets spelling. So the TS is for the threonine kinase and the S is for serine kinase. And then NPH is for this expansion. I'll put it on chat maybe. Brain.
Thank you.
Meets. You're welcome. Meets. So EE, the T and the S is important. NPH. So now we're doing hairy cell leukemia. So this is associated with BRAF. So that's why Hamna's making the link. Nice. 436 maybe. Okay. So yeah, we were over here. So brain. So yeah. So to remember the connection between BRAF and all the other associated neoplasms. All right, so thank you, Hamna. So we have AML and CML. So this is median onset 65 years. Or rods are present. Or rods should always trigger us to think about AML. MPO positive. Cytoplasmic inclusions are seen mostly in APL, which is formerly the M3 subtype of AML. There's super high, so yeah, this was super high circulating lymphoblasts. This is super high circulating myeloblasts. On peripheral smear, may present with leukostasis. What is leukostasis? Capillary occlusion by malignant, non-distensible cells. This is leading to organ damage. So leukostasis is capillary occlusion by malignant, non-distensible cells leading to organ damage. So it can present with the leukostasis. Then what are the risk factors? Prior exposure to alkylating chemotherapy, radiation, benzene, myeloproliferative disorders, and Down syndrome. Typically acute megakardioblastic leukemia, which is formerly M7 AML. So Down was more specific for M7 subtype, which is acute megakardioblastic leukemia. Then APL T1517. So APL T1517 responds to ATRA, which is all trans retinoic acid, vitamin A, and arsenic trioxide, which include differentiation of promyelocytes. DIC is a common presentation. Okay, DIC, so makes sense. Leukostasis, so DIC proceeds and goes to DIC and consumptive coagulopathy. Okay, next is CML.
One quick fact actually. This AML is the MPO positive, correct? But the Down syndrome, this M7, it does not respond to the myeloperoxidase. This is MPO negative because megakaryocyte is negative for the MPO as staining. So Dr. Sattar has told about this.
Okay, nice. 437. So the Down syndrome variant, which is the formerly M7 AML, is MPO negative.
Because megakaryocyte don't respond to the MPO.
Okay. So megakaryoplasts don't take up the MPO staining. They would respond to the myeloperoxidase. Okay, nice. Thank you. Let me make a note of that. So this is MPO negative. Okay, cool. All right, so then we have, CML. Thank you, Shruti. So next year, CML, which is peak incidence 45 to 85 years, median age 64, defined by the Philadelphia chromosome, which is translocation 922, BCR ABL, myeloid stem cell proliferation, presence with dysregulated production of mature and maturing granulocytes. So dysregulated production of mature and maturing granulocytes. What are the granulocytes? Neutrophils, metamyelocytes, myelocytes, and basophils. So usually they give this in the question. In the labs, metamyelocytes and myelocytes are high in New World questions, at least. Yep. And basophils are also high. Normal basophil count is very less, like 0 to 1. So this basophil count, they would probably give a very high number. So that's pointing all to CML. And so here in E, we're seeing lots of neutrophils, metamyelocytes, so precursors, granular basophils, I think, not very clear, but lots of precursors. And in one slide, if you're seeing so many bilobed or nucleated cells, then that's something abnormal. So this was showing the OR rods of AML. This was showing the hairy cell in hairy cell. What was it? Hairy cell leukemia. This was the smudge cells in CLL, crushed little lymphocytes. This A was lymphoblasts. Okay, so yeah, presence with dysregulated production of mature and maturing RBCs. Sorry, granulocytes, mature and maturing granulocytes, as well as splenomegaly, may accelerate and transform to AML or ALL, which is known as a blast crisis. Chronically slow progressing, suddenly transforming to an AML or ALL is known as blast crisis. It responds to BCR-ABL tyrosine kinase inhibitors, imatinib. So APL, so AML subtype APL T1517 responds to ATRA and arsenic. So how does it help? This induces differentiation of promyelocytes. DIC is a common presentation. CML responds to BCR-ABL tyrosine kinase inhibitor, imatinib. Yeah, so it is inhibiting the gene which is problematic. So BCR-ABL tyrosine kinase inhibitor, imatinib. Okay. So AML main high yield like facts or rods, MPO positive inclusions, super high circulating myeloblasts, leukostasis, so present with organ damage. Risk factors are alkylating chemotherapy, radiation, benzene, myeloproliferative, Down syndrome, which is the megakardioblastic leukemia subtype, MPO negative, APL translocation 15-17, response to ATRA and arsenic. How does it help? It induces differentiation to promyelocytes. DIC, which is this consequence of this leukostasis, is a common presentation. Actually, I don't know if it's a consequence. I'm not sure though. So DIC is a common presentation, consumptive coagulopathy.
DIC happens when we treat with, when myeloperoxidase basically dissociates, it leads to DIC.
Myeloperoxidase dissociation will lead
So
to DIC.
after treatment it happens, yeah.
So this is an after treatment, or they're
DIC,
saying
yeah. After treatment it happens.
Okay.
Yeah, I have written, it's written somewhere.
That makes sense. So this myeloperoxide which will leak out will trigger DIC. Okay. Yeah, I think you all had it somewhere. Yeah. Right. So CML facts, median age 64, Philadelphia chromosome definition. So 922 BCR ABL, myeloid stem proliferation. So lots of mature and maturing granulocytes, myelocytes, metamyelocytes, basophils in the question. We have to think CML as well as splenomegaly. Accelerate and transforms to AML or ALL, which is known as a blast crisis. Response to BCR ABL tyrosine kinase inhibitor. What is the drug? Imatinib. Okay. So these are all the leukemias: lymphoid, AML, CLL, SLL, hairy cell leukemia. Myeloid is AML, CML. Okay, are we good? Any mnemonics, pointers, additions?
If you don't mind, after the next page, please do the rapid fire. It's hard to stick.
Yes, maybe after we finish up.
Yes.
Lots of farm stuff. Okay, cool. All right, so next we have myeloproliferative neoplasms. What are these? These are malignant hematopoietic neoplasms with varying impacts on WBC and myeloid cell lines. So variable WBC and myeloid cell lines. So what are these neoplasms? Polycythemia vera, essential thrombocytopenia, and myelofibrosis. Yep. So PCV, this is primary polycythemia, disorder of increased RBCs, usually due to acquired JAK2 mutation, may present as intense itching after shower. So this is known as aquagenic pruritus. What happens in SLE after shower?
That's Lermite something. There might, I forget how to learn.
That's in MS.
MS. Oh,
I'm
this
sorry, yeah.
MS.
I
That
meant to
might.
say multiple sclerosis actually, but I think
Yes,
I said,
yes.
uh,
SLE doesn't have that. Yeah, that's right.
yeah, I meant to say multiple sclerosis. Sorry. Multiple sclerosis, what happens after shower? Uchthoff phenomenon.
Uthoff. Yeah.
Yes, Uchthoff.
Yes.
Oof is
Yes,
too
yes,
hot.
yes.
That's the
Yes.
thing. Okay, yeah, Uchthoff phenomenon. Thank you so much. Uchthoff phenomenon is with the temperature, and Lermitz was the flexing of the neck. Yes. This is aquagenic pruritus. Uchthoff, or I don't know how to pronounce it, but Uchthoff, that's with the temperature, so it's too hot. So it's worsening of symptoms due to exposure to higher than usual temperatures. So increased body temperature like hot bath and exercise. Lermitz is when electrical sensation runs down the back of the spine when bending the neck. These are both characteristic of multiple sclerosis. And now we are talking about aquagenic pruritus seen with polycythemia vera. So here also after shower, symptoms are worse, intense itching after shower. So this is aquagenic pruritus. Okay. So it's a rare but classic symptom is erythromelalgia. So we have one more thing here. Erythromelalgia is another. So aquagenic pruritus, another unique feature. This is erythromelalgia, which is severe burning pain and red-blue coloration. This red-blue coloration due to episodic blood clots in the vessels of the extremities, which is this one. Associated with hyperviscosity and thrombosis. Example, PE, DVT, Budd-Chiari syndrome. So decrease EPO versus secondary polycythemia, where we have excessive erythropoietin, which makes sense. So this will present, so versus secondary polycythemia, which presents with endogenous or artificially increased EPO. Treatment is phlebotomy, hydroxyurea, and ruxolitinib, which is a JAK1/2 inhibitor. Ruxolitinib, which is a JAK1/2 inhibitor. Okay. Then we have essential thrombocythemia. This is characterized by massive proliferation of megakaryocytes and platelets. So polycythemia, so that's RBCs. This is megakaryocytes and platelets. So from the name, we know this is RBCs, this is thrombocytes, so, and their precursors, megakaryocytes. Symptoms include bleeding and thrombosis. Blood smear shows markedly increased number of platelets, which may be large or otherwise abnormally formed. Erythromelalgia may also occur with this condition. So we are seeing what is this? Abnormal platelet, I guess.
The platelets are the one which are little ones on the side, and in the middle they're showing something. Yeah.
Because I was attracted to this one. It looks like a burr cell, but this is actually what the point is.
Right.
The platelet. Okay. Cool. Thank you. So then next we have myelofibrosis. This is atypical megakaryocyte hyperplasia, which will cause increased TGF-beta secretion. We know TGF-beta is responsible for fibrosis, so increased fibroblastic activity, obliteration of the bone marrow with fibrosis associated with massive splenomegaly and teardrop RBCs. So this makes sense. It's full of fibrosis in the bone marrow. So this we saw, right? Bone marrow cries because it is fibrosed. And it is a dry tap. So dry tap we also saw in hairy cell leukemia. So all of these hairy cells are occluding it and causing a dry tap, versus here all the fibrosis, which also is kind of like fibers, right? Hairy. So both the hairy stuff is occluding the bone marrow and causing a dry tap. So
did you notice this? 1 second. Did you notice a little above? Primary, we are seeing that EPO goes down, but in secondary, it goes up, endogenous or artificially.
Yeah. It makes sense, right? Because here there's so many RBCs. The body's trying to shut down RBC production, so it decreases EPO.
Yes.
versus secondary polycythemia occurs when there is, let's say, chronic hypoxia. In chronic hypoxia, so this EPO is released from the kidneys, right? So the kidney is going to be like, oh my God, there's no oxygen. We need to produce more
Yeah,
RBCs.
yeah,
So that
makes
will
sense.
increase the EPO. So that is secondary versus here. There's already so many RBCs, the body shuts down the EPO production. So primary,
right. Yeah.
secondary
Thank
EPO.
you. Makes sense.
Nice. So yeah, so here we see teardrop cells, teardrop RBCs in myelofibrosis. Okay. So labs, how do we differentiate? So polycythemia vera, by definition, this is increased RBCs, but we also have increased WBC and platelets. So all cell lines. Philadelphia negative, JAK2 mutation is the main thing. So we treated with, what was the drug? Ruxolitinib. Ruxolitinib. Okay. Then essential thrombocytopenia, the main thing is thrombocyte problem with megakaryocytes. So the platelets are high, Philadelphia chromosome negative. JAK mutations are present in 30 to 50% of patients. Then we have myelofibrosis. RBCs are less. WBC is variable, platelets are variable. Philadelphia negative, JAK2 mutations in 30 to 50% patients. So RBCs are less in myelofibrosis. CML, which we saw in this page, here they contrasted because here also Philadelphia is positive. CML RBCs are low, WBCs are high, platelets are high, JAK2 mutations negative. So are they trying to contrast with polycythemia? Because in both WBCs and platelets are high. This is Philadelphia positive, this is Philadelphia negative. Here's JAK positive, this is JAK negative. Why did they contrast with this? I don't know. Anyone? This is myeloid. So to differentiate myeloid versus myeloproliferative, I believe. Okay. Have I been at this page for 34 minutes?
So I think in polycythemia, everything is high, right? Every cell line is high, RBCs, WBCs, platelets. In essential thrombocythemia, only the platelets are high, megakaryocytes and platelets. And myelofibrosis, they say initially, actually in the text, they say that megakaryocytes hyperplasia. So it should be platelets are high, that leads to TGF-beta, increased secretion, and that leads to fibrosis. So I don't know why they say variable, but RBCs are down
These
here.
are mature platelets, right? Megakaryocyte means a precursor. So if they had to separate it to precursor platelets, that would be high. Because precursor platelets are high in both of this. This also, right? Megakaryocyte and platelets. I think so.
Okay, but yeah, basophilia and the WBCs are high, in CML platelets are high, and RBCs are down there.
Yes. Okay.
Thank you.
Why did they put CML herbs hitting my brains? What
because
are they trying
it's all
to say?
myeloproliferative disorders. Mostly it's included in myeloproliferative.
Okay.
I think so, yeah.
So the main difference is polycythemia, everything is up. Here, RBCs are down, but WBC and platelets are up because that's again myeloid. Metamyelocytes, myelocytes, basophils, and splenomegaly. Okay.
I think UWorld has a very different explanation about like hypoxia, like dehydration condition, like that. Do you remember? UWorld has a total different way of explaining this.
For which one?
This essential thrombocytopenia and then polycythemia or something. Maybe we can look at it later. Yeah. This table.
Dr. Sattar has talked about actually CML, that he said that it is proliferation of the mature myeloid, especially the granulocyte.
Especially the granulocyte, for which one?
For the CML. You're asking for the CML, right? So there is the increase in the granulocyte only. So that is even in the CML, there is, we can see the, the increased level of the basophils and all this thing. But maybe RBC, this what you have asked, no, like why the RBC has decreased. It's because granulocyte especially has proliferating, not means not the erythrocyte portions. Yeah. Yeah, they have written mentioned it out there. Yeah.
Okay,
Yeah.
nice. So not the erythrocyte, but the granulocyte portion. So which is differentiating us from polycythemia versus CML.
So in the bone marrow, if one thing is keep on proliferating, it will suppress the other, right? So
So this in this one, the RBCs are getting suppressed by this excessive granulocyte line. Okay, nice. Thank you.
And
Thank
then
And your
forget,
granulocyte.
hang on. No, hang on. Forget about the one I said, because I'm seeing the next page is that table there. So you're good. We're good. Next page, the table is there.
Okay,
This is the table I was talking about. Yeah.
Okay. All right, so we'll come to it.
Mm.
All right, thank you. So next we have leukemia. Sorry, it was Hamna, were you saying something?
No, I said just granulocytes are basically your NBE, neutrophils, basophils, and eosinophils. So if the granulocytes are high, so all these, that's why we find basophilia only in CML.
yeah, granulocyte is basically neutrophil and the monocyte.
Neutrophils, basophils, and eosinophils. That
Yeah.
one are granulocytes, right?
Yeah.
Monocytes are in the different lineage. It's not in the, if you see the first picture, where the differentiation occurs. So granulocytes have these three, and neutrophils, basophils, eosinophils, that is monoblasts lineage, monocytes and macrophage.
You're right, but actually, no, I mean, in the pathom, I'm just telling through that eosinophil itself has the CFU, that is the, colony stimulating this thing. Under the influence of IL-5, it has itself having the own pathway. Yes. But yeah, I mean, on the whole, they have taken it, so we should include FA only. But yeah, you're right. Yeah, we should include this one only.
Okay. So you're saying in eosinophil actually has its own production pathway from the
under the interleukin 5, it uses the interleukin 5, and then it
yeah, we saw it in immune also. We said 5 kind of looks like
colony forming unit is so the colony forming sorry, unit of the eosinophil is separate. That Dr. Satar talked, but I think we should go for the boards, and we should follow this FA more like.
All right, cool. Thank you.
Like, erythrocyte have its own colony forming unit, which uses the erythropoietin and produces RBC. A megakaryocyte, it has own colony forming unit, which uses the thrombopoietin and form the platelet. Likewise, the eosinophil has its own colony forming unit, which uses the interleukin 5 and form the eosinophil. So that's why neutrophil and monocyte we include together, but we put it like because it has own colony forming unit.
Okay, nice. Eosinophils are separate. Okay, thank you, doctors. So next we have leukemoid reaction versus CML. This is very high yield facts. Leukemoid, we have reactive neutrophilia more than 50,000 cells versus here we have myeloproliferative neoplasm, which is positive for PCR-ABL. So here neutrophil morphology, so there's toxic degranulation, Dolly bodies, which we saw somewhere, actually in this context only, I think, and cytoplasmic vacuoles. Lab score is high, eosinophils and basophils are normal. Here, by definition is a myeloproliferative neoplasm, positive for BCR-ABL. We saw a little bit ago pseudo-Pelger-Hewitt anomaly with the bilobe neutrophils, and there is decreased LAP. Decreased LAP enzyme. So LAP enzyme is decreased in malignant neutrophils. So they are abnormal neutrophils, so they don't have LAP. Then eosinophils and basophils are also high over here. Okay. So main difference, LAP is low. CML, BCR ABL positive, pseudo Pelger-Hewitt anomaly, lab score low, eosinophils and basophils are high. Leukemoid reactive neutrophilia. Neutrophil count is super high, more than 50,000 cells per millimeter cube. Toxic granulation, Dolly bodies, and cytoplasmic vacuoles. Increased lab score, eosinophils and basophils are normal. How did they describe the Dolly bodies? Anyone remembers? They said some words like
beautiful light blue peripheral.
Light blue things in the periphery. You said like doll-like, so they're very light blue. What else was it?
Yeah, light blue.
They're bilobed.
Bilobed is this one, the duet Hewitt. Dolly also is bilobed?
No.
Dolly is light blue peripheral inclusions. Here, this
yeah, and these toxic ones are coarse
of
granulation.
RER. Sorry, go ahead. Toxic
granulation is dark blue coarse granules. Dolly bodies is light blue peripheral inclusions.
Of RER. That's what I was trying to recall. Of RER. Blue cytoplasmic inclusions of rough endoplasmic reticulum in the periphery. Toxic granules are dense, dark purple granules. Both are present in this leukemoid reaction. With the left shift. Okay, nice. Thank you. So each has its own body. For leukemoid, we have Dolly bodies, toxic granules, cytoplasmic vacuoles, versus this one has a duet cell. Pseudo Pelger-Hewitt anomaly. Okay, cool. So next we have polycythemia. What is polycythemia? It can be relative polycythemia, appropriate absolute, inappropriate absolute, or polycythemia vera. vera. So relative, the plasma volume is low. So this is a primary disturbance. So it appears as if there is polycythemia. But the main thing is actually plasma volume is low. RBC mass normal, oxygen saturation normal, EPO levels normal, associated with dehydration and burns. Next, we have appropriate absolute. The primary problem is with decreased oxygen saturation. So EPO levels are triggered, RBC mass is then increased as a consequence. So primary disturbance is the decreased oxygen saturation. So seen in lung disease, congenital heart disease, high altitude, and OSA, so it makes sense. Decreased oxygen saturation triggers the kidney to produce EPO. EPO will increase the RBC mass. Then we have inappropriate absolute. Here there is EPO levels coming from somewhere randomly. Either there's exogenous EPO, like an athlete misuse, also called blood doping, or androgen supplementation, which will also increase the erythropoietin levels. Or it could be inappropriate EPO secretion from a malignancy like renal cell carcinoma or a hepatocellular carcinoma. So that makes sense. If the EPO is high, RBC masses increase as a consequence, oxygen saturation is normal, plasma volume normal. Then polycythemia vera, primary disturbance is a super high RBC mass, and EPO levels have a feedback inhibition, so they go down. Plasma volume is also high because there's lots of RBCs. So EPO decrease in PCV due to negative feedback, suppressing renal EPO production. Main thing is polycythemia vera.
So Saira, in polycythemia, it's a major your RBC mass increase. That's why EPO decreases, right? Why the plasma volume increase?
The volume itself is like if you uska वजन उसका weight बढ़ जाता है ना, so RBC mass is so much, you just think of it as voluminous increase. So not the fluid, but if you take a beaker and measure the blood, there's too much cells, so that's just increasing the volume. Think of it like that.
Okay, so it's not the fluid level, right?
It's not the fluid, it's the total volume. Total plasma volume is high because of the RBC mass itself. So as a consequence, this is high.
So in dehydration and burns, it decreases the volume. Okay.
Yeah, here it makes sense, right? Fluid component of the plasma is less. So that's the triggering cause. Polycythemia vera, volume is high, or you can think that the RBC mass is so much that it's squeezing the fluid, I don't know, into the plasma compartment. Because technically plasma is the other than the cellular compartment, that's the plasma. So my answer may be wrong, but that was just to remember it. I'm not sure. Anyone? Any better answer, please?
Yeah, you're right. And in dehydration and burns, basically the fluid losses are there. So plasma volume goes down. In polycythemia, it's the RBC mass will be increased. So that's why EPO goes down. And though maybe to accommodate all these RBC mass, plasma volume also goes up. Because otherwise, if it's so much mass increase, then where it would go?
Agree. That is.
Plasma volume goes up. So that's why erythropoietin decreased in PCV due to negative feedback suppressing renal erythropoietin production. Okay. Inappropriate, the word is inappropriate. So maybe it's exogenous or tumors. And appropriate, it's lung disease, heart disease, high altitude OSA.
Yep, appropriate compensation. So that makes sense.
Yeah.
This is appropriate. So it's coming from either outside or from a tumor. Okay. All right, cool. Thank you. So
and
here
4
comes...
tumors are associated with this EPO thing, if I'm not wrong. RCC, HCC, pheochromocytoma, and one else.
RCC, HCC, PO, where the EPO is high, you mean?
Potentially really high hematocrit levels. Okay. So it's pheochromocytoma, RCC, HCC, leiomyoma, and hemangioblastoma.
So these all have increased EPO.
Yeah.
Inappropriate EPO. What was the last one? Hemangioblastoma.
Hemangioblastoma. So the mnemonic is potentially really high hematocrit levels.
Potentially really high. Is this on first aid?
Yes.
Potentially really high hemo thing levels. Okay. P for PO, R for RCC, H for HCC. The other H is for hemangioblastoma, and the other L, next L is for leiomyoma. Okay, nice. Thank you. Okay. So next we have chromosomal translocations. My most favorite page. No, I'm being sarcastic. So T814, Burke 8. So as doctor said earlier, so Burke 8 lymphoma. So this is a c-MYC activation. 1114. So mantle cell lymphoma with the cyclin D1 activation. 1118, which is a marginal zone lymphoma. T1418, follicular lymphoma, BCL2 activation. T1517, APL, which is formerly the M3 type of AML. T922, which is the Philadelphia chromosome. So this is CML, BCR-ABL hybrid. ALL is less common. Philadelphia cream mill cheese. So to remind us, Philadelphia is CML and ALL less commonly. Okay. So this we said 8. This we had our mnemonic with the man and the D. 1118, this is marginal. So combination of the 11, 111, and then the 8. 1418, what did we say? F, this Fez mnemonic, yeah. Follicular with the chain. Then APL 1517. APL 1517. Then Philadelphia 922. Okay, this is okay from just repetition. Philadelphia is 922, but it's seen in CML and ALL. CML is the classic. So BCR-ABL hybrid. ALL less commonly it can be present. So notes the IgG heavy chains on chromosome 14 are constitutively expressed when other genes like c-MYC and BCL2 are translocated next to the heavy chain gene region. They are overexpressed. So IgG heavy chains are on chromosome 14 are constitutively expressed, meaning normally expressed. But when other genes like c-MYC and BCL2 are translocated next to these heavy gene genes, they are overexpressed. Okay. Next, we have Langerhans cells histiocytosis. This is a collective group of proliferative disorders of Langerhans cells. These are antigen-presenting cells, normally found in the skin, Presence in a child as a lytic bone lesion. So skin se bone tak chala gaya. So child as a lytic bone lesion. Translation, I meant to say from the skin, it's gone to the bone, and a skin rash, or as recurrent otitis media with a mass involving the mastoid bone. So from the skin, it's gone to lytic bone lesions and skin rash and recurrent otitis media with a mass involving mastoid bone. Cells are functionally immature and do not effectively stimulate primary T cells via antigen presentation. So yeah, their normal role is antigen presentation, but because they are functionally immature, they do not effectively stimulate primary T cells via antigen presentation. They express two main markers, S100 and CD1A. Purbeck granules or tennis rackets and or rod shapes on EM are characteristic. And we also said coffee bean nuclei, right? For Langerhans, yeah.
Yes.
Yes. And what were the other things for coffee? We said volvulus had the coffee bee sign, sigmoid volvulus. And
Tumor of ovary.
Yeah, Brenner's tumor of ovary also had coffee bean nuclei. Nice. So this was a UWorld correlate. Yeah, so they were asking, assess the antigen presenting cell function study. They spoke about Langerhans cells, increased expression of which of the following surface marker is most indicative of Langerhans cells. So we have to associate this as an antigen presenting cell, and APCs will have B7. So T lymphocyte activation by a dendritic cell, dendritic APC, like a Langerhans cell in the skin, requires two signals, the binding of MHC2 with a TLR and the binding of B7 with the CD28. The requirement of both signals decreases the activation of T lymphocytes to self-antigens and decreases the incidence of autoimmunity. So yeah, so increased expression of B7 is most indicative of Langerhans cell activation. Okay. What are we actually seeing? Rod, tennis rackets or rod shaped? Okay, so this is the tennis racket. I think the older book had a better image. All right, cool. So next we have tumor lysis syndrome.
Better, bold bracket.
Right? Yeah, they actually showed a good tennis racket. Let me put it up.
Okay, it's okay. Everyone knows it.
Okay. Yeah, this one. And this is also showing the lytic lesion in the head, in the skull. Langerhans cell, APC, B7, CD8, 86 surface mark. Okay, yeah. All right, so next we have tumor lysis syndrome. What is this? This is an oncologic emergency triggered by massive tumor cell lysis, seen most often with lymphomas and leukemias, usually caused by treatment initiation, but can occur spontaneously. So usually with treatment initiation, but can also occur spontaneously with fast-growing cancers. Release of potassium causes hyperkalemia. Release of phosphate leads to hypophosphatemia. Hypocalcemia due to calcium sequestration by the phosphate. Increased nucleic acid breakdown, which leads to hyperuricemia, acute kidney injury. Prevention and treatment include aggressive hydration, allopurinol, and rasparicase. So here we're seeing tumor cell lysis. They release K plus potassium, increase potassium. They release phosphate, so increase PO4, PO4 3 minus. The nucleic acid destroyed, so increase uric acid. Uric acid form crystals and can cause acute kidney injury. This phosphate combines with the calcium, causing calcium phosphate crystals, also causing kidney injury. Increased K plus will lead to muscle weakness and arrhythmias. Hypocalcemia can cause ECG changes and seizures as well as tetany. So that's tumor lysis syndrome. Okay, should we take a short break before we start OncoPharm?
Yes, please.
Yes. Okay, thank you. So yeah, this OncoPharm is high. Let's try to finish it quickly.
And after break, please 5 minutes quiz to stick these things.
Yeah.
Otherwise, it's so
Okay, done.
volatile.
Start with a 5-minute pop quiz and then move to 1, 2, 3, 4, 5, 6, 7.
Especially with
7 minutes.
translocations.
Yeah, and
Yeah.
translocation,
Not
Saira,
bad.
I have made the numeric now. I've told you before. So it's when it's 11, 14, so kids are like, sort of mental.
Mental.
When they're around the 11 to 18, so 11 is the same, but when they reach to the 18 it, so they become like little bit marginal zone, like, so not that much aggressive at that age. Yeah, they got some sense. So it's marginal levels of intelligence.
Any way to remember this 15, 17 for APL?
15,
Odd
17 for APL, and yeah, actually 11, 22 for Ewing sarcoma as well. So all write it down on one page. So
what is it for Ewing's?
11, 22. 11, 12, 11, 22, na?
11, 22, yeah. 12, 21 we just saw. What was that for?
ALL.
ALL.
Good prognosis.
Good prognosis was 12, 21. Yeah. 12,
Yeah.
21.
M3, APL, 15, 17.
12, 21 is ALL.
So this is the age where we get mostly acne, right? APL thing. That's why we give retinoic acid in this thing.
Nice.
15, 17.
17, teen. Okay, but then 14, 18 also is teen. So
No, 15, 17.
17, odd numbers, APL. Odd numbers, so we look odd because of acne. So APL, so it's treated with Atra. APL was the one treated with Atra, right?
Yeah, APL is the one that is treated with Atra.
Okay, Atra. So 15, 17, 18.
Yeah, good. 15, 17, 18.
That's in Hindi, the numbers for 15, 17, 18. So 15, 15, 8, 17. So they odd numbers. So look odd because of acne. तो उनको 18 दे दो. ठीक है. Nice. Okay, guys. Let's take a 15-minute break and we'll come back sharp. All right, let's go. So next we have hemonc pharmacology. First thing, most important, hemonc drug, heparin. What's the mechanism? It activates antithrombin 3, which decreases action primarily of factors 2A and 10A. So as we saw in the UWorld image, 2A and 10A is what it's mainly acting on. It has a very short half-life. Clinical use is immediate anticoagulation for pulmonary embolism, acute coronary syndrome, MI-DVT. Used during pregnancy because it does not cross placenta. And we monitor PTT. Which immunoglobulin crosses placenta? IgG. Nice. All right, so yep. Then next we have adverse effects, bleeding, which we reverse with protamine sulfate. HIT, heparin-induced thrombocytopenia, lots of questions on that one. Osteoporosis with long-term use. And drug-drug interactions and type 4 RTA. Type 3 RTA earlier today, what was the correlation we said?
Fanconi syndrome, right?
Yeah, correct. Yes, Fanconi syndrome. Yes, thank you. All right, so bleeding, HIT, osteoporosis, drug-drug interactions, and type 4 RTA. So HIT are two types, type 1 and type 2. So HIT type 1 is mild. Platelets are more than 100,000 per millimeter cube. This is transient, non-immunologic drop in platelet count that typically occurs within the first 2 days of heparin administration, and it's not clinically significant. HIT type 2, this is development of IgG antibodies against heparin-bound PF4 that typically occurs 5 to 10 days after heparin administration. So this is in the first 2 days, this is 5 to 10 days. Okay, then antibody heparin PF4 complexes binds and activate platelets. So this leads to removal by splenic macrophages and thrombosis and a super low platelet count. So the complex binds and activates platelets. So it's reducing platelet count. There's also removal by splenic macrophages and thrombosis. Okay, so highest risk with unfractionated heparin. Treatment is discontinue heparin and start alternative anticoagulant with argotroban. Fondaparinux is safe to use because it does not interact with PF4. Okay, notes, low molecular weight heparins like enoxaparin and dalteparin act mainly on factor 10A. Fondaparinux acts only on factor 10A. Both are not easily reversible. So these LMWs are not easily reversible. Unfractionated heparin used in patients with renal insufficiency is used in patients with renal insufficiency. Low molecular weight heparins should be used with caution because they undergo renal clearance. So unfractionated heparin has two good features, is in that it's can be used in pregnancy and also in renal insufficiency. Heparin is okay. Okay. All right, so one more time, mechanism of heparin is activates antithrombin, decreases its action of primary factors 2A and 10A. So main targets are thrombin and 10A. It has a short half-life. Clinical use is immediate anticoagulation for pulmonary embolism, acute coronary syndrome, myocardial infarction, DVT, and it can be used in pregnancies because it does not cross placenta and monitor PTT. Adverse effects are bleeding. We reverse with protamine sulfate. So yeah, bleeding is reversed with protamine sulfate.
What's the mnemonic we use for pregnancy? That it is good. Someone has mnemonic with us, right? Heparin is for pregnancy thing.
Heparin for pregnancy mnemonic doesn't ring a bell.
Okay. Just
Anyone? Any idea?
okay, it's okay. Heparin is safe. Basically, heparin is safe during pregnancy. Okay. Thank you.
No worries. So bleeding, HIT, osteoporosis, drug-drug interaction, and type 4 RT are the side effects. For bleeding, we reverse with protamine sulfate. HIT two types, type 1, type 2. Type 1 is mild. Platelets are more than 100,000 still. They'll drop, but less, still more than 100,000. Transient non-immunologic drop in platelet count that typically occurs within the first 2 days of heparin administration. It's not clinically significant. HIT type 2. This is development of IgG antibodies against heparin-bound platelet factor 4 that typically occurs 5 to 10 days after heparin administration. So the complex is antibody, heparin, PF4. So three things: antibody, heparin, PF4 complex binds and activates platelets now, and that is removed by splenic macrophages and thrombosis. So removal by splenic macrophages and thrombosis will cause super low platelet count. Highest risk with unfractionated heparin. Treatment, discontinue heparin and start alternative anticoagulant like argatroban. Fondaparinux is safe to use. It does not interact with PF4. Notes, LMW heparins like enoxaparin, dalteparin act mainly on factor 10A. So not much effect on 2A. Fondaparinux only works exclusively. Fonda is fond of 10A. Both are not easily reversible. Hairpins always come in handy to pregnant moms. That's the mnemonic. Okay, nice. Thank you. Hairpins or heparin always come in handy to pregnant moms. Okay. Nice. Thank you, Fez. So fondaparinux acts only on factor 10A. So fonda is fond of 10A. Both are not easily reversible. Unfractionated heparin are used in patients with renal insufficiency. So low molecular weight heparins should be used with caution because they undergo renal clearance. Okay, so next we have warfarin. So another important drug. What's the mechanism of warfarin?
One thing, why it's used in type 4A, because heparin is directly toxic to zona glomerulosa and decreases aldosterone production. So that leads to type 4 RTA.
Why it causes type 4 RTA? The reason is?
Heparin is directly toxic to zona glomerulosa. It decreases aldosterone production, and we know that decreased aldosterone production in type 4 RTA, right?
Nice. Yes, that makes sense. Thank you. So heparin is directly toxic to the zona glomerulosa, so decrease aldo production. and which is the main pathology behind type 4 RTA. Okay, cool. Thank you. So that's heparin. Yep. Okay. Next, warfarin. The mechanism is inhibits vitamin K epoxide reductase and epoxide reductase by competing with vitamin A, causes inhibition of vitamin K dependent gamma carboxylation of clotting factors 2, 7, 9, and 10 in protein CNS. Metabolism is affected by polymorphisms in the gene for vitamin K epoxide reductase complex, which is VKORC1. In lab assay has an effect on the extrinsic pathway and increases PT. So this has a long half-life. The ex-president went to war to remind us that extrinsic pathway and increased PT with warfarin. Okay, this is a good one. So ex-president went to war. So remind us, extrinsic pathway, increased PT with warfarin. Clinical use, chronic anticoagulation. So this was for acute situations, immediate anticoagulation. This is for chronic anticoagulation situations like venous thromboembolism prophylaxis and prevention of stroke in AF. So yeah, venous thromboembolism, so TE prophylaxis and prevention of stroke in AFib. Not used in pregnant patients because warfarin, unlike heparin, crosses the placenta. So warfarin goes to war, so this will cross the placenta. Monitor PT and INR. Yeah, INR we also saw earlier. This is the main reason is INR is to follow up warfarin activity. So adverse effects are bleeding, teratogenic effects, and skin and tissue necrosis, as seen here. Warfarin-induced skin and tissue necrosis is a high-yield question. Drug-drug interactions metabolized by cytochrome P450, specifically the 2C91. So cytochrome P450, CYP2C9. There's initial risk of hypercoagulation. So protein C has a shorter half-life than this is also comes up in questions. There's initial risk of hypercoagulation. The main use is anticoagulation, but initially it causes some hypercoagulation. Why? Because protein C has a shorter half-life than factors 2 and 10. So existing protein C depletes before the existing factors 2 and 10 deplete. And before warfarin can reduce factors 2 and 10 production. So thereby net effect is hypocoagulation, meaning protein C depletes first, which is the anticoagulant is depleting first, leaving the existing factors 2 and 10. So they will coagulate. So there's a risk of hypercoagulation initially. So one more time, there's an initial risk of hypercoagulation. Why? Because protein C has a shorter half-life than factors 2 and 10. Existing protein C depletes before existing factors 2 and 10 deplete, and before warfarin can reduce 2 and 10 production of new factors. So there is a hypercoagulation. Skin and tissue necrosis within first 2 days of large doses is believed to be due to small vessel microthrombosis. Heparin bridging. So what about heparin bridging? Heparin is frequently used when starting warfarin. Heparin's activation of antithrombin enables anticoagulation during the initial transient hypercoagulable state caused by warfarin. Initial heparin therapy reduces the risk of recurrent venous thromboembolism and skin and tissue necrosis. So the bridging period is heparin. Next, we have for reversal of warfarin, give vitamin K. And for rapid reversal, give FFP or PCC. Okay, yep. So quick review, mechanism of warfarin is vitamin K epoxide reductase. Because of decreased carboxylation, and it's also, so two things, it limits vitamin K epoxide reductase by competing with vitamin K. So it's a competitive inhibitor. Inhibition of vitamin K dependent gamma carboxylation of clotting factors 2, 7, 9, and 10, as well as protein CNS. Metabolism affected by polymorphisms in gene for vitamin K. So VKORC complex.
What is it? What does it mean? I think we have a question regarding this polymorphisms in the gene for vitamin K.
So polymorphism means different forms of gene issues, right? So some people will have mild enzyme deficiency, some will have very high. So there's multiple presentations. I think that's what I understand.
Okay, so this weak is ORC1 is the epoxide reductase complex gene.
Yep. So V for VK, vitamin K, OR. So I think this O they have taken from epoxide reductase complex 1. So the polymorphisms in gene for this vitamin enzyme complex, basically. That's what it means.
Thank you.
Yeah, so metabolism is, you're welcome. Metabolism is affected by polymorphisms in the gene for VKORC1. So in lab assay, this has effect on extrinsic pathway and increases PT. Ex-president went to war. Yep, so yeah, XPT war. Clinical use, chronic anticoagulation, as in the case of venous thromboembolism prophylaxis and prevention of stroke in AF, not used in pregnant patients because warfarin, unlike heparin, crosses the placenta, monitor PT and INR. Adverse effects, bleeding and teratogenic effects, as well as skin necrosis. Drug-drug interactions as well, because it's metabolized by cytochrome P2C9, P450 subtype. Initial risk of hypocoagulation and heparin bridging are two important side effect concepts.
To remember, sorry, Saira, to remember this 2C9 thing, we have factors like 2, 7, 9, and 10. So otherwise,
Nice. 2, 7, C, they sound similar. So 2,
so
7,
C9. Otherwise, it's 2D6, and otherwise all many 3A4, and I don't know. So
yeah.
because these factors fall into warfarin thing.
What is that? Can you repeat, Hamna?
To CYP 2C9, so it involves the factors like 2, 7, 9, and 10, and C and S, right?
वो तो vitamin K dependent है ना?
Yeah, vitamin K dependent, but the warfarin acts through this because cytochrome P450 we have different SIPs, no? So just a correlation there to remember 2C9.
Okay, thank you.
Thank you. So initial risk of hypocoagulation and heparin bridging, two important concepts. Why is that initial risk? Protein C has a short half-life. So that's important pharmacokinetic thing to remember. Protein C short half-life than factor 2 and 10. So existing protein C depletes before the existing factor 2 and 10 deplete, and before warfarin can reduce new factor 10 and 2 and 10 production. So net effect is this increased hypocoagulation. Skin and tissue necrosis within the first few days of large doses are believed to be due to small vessel microthrombosis from this hypocoagulations. Okay, heparin bridging. Heparin is frequently used when starting warfarin. Heparin's activation of antithrombin enables anticoagulation during the initial transient hypocoagulable state caused by warfarin. Initial heparin therapy reduces the risk of recurrent VTs and skin or tissue necrosis. For reversal of warfarin, give vitamin K. For rapid reversible, give FFP and PCC. Next, heparin and warfarin comparison. Heparin is given parenterally, so IV and subcut, versus warfarin can be given orally. Site of action, this is in the blood. Warfarin is working in the liver, as we saw in the other image before. Onset of action, this is rapid and this is slow, so thereby useful for chronic situations. Then duration of action, this works in hours, and warfarin takes time, takes days to inhibit all the enzymes and then inhibit the production of the factors, so that makes sense. Monitoring, we have to monitor PTT or the intrinsic pathway versus PT and INR for this. Crosses placenta, no, and warfarin is teratogenic. It goes to war. Okay, this does not cross, this is teratogenic. So, okay, so that's fair, right? Easy. So heparin is parenteral, oral warfarin. For warfarin, the onset of action is rapid and warfarin is slow. Duration of action is hours for heparin, and so H for H in hours, days. It takes time for warfarin to act. Monitoring, you monitor with PTT versus PT-INR for extrinsic, for warfarin. Crosses placenta, no, warfarin is teratogenic. Okay, next we have direct coagulation factor inhibitors. They do not usually require lab monitoring, so that's good. don't have to poke the patients, so does not require lab monitoring. What are these drugs? Bivalirudin, the bad ones, which are actually good for the patient, and apixaban, edoxaban, and rivaroxaban. Okay, so then we have anticoagulation reversal. Okay, so direct coagulation factor inhibitors do not require lab monitoring. These are bivalirudin, argatroban, and dabigatran. These are directly inhibiting thrombin, which is factor 2A. So direct inhibition of thrombin 2A. These directly inhibit or ban factor 10A. So 2A and 10A. Venous, so we use it in venous thromboembolism, and AFib can be used in HIT, and can be used in HIT when heparin is bad. So HIT we use bad, which is bivalirudin, argatroban, and dabigatran. Bleeding, which is the adverse effect, we use idarucizumab, can be used to inhibit the big guy. That was our mnemonic. So yeah, idarucizumab to inhibit dabigatran. Then apixaban, edoxaban, and rivaroxaban. These directly inhibit factor 10A. These are oral agents. They also use for DVT and PE treatment as well as prophylaxis, stroke prophylaxis in patients with AFib. Side effects, again, bleeding. So here we reverse it with adexanet alpha, which also has a 10A. So 10A drugs have the 10A in the name. This antidote also has 10A in its name. Andexanet alpha. So it puts the 10A in a net and then takes away the effect. So adexanet alpha. All right. So yeah, where is these bad drugs used? In HIT when heparin is bad. Other uses, venous TE and AFib. The XA bands are oral agents used in DVT, PE treatment prophylaxis, stroke prophylaxis with AFib patients. 2A, 10A. Bad drugs and 10A drugs. Okay, cool. Next, we have anticoagulation reversal. This we already saw. So heparin reversal agent is protamine sulfate. Notes is its positive charge peptide that binds the negative charge heparin. So opposites attract. So positively charged peptide that binds the negative charge heparin. Then warfarin, vitamin K slow, plus or minus FFP or PCC, which is rapid. Then we said dabigatran, idarucizumab, which is a monoclonal antibody Fab fragment. Direct factor 10A inhibitors, andexanet alpha, which is a recombinant modified factor 10A. So this is inactive. So it just puts a net and takes it out of the body. Kind of, just remember. So that's anticoagulation reversal. Next, we have antiplatelets. They all work by decreasing platelet aggregation. So antiplatelets. What are these drugs? Aspirin, clopidogrel, prasugrel, ticagrelol, eptifibatide, and tirofiban. So fib drugs, and the xylostazole and dipyridinol, which we saw earlier, phosphodiesterase inhibitors. All right, so aspirin, this irreversibly blocks COX, so decreased thromboxane A2 release. So irreversibly blocks cyclooxygenase, decreasing the thromboxane A2 release. Clinical use is acute coronary syndrome, coronary stenting, decreases incidence or recurrence of thrombotic strokes. So acute coronary syndrome, coronary stenting, and thrombotic stroke. Yes. Adverse effects are gastric ulcers, which makes sense. Tinnitus, we saw with aspirin toxicity, allergic reactions, renal injury, and Rey syndrome in children. We've already covered this. This is high yield. Okay. Yep. So aspirin is done. Next, we have clopidogrel, prasugrel, and ticagrelol. These block ADP-P2, Y12 receptors. Decreasing ADP-induced expression of GP2B3A. What was the other name for this receptor? Alpha, beta, something, integrin.
Integrin alpha 2B, integrin alpha 2B, beta 3 is
Beta 3, right? Yeah. Alpha 2B and beta 3. Ulta it was, yeah. So integrin alpha 2B, beta 3. Okay, thank you. So these drugs block the ADP-P2 vital receptor, decreasing ADP-induced expression of GP2B3A. So clinical use same as aspirin and dual antiplatelet therapy. Okay, so they can be clubbed. Okay, so same for acute coronary syndrome, coronary stenting, and thrombotic stroke prevention. So dual antiplatelet therapy. Then adverse effects is bleeding, eptifibatide, tirofiban. These block. So this is working indirectly by decreasing ADP-induced expression of GP2B3A. These are directly blocking 2B3A fibrinogen receptor on activated platelets. So clinical use, unstable angina and PCI, percutaneous coronary intervention. Adverse effects, bleeding and thrombocytopenia. The next we have silostazole and dipyridamole. These block phosphodiesterase enzyme. So they decrease CAMP hydrolysis and increase CAMP in platelets. Decreasing CAMP hydrolysis and increasing the CAMP levels in platelets. So net effect, they're causing relaxation of the vessels. So they are used in intermittent claudication, stroke prevention, cardiac stress testing, and prevention of coronary stent restenosis. Adverse effects are nausea, headache, facial flushing, hypotension, and abdominal pain. Nausea, headache, facial flushing, hypotension, and abdominal pain. So they decrease platelet aggregation by causing this. So in the platelets also, actually, what I was talking about was smooth muscles. So yeah, silostazole and dipyridamole block phosphodiesterase, thereby decreasing CAMP hydrolysis and increasing CAMP inside the platelets. So thereby decreasing their ability to aggregate. So decreases platelet aggregation and useful in intermittent claudication. Yeah, we saw that in the other table the other day. Silostazole, claudication. C was a mnemonic. C for claudication, stroke prevention, cardiac stress testing, and prevention of coronary stent restenosis. Side effects, nausea, headache, facial flushing, hypotension, and abdominal pain.
And in the previous book, the abciximab is also added with eptifibatide and tirofiban. It also directly blocks GP2B3A.
Why did they remove it? That still is 2B3A blocker only, na? Monoclonal antibody, maybe because they put it together with others.
In picture, they have given 2023 that in the physiology we read, no?
Yeah, over there they're written. Yeah, but abciximab also the same mechanism of action. Blocks GP2B3.
And silostazole is PDE3 blockers, or what was that?
Non-specific it was, na? I think it was in the bottom of that page. Let me pull it up.
Some note was on at the down. No?
Sorry. Yeah, you're right. Silostazole was PD3. Dipyridamole was non-specific.
Okay.
Thank you.
Yeah.
Dipyridamole was non-specific. Okay.
Thank you.
Thank you. Yep. Okay. So that was antiplatelet drugs. We saw reversal, we saw antiplatelets, all the drugs that cause decreased platelet aggregation. Now we have thrombolytics. So these are going to break down a clot that is formed. Thrombolytic. What are these? Alteplase, ret alteplase, and tenecteplase. So alteplase is TPA. Reteplase is RPA. Tenecteplase is TNK TPA. So what is the mechanism? These directly or indirectly aid conversion of plasminogen to plasmin, conversion of plasminogen to plasmin, which cleaves thrombin and fibrin clots. So yeah, it cleaves thrombin and fibrin clots, increases PT as well as PTT, but no change in platelet count. Increases PT, increases PTT as well, but no change in platelet count because it is indirectly or directly aiding conversion of plasminogen to plasmin. Plasmin cleaves thrombin and fibrin clots. Okay, makes sense. Basically, it's increasing plasmin levels so that they can go and cleave the thrombin and fibrin clots. Clinical use in early MI, early ischemic stroke, direct thrombolysis of high-risk PE. So where is this used? Early MI, early ischemic stroke, direct thrombolysis. Yeah, these are time sensitive. So early MI, early ischemic stroke, direct thrombolysis of high-risk pulmonary embolism. Adverse effects are bleeding, contraindicated in patients with active bleeding or history of intracranial bleeding, or recent surgery, known bleeding diathesis, or severe hypertension. Non-specific reversal. So yeah, this makes sense, right? So that's why we need to check, even if the patient is in the ER, you have to check if they have any bleeding diathesis. So yeah, main adverse effects: bleeding, contraindicated in patients with active bleeding, history of intracranial bleeds, recent surgery, known bleeding diathesis, or severe hypertension. Non-specific reversal with antifibrinolytics like aminocaproic acid and tranexamic acid, platelet transfusions, and factor corrections like cryoprecipitate and FFP PCC. Okay, so suppose they had a bleeding diathesis and by mistake we have given TPA. Non-specific reversal is with antifibrinolytics, platelet transfusions, and factor corrections. What are the antifibrinolytics? Aminocaproic acid and tranexamic acid. Platelet transfusions, we're giving platelet. Factor corrections, cryoprecipitate, and so cryoprecipitate, FFP, and PCC. Okay. So that's thrombolytics. So yeah, first we did heparin, then warfarin, heparin versus warfarin contrast. Then we did direct factor inhibitors, direct coagulation factors. So direct 2A inhibitors, direct 10A inhibitors, anticoagulation reversible with their reversal agent. Then we saw antiplatelets and thrombolytics. Okay, cool. Next, coming to cancer therapy drugs. So cell cycle, yeah, these are high yield. So let's see. We have the M phase inhibitors, microtubule inhibitors, which are taxanes and Vinca alkaloids, inhibiting the mitosis phase. So M, mitosis and cytokinesis. Then we have G1, where the duplication of cellular content occurs, and they cycle between the G0. So transition from G0 to G1 or progression to S. So G1 to S inhibitors are cell cycle, no, those are independent drugs. So this is RB P53 modulate the G1 restriction point. Yeah, actually these are here only. Cell cycle independent drugs, which means they work everywhere, is it? Platinum compounds, alkylating agents like busulfan, nitrogen mustards, nitrosurias, and procarbazine. Intercalating drugs are anthracyclines and dactinomycin. Okay, so that's M phase specific is taxanes and Vinca alkaloids. G1 to S is what we have to remember is RB and P53 modulate at the G1 restriction point. Then synthesis inhibitors, antimetabolites, the cladribine. So these are cell cycle non-specific, which is cladribine only actually. Okay, cladribine is cell cycle non-specific. Cytarabine, 5-FU, hydroxyurea, methotrexate, pentostatin, thiopurines, they're all DNA synthesis inhibitors. Then we have topoisomerase inhibitors. This is etoposide, teniposide, irinotecan, topotecan. This we already know. Sides left and right, two sides. So topoisomerase 2 inhibitors. Can has only one side, one thing. So one can. So topoisomerase 1. So these are all working between the transition from S to G2 phase, topoisomerase inhibitors. Then actually, no, they're inhibiting both, I think, DNA synthesis and double check repair, or G2 phase, S phase and G2 phase. Then we have bleomycin. There's a big guy which is inhibiting two things, which is G2 and mitosis. So double check repair as well as mitosis inhibited by bleomycin. Say one more time, cell cycle independent drugs are platinum compounds, this is platin and all those, alkylating agents, which are busulfan, nitrogen mustards, nitrosurias, and procarbazine, and then intercalating drugs like anthracyclines and dactinomycin. This was updated in the errata actually. All right, so then cancer therapy targets.
Dactinomycin and anthracyclines were not part of alkylating, right?
Yeah, not part of alkylating. Yeah, they are separate class now. The intercalating drugs.
Okay, intercalating. Okay. Anthracyclines and dactinomycins, right?
Yep, anthracycline and actomycin, two things. Yes.
Okay. Anyone has any mnemonic for these pathway? No.
ADI, AD for ADI, so intercalating. ADI, I don't know. That's Indian name, I guess. That's for intercalating.
तो cell cycle पे act करने के लिए like.
Acha, where they work?
Yeah, where they work.
Anyone?
Texans are easy mitosis, texans and vinca. Bleomycin is also, I think, G2 and mitosis. Anti-metabolites, yeah, easy topoisomerase. Okay, both of them, G2 and.
Anti-metabolism, so metabolism is cut down, so no synthesis.
Yeah, no synthesis.
So that's okay. Topoisomerase we know, but the thing is to remember it's working in S phase as well as G2.
Yeah.
G2.
Okay. So and nobody is working on G1 phase and G1 phase, right?
No, cladribine is non-cell specific, so that would also work in G1. And the cell cycle independent means they work anywhere, yeah.
This cisplatin, busulfan, cyclophosphamide, all this thing is the G1 inhibitors only, right? Where are they?
Because it's a cell cycle independent, I thought they would work at any point. Let's see here if it's mentioned.
Cell cycle independent means they are not working on this cell cycle.
I think it is at the G1, no?
Let me see, cisplatin, if we get to it.
Till now, I was thinking it's G1 only.
Cell cycle non-specific. Matlab they can work anywhere, no?
Yeah, I guess so.
Yeah, you're
Not
correct.
any
Yeah.
point in the cell cycle they can work.
You're right.
So yeah. Yeah, we'll come back to this and we'll make some mnemonics. So we'll do them individually and maybe something will come up. All right, let's see. So cancer therapy targets. First, we have nucleotide synthesis. Nucleotides will come together to form DNA. DNA is converted to RNA. RNA creates protein, translates to protein. Protein causes cell division. So nucleotide synthesis level, we have methotrexate and 5-FU. These will decrease thymidine synthesis, and thiopurines, which decrease de novo purine synthesis, and hydroxyurea inhibits the enzyme ribonucleotide reductase. So 3 categories: methotrexate and 5-FU, thymidine synthesis, thiopurines, de novo purine, it's in the name, purine synthesis, hydroxyurea inhibiting the enzyme ribonucleotide reductase. At the DNA level, we have alkylating agents and platinum compounds. They cross-link DNA. So these are cross-linkers, both platinum chains and alkylating chains. So alka is wearing a chain, platinum chain. So alka and platinum chain both cross-link DNA. Bleomycin, DNA strand breakage. Bleomycin, DNA strand breakage. Bleo blasts the strand, so DNA strand breakage. Anthracyclines and dactinomycin, these are DNA intercalators. So ADI, ADI for this. Anthracycline and dactinomycin are intercalation inhibitors, intercalating drugs. Etoposide, tenoposide, we know. Teniposide inhibits topoisomerase 2. Ticans, we know. Topoisomerase 1. So and then the final one is a cell division inhibitors. This is vinca alkaloids. So we know microtubules we've seen earlier. So that's needed for the cell to separate, go to the thing and divide. So that's vinca alkaloids, microtubule function inhibitors, and taxanes. Taxanes also inhibit microtubule assembly. So this difference is this is formation and this is disassembly. So what if I've seen here? Cancer cells often develop mutations in genes that control the cell cycles like CDKs, RB, or cell death. All the medications like venetoclax, okay, new drug, have been developed to counter the products of these mutations. Neither carboplatin nor paclitaxel focuses primarily on the cell. Okay, this was a choice, not high yield. Just a new drug. So I think I put it venetoclax for counter these cell cycling regulators. Okay. So yeah, we have cancer therapy targets, nucleotide synthesis inhibitors, DNA inhibitors, and cellular division inhibitors. Under DNA, we have 1, 2, 3, 4, 5. Okay. Alka with the platinum chain, Bleo, which is blasting the strand. ADI for anthracyclines and dactyno for intercalators. Sides, though, we know 2 sides, and CAN is 1. Okay, so moving on, next we have antibody drug conjugates. Yeah, this is a NBME question, I think. So yeah, this is formed by linking monoclonal antibodies with cytotoxic chemotherapeutic drugs. So the conjugate of monoclonal antibody and a chemotherapeutic drug. So by doing this, antibody selectivity against tumor antigens allows targeted drug delivery to tumor cells while sparing the healthy cells. So it's increased efficacy and decreased toxicity. This is so smart. Example is adotrastuzumab emtansine, TDM1 for HER2 positive breast cancer. So combination of trastuzumab with ADO trastuzumab emtansine. Yeah, this is not very smart. Adotrastuzumab emtansine DM1 actually, not I. Adotrastuzumab emtansine TDM1 for HER2 positive breast cancer. Okay, so what are we doing? We are giving an antibody and a drug conjugate. So it goes and binds specifically to the tumor cells alone. So what's happening? It's binding to its antigen, to the tumor antigen. It becomes endocytosed. Lysosomal degradation occurs. So now drug is released and the drug will destroy the DNA, RNA, etc. and destroys the tumor cell. So that is the antibody drug conjugate. This was on UWorld. This is the question. Okay. So yeah, targeted drug therapy, conventional chemo, like chemotherapy aging like cisplatin, will go and bind to cancer cells and healthy cells. So affects both cells. This is a very blurry image. Okay. So it's going to affect both healthy and cancer cells. So lots of side effects. Active targeting, we're packing them in a liposome with an antibody. So antibody drug conjugate, and this is one more step, packed in a liposome. So EGFR antibodies are present. So it goes and binds to the EGFR positive tumor cells, which are selective for the cancerous cells. So EGFR is frequently overexpressed in lung cancer, breast cancer, and glioblastoma. So this is a targeted drug therapy. Antibody drug conjugate improves drug efficacy, minimize toxicity by allowing conventional chemotherapeutic drugs like cisplatin to selectively target and kill cancer cells while sparing healthy cells. So this is a targeted delivery. What was the question? They said cisplatin encapped in capsules. Compared to conventional cisplatin, the new formulation is most likely to have which of the following effects? Selective drug uptake by cancer cells. Not inhibition of tumor-induced angiogenesis. The correct answer is selective drug uptake by cancer cells. Okay. Okay. So that's this page. Then the cell cycle, where do we target? And then antibody drug conjugates. So moving on, we have anti-tumor antibiotics, anti-metabolites, alkylating agents, platinum compounds, microtubule inhibitors, topoisomerase inhibitors, the monoclonal antibodies, anti-cancer small molecule inhibitors, chemotoxicity amelioration stuff, and the chemoman. Okay, so anti-tumor antibiotics. So these are antibiotics which are used for against the tumor. So what are these? These are all cell cycle non-specific except bleomycin. Bleomycin is G2M space specific. So what is this G2M phase specific bleomycin. This induces free radical formation and breaks DNA strands. So B for breakage, B for breaks in DNA strands. This induces the free radical formation. So where do we use this? In testicular cancer and Hodgkin's lymphoma. Adverse effects of bleomycin, we've seen this in pulmonary fibrosis and skin hyperpigmentation. So main tested side effect, pulmonary fibrosis. Then next we have dactinomycin and anthracyclines. These were intercalators. So both are intercalators. So intercalates meaning they mesh into the DNA, preventing RNA synthesis. This generates free radicals as well as intercalates in DNA, breaks in DNA and decreases replication. It also inhibits topoisomerase 2. So three things it's doing. It's generating free radicals. Then next, it is also intercalating in the DNA and creating breaks in DNA. Therefore, there's decreased replication. And then third one, it is also inhibiting topoisomerase 2. So what are these? These are doxo and donorubicin. Okay, so before that, dactinomycin. So this is mycin, so antibiotics, rubicin, so they're all sins. So they are antibiotics. So where do we use the dactinomycin? Wilms tumor, Ewing sarcoma, and rhabdomyosarcoma. What are the adverse effects? Myelosuppression. So anthracyclines, doxo, and dono. Yes, so three things we said. And then where are these used is solid tumors, leukemias, and lymphomas. They're tested heavily for their side effect, which is dilated cardiomyopathy, often irreversible. We prevent it with dexrazoxane. And it can also cause myelosuppression. Side effect, pulmonary fibrosis for bleomycin and myelosuppression for dactinomycin, so it's very non-specific. Dilated cardiomyopathy, specific side effect for doxo and dono. Irreversible, contrast with trastuzumab, which is reversible. I think we're going to see it in a few. Prevent this dilated cardiomyopathy by giving dexrazoxane. And the other side effects is myelosuppression. Okay. So that is anti-tumor antibiotics, which are the SINs.
Yeah, side effects are easy here, but the mechanisms are bleomycin, free radical formation, which breaks in the DNA strands, dactinomycin intercalation into DNA, preventing RNA synthesis, and anthracyclines, like three functions. First with bleomycin and free radical generation, intercalation into DNA, so breaks in DNA and decreased replication, and the last one they have create on their own, inhibits topoisomerase 2. Was not before.
Yeah. Yes.
Okay.
Okay, so yeah, this we said ADI. So AD, these are intercalating. So that is easy to remember. The extra thing for doxo and dono is free radical generation and topoisomerase 2 also. They think they're dawn, so they can do whatever they want. So they inhibit topoisomerase 2 also. Just to remember. The other
Like,
topoisomerase 2, though we know.
like etoposide, right? Yeah, okay.
Yeah, etoposide and tunoposide, दो side होते हैं, तो we know that's topoisomerase 2. So ये extra आ गया यहाँ पे. Dono, Okay, so these are anti-tumor antibiotics with all the SINs. So next we have anti-metabolites. Anti-metabolites means they're not allowing metabolism or not allowing synthesis. So these are all S-phase specific except this cladribine, which is cell cycle non-specific. Okay, there has to be one odd one out in the clan. This is the cladribine, which is cell cycle non-specific.
And where we use cladribine?
Hairy cell, right? Oh yeah. Hairy cell. Cladribine and one more was there. Okay, this one only. Okay. So both are same mechanism. Okay. Okay, so what are the antimetabolites? We have thiopurines, cladribine, pentostatin, which are the purine analogs, cytarabine, which is pyrimidine analogs. So purine analog, then pyrimidine analog. This is also purine. Thiopurine is in the name, so purine analog. Cladribine is, so per se, this is purine. Cytarabine, arabinofuranosyl, cytidine. So cytidine, cytosine, we know that's a pyrimidine. Then 5-FU, this is a pyrimidine. Fluorouracil and cytosine are pyrimidines. Hydroxyurea, as we saw on the main chart, this is a ribonucleotide reductase inhibitor. Then we have methotrexate. This is a folic acid analog. Okay, so that's the overview. So thiopurines, what are the drugs? 6-azathioprine and 6-mercaptopurine. These are purine or thiol analogs, which decrease de novo purine synthesis. Aza is converted to 6-MP, which is then activated by AGPRT. Aza is converted to 6-MP, so the Aza is the precursor converted to 6-MP, which is then activated by AGPRT. Clinical use.
Prodrug.
Prodrug. Aza is the prodrug, yes. Then use in rheumatoid arthritis, IBD, SLE, ALL, steroid refractory disease, prevention of organ rejection, and weaning from glucocorticoids. Rheumatoid, IBD, SLE, ALL, steroid refractory disease, prevention of organ rejection, and weaning from glucocorticoids. Adverse effects is myelosuppression, though it's pretty much for all of these drugs, so they won't test it because it's not anything unique to any of them. GI liver toxicity. Yeah, this was the one which also causes pancreatitis, right?
Yes.
Neela was here, yes. So yeah, azathioprine also causes pancreatitis other than the liver. Excuse me, 6-MP. 6-MP is inactivated by xanthine oxidase and increased toxicity with allopurinol or febuxostat. So this we've seen somewhere else already. All right, so 6-MP is inactivated by xanthine oxidase. So, and these are increased toxicity with allopurinol or febuxostat. Then we have cladribine and pentostatin. These are purine analogs, so unable to be processed by ADA, adenosine deaminase, therefore interfering with DNA synthesis. Main use, hairy cell leukemia. So this is unique. So to remember, hairy cell, cladribine, pentostatin. Myelosuppression, yeah, whatever. Then we have cytarabine, arabinofuranosyl cytidine, also known as ARA-C or cytosine arabinoside. These are pyrimidine analogs. So again, cause DNA chain termination. Another mechanism is inhibiting DNA polymerase. So where are these used? Leukemias like AML and lymphomas. Leukemias and lymphomas. AML and lymphomas. Okay, thank you. All right, then we have myelosuppression. Myelosuppression is a side effect. So yeah, that's very common. So then 5-FU, we have pyrimidine analog bioactivated to FDUMP. So thymidylate synthase inhibition decreases DTMP and decreases DNA synthesis. Cepacitabine is a prodrug. Cepacitabine is a prodrug of 5-FU. So it's a pyrimidine analog bioactivated to FDUMP. Thymidylate synthase inhibition, so decreased TMP and decreased DNA synthesis. Cepacitabine is a prodrug. Where do we use this? Colon cancer, pancreatic cancer, actinic keratosis, which is a pre-malignant condition. So 5-FU is used over here. Basal cell carcinoma, topical use. Okay. Effects are enhanced with the addition of leucovorin. Leucovorin for 5-FU, enhanced effect. Okay, myelosuppression, whatever. So then palmar-plantar erythrodysesthesia, which is hand-foot syndrome, which is unique for 5-FU. Okay, FU is for hand-foot syndrome. Okay. Palmar-plantar erythrodysesthesia. Erythro redness, esthesia, sensation. So something to do with that.
Yeah, it looks like erythromyalgia.
Where do we see erythromelalgia? two places we saw today. One was PCV and the other one?
Thrombocythemia, essential thrombocythemia.
Thank you, essential thrombocythemia. So this is erythro.
Palmar plantar
Dysesthesia.
erythrodysesthesia. Yeah. Hands and foot.
Yeah, it's a dermatological toxicity induced by some chemotherapy drugs, characterized by tingling and tenderness, developing into symmetrical redness, swelling, and pain, primarily on palm of hand and sole. Okay, that makes sense. So erythro, redness, esthesia, so tingling and tenderness, symmetrical redness and swelling, primarily of the hands and soles, so hand and foot syndrome. Okay. Then next is hydroxyurea, inhibits ribonucleotide reductase, so decreased DNA synthesis, myeloproliferative disorders, so used where in myeloproliferative disorders like CML, polycythemia, and sickle cell disease, increased HbF, severe myelosuppression, and megaloblastic anemia. So megaloblastic anemia, we saw when we did it, one of the causes is hydroxyurea. All right, so next is methotrexate. It's a folic acid analog that comparatively inhibits DHFR, so decreased TMP and decreased DNA synthesis. So yeah, we saw it in the first few pages of biochem. Do dump trump, so DUMP, then decreased TMP and decreased DNA synthesis. So then where is it used? Cancers, which is leukemias, ALL, lymphomas, choriocarcinomas, unique sarcomas, non-neoplastic uses. This is important. So this is used in ectopic pregnancy, medical abortion with misoprostol, rheumatoid arthritis, and psoriasis, IBD, and vasculitis. So yeah, methotrexate, cancers like ALL and lymphomas, choriocarcinoma, and sarcomas. Non-neoplastic uses are for ectopic pregnancy, which makes sense. It's ectopic location. Medical abortion with misoprostol, rheumatoid arthritis, methotrexate, psoriasis, methotrexate, IBD, and vasculitis, methotrexate. Myelosuppression reversible with the leucovorin rescue. So leucovorin enhanced effect with F5FU. Leucovorin rescue is given for methotrexate. Other side effects, hepatotox, mucositis like mouth ulcers, pulmonary fibrosis with this as well, which we saw with the bleomycin. Folate deficiency, which makes sense. So that is teratogenic as well as nephrotoxic. Okay. So these are all antimetabolites, S-space specific, except cladribine. This one, which is cell cycle non-specific, used in hairy cell leukemia. So high yield points, thiopurine, purine analog, steroid refractory disease, prevention of organ rejection, GI liver pancreatitis, increased toxicity with allopurinol, febuxostat. Cladribine, purine analog, used in hairy cell leukemia. Cytarabine, pyridamine analog, as well as DNA polymerase inhibitor, used in AML and leukemia and lymphomas. 5-FU, pyrimidine analog, capacitabine is a prodrug. Capacity stuff is for 5-FU prodrug. Colon cancer, actinic keratosis is unique. So actinic keratosis and basal cell carcinoma, topical use, effects enhanced with leucovorin. Enhanced effect with leucovorin versus methotrexate, we give leucovorin rescue. Myelosuppression, palmar-plantar erythrodysesthesia, hand-foot syndrome. Hydroxyurea inhibits the enzyme, decreasing synthesis. Myeloproliferative disorders, sickle cell disease. Megaloblastic anemia is unique side effect. Methotrexate, folic acid analog, used in cancers, ALL and lymphomas, choriocarcinoma and sarcomas. Non-neoplastic, ectopic, abortion, rheumatoid, psoriasis, IBD, vasculitis. Myelosuppression, reversible with leucovorin rescue. Hepatotoxicity, mucositis like causes mouth ulcers, pulmonary fibrosis, folate deficiency, and nephrotoxicity. So that's anti-tumor antibiotics and antimetabolites. Then we have alkylating agents, platinum compounds, microtubule inhibitors, and topoisomerase inhibitors. Most of these we are easy, we know them. So what are the alkylating agents? These are all cell cycle non-specific: busulfan, nitrogen mustards, nitrosurias, and procarbazine. So we said alka and platin will cross-link chains, cross-link DNAs. So Alka, who's wearing the platinum, just to remember. Mnemonic, so cross-links DNA, this also cross-links DNA, and mechanism unknown, but it's a weak MAO inhibitor. But it is cell cycle non-specific, it's alkylating agent. I don't know why it's with this. Maybe it has an alkyl group, or it's adding an alkyl group, not sure. Okay, so all are pretty much cross-linking inhibitors. Clinical use, busulfan is used to ablate patients' bone marrow before bone marrow transplantation. Busulfan is ablation, it's ablating bone marrow before bone marrow transplantation. So this is like a vacuum cleaner, busulfan. It's ablating patients' bone marrow before bone marrow transplantation. Adverse effects is severe myelosuppression in almost all cases, pulmonary fibrosis, which is the high yield one, with busulfan and bleomycin. So bleomycin, methotrexate, pulmonary fibrosis, and busulfan, pulmonary fibrosis and hyperpigmentation. Nitrogen mustards, these are cyclophosphamide and ifosfamide. Cross-linked DNA require bioactivation by liver. Where is it used? Solid tumors, leukemias, lymphomas, rheumatic disease like SLE, and GPA. So SLE and GPA, we use nitrogen mustards. Myelosuppression, so CIAD is important for nitrogen mustards. Fanconi syndrome, which we said was RTA type 2 or 4?
2. बीच में था ना, बीच वाले कॉलम में था.
Fanconi syndrome type 2 होता है.
हाँ.
Proximal वाला. Because it's a PCT failure, na? So.
Okay, thank you.
SIADH, what are the drugs causes SIADH?
Mnemonic you had told one time.
SSRIs, cyclophosphamide, and carbamazepine, right? 3 drugs.
Really, only 3? Oh, there were so many more. SSRIs, carbamazepine, and
Cyclophosphamide.
Cyclophosphamide. Okay. Thank you.
Yeah, other causes are also, but healed mnemonic, remember? SIADH. Head injury and demeclocycline
In
and
the book, is the mnemonic, or is it outside the mnemonic?
healed is in the book, SIADH.
Zero memory. What is this? Let's see. Yeah, this one. Can't concentrate serum sodium. So carbamazepine, cyclophosphamide, SSRI, CCSS.
Yeah, and the healed one was in SIADH, this one, yeah.
I have written healed, HEAL.
Yeah, these mnemonics are tricky. If you don't remember them correctly, then sometimes I remember the mnemonic and be like, what does it stand for?
I know.
Yeah, most of the time actually. Okay, healed. So this is head trauma, CNS. Oh, these are causes. Okay. And this SSRS, so can't concentrate sodium, is the mnemonic for the drugs. Okay. So now we are talking about cyclophosphamide. So that's the link. Okay, cool. Thank you. So, okay, so coming back, so myelosuppression, CIAD, Fanconi syndrome, which is type 2 RTA, ifosfamide specific, is Fanconi, then hemorrhagic cystitis, bladder cancer, which we prevent with MESNA. This is a question, I think. Hemorrhagic cystitis and bladder cancer caused by the nitrogen mustards are prevented with MESNA. Then nitrosoureas, this is carmustine, lomustine, again cross-linked DNA, but they require bioactivation by the liver. And they also cross BBB, so they have CNS entry. So which makes sense that they use in brain tumors like glioblastoma multiforme, and put nitro in your Mustang and travel the globe. Yeah, when we did the drugs in the systems, we saw this CNS toxicity, convulsions, dizziness, and ataxia. Procarbazine, mechanism unknown, it's a weak MAO inhibitor used for Hodgkin's lymphoma and brain tumors, myelosuppression, okay, pulmonary toxicity, leukemia, and a disulfiram-like reaction. Okay. All right, then platinum compounds, we said cisplatin, carboplatin, oxaliplatin. They all have platinum in the name. They are think platinum chain with the links, so cross-linked DNA, cell cycle non-specific. Clinical use is solid tumors like testicular, bladder, ovarian, GI, and lung. So solid tumors, testicular, bladder, ovarian, GI, and lung, as well as lymphomas. Adverse effects is nephrotoxicity, like Fanconi syndrome, again type 2 RTA, prevent with amifostine, peripheral neuropathy, and ototoxicity. Platinum earrings, right? You guys used to say that in the morning, I think. Platinum earrings to say ototoxicity, peripheral neuropathy, and nephrotoxicity as well. Okay.
They
And
have
the other
removed
earring thing was Jervell and that one.
Jervell and Lee Nielsen and loop diuretics also passes.
Loop earrings also. Yes, yes, yes.
Ira,
Nice.
they have removed temozolomide in the new book, right?
Yeah.
Which is used for glioblastoma multiforme and
else.
DNA methylation agent. Okay.
Put it somewhere else, maybe. No, they removed it. Okay.
It's okay. Good.
What is the drug again? What was it used for?
Temozolomide, it's an alkylating agent. It's used for glioblastoma multiforme and it causes DNA methylation.
2022 mein.
Okay. It's used for GBM, that's all we need to know.
That is the one for MGMT, silence.
Oh my God.
Yeah, temozolomide, MGMT silence. It silences MGMT. So what is the role of MGMT? It's a DNA repair damage, right?
Yeah. That's its responsibility, yes.
Yes.
So MGMT is temozolomide. Okay. Yeah, they have removed it. Used in GBM, myelosuppression, DNA methylation is mechanism, temozolomide. So yeah, it will silence MGMT, is it?
Yeah, it will silence MGMT, and what is the normal function of MGMT is DNA repair. DNA repair damage.
DNA repair. Yeah. So that cells are so by inhibiting the DNA repair, then it's more targeted towards the destroyed cells. Okay. Or DNA damaged cells. Yeah, that was a whole MGMT question.
Makes then tumor cells much more susceptible to these alkylating agents.
Alkylating agents. Yeah. Okay. Nice. Thank you. This is alkylating agents. Yeah. Temozolomide. Just FY. DNA methylation. GBM. MGMT drug. Okay. Thank you. Thank you. So next we have microtubule inhibitors. These are M for M phase specific and taxanes and vinca alkaloids. So taxanes are docetaxel, paclitaxel. These hyperstabilize the polymerized microtubules and prevent mitotic spindle breakdown. Various tumors like ovarian and breast carcinomas, adverse effects are myelosuppression, neuropathy, hypersensitivity. So taxes will stabilize the society. So hyperstabilized polymerized microtubules prevent mitotic spindle breakdown. So various tumors like ovarian and breast, myelosuppression, neuropathy, and hypersensitivity. Vincalcras, vincristine, vinblastine, these bind beta-tubulin and inhibit its polymerization into microtubules, preventing mitotic spindle formation. Solid tumors, leukemias, Hodgkin's and non-Hodgkin's lymphomas. The use, so vincristine crisps the nerves, neurotoxicity, axonal neuropathy, constipation. So axonal neuropathy, constipation including ileus, and vinblastine blasts the marrow, so myelosuppression. Okay, so vinblastine for myelosuppression, vincristine for neurotoxicity, axonal neuropathy specifically, and constipation including ileus. Okay, so this binds beta-tubulin and inhibits the polymerization. This is hyperstabilized, already polymerized microtubules, so preventing their breakdown. Okay, so the cells cannot split now. Okay. Topoisomerase inhibitors all increase DNA degradation, resulting in cell cycle arrest in the S and the G2 phases. irinotecan, topotecan, inhibit topoisomerase 2. So tick 1. Clinical use colon, ovarian, small cell lung cancer, severe myelosuppression, and diarrhea. Etoposide, 2 sides, both sides. Inhibit topoisomerase 2. Where do we use it? Testicular, small cell lung cancer, leukemia, and lymphoma. So here, this TICANs are used for colon cancer, ovarian cancer, and small cell lung cancer. So small cell, we use topoisomerase inhibitors. Adverse effects: severe myelosuppression, diarrhea, myelosuppression, and alopecia. Okay, how are we doing on time?
So fluoroquinolones are what? Inhibit.
Sorry, DNA gyrase inhibitors.
Which are?
Topoisomerase 2 also, right? Isn't it? Not sure.
Fluoroquinolones are basically topoisomerase 2 and 4. Topoisomerase 2 is DNA gyrase.
So fluoroquinolones inhibit both.
Yes.
Can you repeat that?
Fluoroquinolones inhibits topoisomerase 2 as well as 4. Topoisomerase 2 is also called DNA gyrase. If I'm not wrong.
Topoisomerase 2 is called DNA gyrase. Okay. Fluoroquinolones inhibit both DNA gyrase as well as topoisomerase 4, you're saying. Okay, gotcha.
Yeah, so topoisomerase 2 or DNA gyrase is the same thing now. So 2 and 4, both inhibits.
Okay, nice. Thank you. Is that in the book? That they're both 2 and 4. Okay. Okay, cool. Thank you. So next we have tamoxifen. This is a SERM with complex mode of action. So antagonist in breast tissue and partial agonist in the endometrium and bone. So this is a SERM with complex mode of action. So yeah, this is high yield. It's an antagonist in breast tissue, but partial agonist in endometrium and bone, blocks the binding of estrogen to ER in ER positive cells. Prevention and treatment of breast cancer, prevention of gynecomastia in patients undergoing prostate cancer therapy. So yeah, breast cancer, prostate cancer therapy, 2 main uses. Adverse effects: hot flushes, increased risk of thromboembolic events like DVTP and endometrial cancer. Tamoxifen is going to cause endometrial cancer, so that's why I cannot relax. But what happened to raloxifene? Okay, I think it's in female reproductive. Okay, so tamoxifen, yeah. So main uses: prevention treatment of breast cancer and patients undergoing prostate cancer therapy. ER positive breast cancer. Okay. Next is monoclonal antibodies. Works against extracellular targets. So work against extracellular targets to neutralize them or to promote immune system recognition. So ADCC by NK cells. These are, this is a high yield fact, eliminated by macrophages and not cleared by kidneys or liver. Yes, monoclonal antibodies are eliminated by macrophages, not cleared by kidney or liver. So what are these? These are alemtuzumab, bevacizumab, cetuximab or panitumab, rituximab, trastuzumab, pembrolizumab, nivolumab, cemiplimab, which are PD-1, atezoli, durva, and avelumab is PD-L1 and ipilimumab. So this we've seen in that PD page. This also we've seen. Trastuzumab, okay, CD20 by now should have been drilled in. Alemtuzumab. Yeah, this was rituximab. Bevacizumab is VEGF. We saw in cetuximab, and panitumab is the add-on. Okay, so alemtuzumab, CD52, chronic lymphocytic leukemia and multiple sclerosis. So CLL and MS, which is common to this. Here also CLL and MS. Okay, so adverse effects: increased risk of infections and autoimmunity. Example, ITP. So this is a correlate. ITP is an adverse effect of alemtuzumab. Okay, then bevacizumab is BV, blood vessel. So it's a VEGF is a target, inhibits blood vessel formation. Used in CRC, RCC, NSCLC, and angioproliferative retinopathy. So yeah, this guy likes to go to school. RCRC, RCC, SS, SCLC, everything. I mean, if you're going to India, you'd relate, but yes, these were like our high school exam, SSLC board, blah, blah, blah. Anyway, so hemorrhage, blood clots, impaired wound healing. So CRC, RCC, NSCLC, and angioproliferative retinopathy. This makes sense because it's working on the blood vessels. VEGF is the target. Cetuximab, panitumab, this is EGFR. So used in metastatic CRC, wild type RAS mutation. Metastatic colorectal carcinoma, head and neck cancer. Adverse effects are rash, elevated LFTs, and diarrhea. So cetuximab and panitumumab, EGFR is the target. Okay. Anything to remember this? Cetuxi and panitumumab. Okay, rituximab, the
पानीपत की लड़ाई है सिटुक्सिमैब panitumumab
Pani and Situ,
Pani and
EGFR. पानीपत की लड़ाई with EGFR.
C2 वाला पानी पी के metastatic colorectal cancer.
Metastatic colorectal. C2
Oh my God.
pani. Okay.
Rituximab, panitumumab, EGFR, metastatic colorectal cancer. Yeah, only that's important that it's used for metastatic colorectal cancer.
Okay. And this random pani पी के rash हो गया इसको, diarrhea भी हो गया इसको. Okay, fine.
These are इसके side adverse effects are not important. इसके targets important.
Okay, cool. So yeah, 52 for LM2, bevacizumab is VEGF, cetuxi and pani is EGFR. Rituximab is CD20. This we know. Ritu is a 20-year-old girl with no home, so used in non-Hodgkin's. Miss Ritu and TIA. Okay, whatever. So MS is multiple sclerosis for both. So yeah, non-Hodgkin's lymphoma, CLL, rheumatoid arthritis. TIA was the TTP, ITP, and IHA and MS. So adverse effects are infusion reactions due to cytokine release following interaction of rituximab with its target on B cells, infusion reaction. Then trastuzumab is HER2 target.
It causes pneumonia, bacterial pneumonia. That's a side effect of rituximab.
Bacterial pneumonia. Okay. So that's the important side effect of rituximab. Where do we use this? Multiple sclerosis, TIA, which is TTP, ITP, IHA, rheumatoid arthritis, and non-Hodgkin's lymphoma. And side effect you said was?
Bacterial pneumonia.
Bacterial.
And
Okay.
her mother was CD52, right?
Yeah, her mother was CD.
Who's in CLL. Okay.
Yeah, I mean, yep. Alema, I don't know if they use it in Pakistan, but Alema, they say like someone who's like your grandma or older mom, right? Someone respectable.
Yeah.
Yeah, so that's to remember. Ritu's mom is Alema, which is CD52. Okay, trastuzumab is HER2 is a target, breast cancer and gastric cancer, and dilated cardiomyopathy. So this we said was important because this is often reversible dilated cardiomyopathy. Pembrolizumab, nivolumab, we had some mnemonic for this, right? ADA was PDL, ADAL was with the ligand.
Adal.
Okay.
You said Adal.
Yeah, Adal or Lada, we can say LADA. Yeah. So either way, yeah. Pembroli, Nivo, PNC for PD1. The target for these are PD1, Pembroli, Nivolu, and Semi. PD1 is the target. The L target is ADA, which is the ligand. Atezolizumab, durvalumab, or avelumab. Or we can also say LADA. with the ligand. Okay. And then ipilimumab is CTLA4. Okay. These are used in various tumors, NSC, LC, RCC, melanoma, and urothelial carcinoma. Increased risk of autoimmunity, example, dermatitis, enterocolitis, hepatitis, and pneumonitis, endocrinopathies. Okay. P and C for the PD-1. Okay, I think we can finish just one more page. Okay, let's do it. 10 more minutes. Okay, so anti-cancer small molecule inhibitors. Alectinib and crizotinib, target is ALK, NSCLC, adverse effects edema and rash and diarrhea. Erlotinib, gefitinib, afatinib, EGFR, also NSCLC, rash and diarrhea. Imatinib, dasatinib, we've seen, this is important, BCR, ABL, and also other tyrosine kinases like c-KIT, used for CML, ALL, and GIST. Yep. So adverse effects are myelosuppression, increased LFTs and edema and myalgias. So yeah, increased liver function test, edema and myalgias. Ruxolitinib, this we already saw, JAK1/2 inhibitor, and this is used in PCV. Adverse effects is bruises and increased LFT as well. So yeah.
Ira, any mnemonics for this above ones, Alec?
Alec is Alec, right? Just in the name, ALEK. If you write Alec.
And these are all Tinib and Arabs, right? Parib and Tarib. Sorry, Parib and Tinibs.
Tinibs, yeah, pretty much Tinibs. And this only one, this is Parib.
Parib, okay.
Tinib is tyrosine kinase inhibitors. So somehow related to the Tinibs. So Alec is ALK, ALK. Crizo is this weird one. We have to make something. Crizotinib and Erlo. So this is in the name EGF. So erlotinib, gefitinib, and afatinib. EGFR, EGF. Okay, let's see. Then imatinib, dasatinib, and nilotinib. This is for PCR ABL. CML, ALL, GIST. Ruxolitinib. This is JAK1/2 inhibitor, and PCV it's used. Bortezomib, ixazomib, and carfilzomib. All the ZOM ones are the ZOMs, ZOM, proteasome inhibitors. Induce arrest at G2 to M phase via accumulation of abnormal proteins and apoptosis. Yep. Proteasome pathway, proteasome inhibitors induce arrest at G2 M phase via accumulation of abnormal proteins leading to apoptosis. This we have seen in UWorld, that image. I think I didn't put it. Okay, I'll get to it in a sec. So clinical use is multiple myeloma and mantle cell lymphoma. Mantle cell, what was the number of translocation?
11.
11 and
14, 18 to marginal.
18 was marginal, 11, 14, right?
11,
40.
Mental age was 11, 14 or 11, 15? 11, 14. 14, yeah. Okay, nice. Adverse effects.
Can you remember this proteasome? Sara chakkar iska proteasome bana.
Yeah, 1 second. I'll finish this table and I'll pull up that image. I'll go to it.
Okay.
It's in UWorld, right? So yeah, where is this used? Multiple myeloma and mantles. So M, all the ZOME drugs. Then adverse effects, peripheral neuropathy, herpes zoster reactivation. So this is unique, herpes zoster reactivation. Why? Because it decreases T cell activation and decreases cell-mediated immunity. Decreases T cell activation. Okay, that's the reason. Although the mechanism target is proteasome stuff, this is decreasing T cell activation. So something to remember. Okay, then Vemuraf, Encoraf, Debraf, all these are RAF, BRAF inhibitors. Used in melanoma, often co-administered with the MEK inhibitors like tremetinib, MEK inhibitors. So melanoma, M stuff, MEK inhibitors, BRAF plus SIC. Okay, so rash, fatigue, nausea, and diarrhea, other side effects. Palbociclib, cyclin-dependent kinase 4-6, so it's in the name, cyclin-dependent kinase 4-6, induces arrest at G1 to S phase. So here it was G2 to M phase. G2 to M phase, here it is G1 to S phase. This is to remember these small molecule inhibitors. G2 to M is the Zome drugs, G1 to S is this one, okay.
Yeah, because CDKs work on, if there is no CDK, so G1 phase mein nahi jayega na?
Correct. Yes, yeah, this CDKs are needed for it to transition to the S phase, yeah. From our grandchildren and grandpa and naughty son wala story, right?
Yeah, cyclins with combined with CDKs and then they, RB
Complex will,
phosphorylation and then RB will leave the E2F free.
EF2.
E2F will go and
Yep.
continue the cell cycle.
Nice. So G1 to S will, that makes sense why it's G1S. So where is this used? Breast cancer and myelosuppression pneumonitis. Olaparib, this is a PAR, so poly-ADP ribose polymerase. So this is decreasing DNA repair used in breast, ovarian, pancreatic, and prostate cancers, myelosuppression, edema, diarrhea. So poly-ADP ribose polymerase is the target. So it's actually attacking the enzyme. Poly-ADP ribose polymerase enzyme. That's the olaparib target. Okay, so let's see the proteasome inhibitors and come back to our table.
Proteasome decrease MHC1 to T cell binding, right?
Proteasome, say again, inhibits?
Inhibit MHC class 1 to T cell binding. That's why.
Yeah. That's why the T cell activation, actually, that makes sense. We saw that somewhere. Was that an NBME question? Or somewhere we discussed this, I remember. Proteasome is needed for MHC1. Yeah. Maybe in immunology we saw it somewhere. Yeah, you're right. Thank you. So what am I looking for? Proteasome pathway, this one. Did I pick the wrong thing? Here we go. Okay, so normally, if there is a target protein, ubiquitin will flag it. So there's a signal here. If it's tagged by ubiquitin, proteasome is this mechanism, its main function is to destroy unwanted proteins, right? So what it does, when it sees this flag, it's going to take up that protein and uses ATP and hydrolyzes this protein, hydrolyzed oligopeptides, and ubiquitin is cleaved from target protein and it's recycled. So if this proteasome is targeted, what happens? Now we don't have destruction of these abnormal proteins. Abnormal proteins will accumulate. And then they are flagged by, no. I think this was the one I used to think, and then you guys corrected me one day, right? What was it? Let me read you.
I think, go ahead and then.
Let me read. So ubiquitin is a protein found in eukaryotic cells that is attached to other substrate proteins in highly regulated process termed ubiquitination. Proteasome recognizes ubiquitinated proteins and uses ATP energy to drive the proteins to its tubular structure, degrading them into peptides. Attachment of 4 or more ubiquitin monomers is typically required before proteasomal degradation can take place. Ubiquitination plays a role in many cell functions, requiring the breakdown of specific proteins, including antigen processing, muscle wasting, cell cycle regulation, and disposal of misfolded proteins. Impairment of the ubiquitin proteome system can contribute to the development of neurodegenerative diseases like Parkinson's and Alzheimer's. Failure to properly degrade abnormal proteins can cause aggregation of misfolded proteins and eventual obstruction of intracellular molecular traffic, leading to cell death. So mutations in genes involved in the ubiquitin proteasome pathway like Parkin and PINK1, DJ1, they are associated with autosomal recessive forms of Parkinson's disease that have an early age of onset at 50. So how do these drugs work? This is lenalidomide. This is different.
Yeah, lenalidomide we also use for multiple myeloma, right?
Correct. So yeah, they're susceptible. MM cells are particularly susceptible to proteasome inhibition because they generate extremely high quantities, some of which misfold and aggregate in the ER. Increased stress on the ER then triggers an unfolded protein response that eventually leads to activation of caspases and cellular apoptosis. So I think, yeah, I was going the right track. The unfolded proteins will accumulate, and it's like gets overfed kind of, and then this unfolded protein response triggers the activation of caspases and apoptosis. So by giving these bortezomib drugs, we are inducing apoptosis in the cell.
Yeah, so because normally the proteasome will not function, so it will not degrade the cancer proteins, right?
Exactly. Yep. Mm-hmm.
So the cancer proteins will keep on accumulating, and further they will keep on arrest at the G2 to M phase, and that leads to caspase activation and apoptosis.
Yeah, the proteins will overload in the cell, and that will trigger the caspases to get activated and cause apoptosis. Yeah, that's the mechanism. Nice. So this is mainly used in multiple myeloma and mantle cell lymphoma. Okay. Yep. So then, so these are the drugs: ALEC, ALCA, EGFR, so erlotinib, gefitinib, and afatinib. Imatinib, dasatinib, and nilotinib is BCR-ABL. Nilu is helping us in CML, and just Nilu, imatinib, dasatinib. Ruxolitinib is JAK1/2. Zome is the bortezomib, ixazomib, and carfilzomib. Vemur, RAF. These are all used for melanoma. Palbociclib, cyclin drugs for breast cancer. Olaparib is poly-ADP ribose polymerase enzyme inhibitor. Okay. All right. So we'll do a pop quiz maybe then tomorrow morning. So last thing before we go to Taxman, chemotoxicity amelioration. So the toxicity, how to calm it down. So we have amifostine, which is free radical scavenger. So its use is preventing the nephrotoxicity from platinum compounds. Dexrazoxane, we know this is a iron chelator, and we gave it with the doxo and dono to prevent the cardiotoxicity from anthracyclines. Then leucovorin, we know leucovorin rescue, so tetrahydrofolate precursor. Myelosuppression from methotrexate, leucovorin rescue. It also enhances the effects of FU. So it's protecting the side effect for methotrexate, and it's enhancing the effect of 5-FU. Then we have mesna. Mesna is a sulfhydryl compound that binds acrolein, which is a toxic metabolite of cyclophosphamide and ifosfamide. I think this is a UWorld question. Mesna. The S in the mesna is for sulfhydryl compound. It binds the A in the end, which is acrolein. Where is the acrolein coming from? It's a toxic metabolite of cyclophosphamide and ifosfamide.
Oh, one thing. Sulfhydryl was the good thing, right? We had it in G6.
G6PD respiratory burst. Yeah.
We had decrease of sulfhydryl in G6PD, right?
G6PD.
Yeah,
The toxic one is the GSSG one, which is the bad one.
That is increased in G6PD basically.
Yeah.
Salfadril increase or decrease is the good one.
GSSG is a bad one, that is increased. GSH is a good one, that was reduced from is decreased.
Yeah, the one with the 2S, the SS is the bad one.
Yeah.
So in G6PD deficiency, this 2 disulfhydryl groups make it very bad. If it's 1S, it's okay. It's reduced and it's good guy.
This is sulfhydryl group, not GSH. And you are talking about this disulfide group. This is GSS is a disulfide group.
So yeah, what she's saying is sulfhydryl is good in this situation, right?
Yeah, in this situation, sulfhydryl is good. Yeah, so she's saying right there.
Correct, yep.
Thank you.
Disulfide bond, disulfide is the toxic one.
Disulfide is the toxic, yeah, and sulfhydryl is the good one, which is decreased in G6PD deficiency, right?
Yes, correct.
Thank
Nice.
you. A reduced form actually is sulfhydryl. Oxidized form is that disulfide.
SS form, yeah.
Yeah.
Yeah, it's reduced is compressed, so it's only 1S. Oxidized is two things, yeah.
Yes.
So here the mesna is binding to the sulfhydryl compound that binds acrolein. So basically this drug is a sulfhydryl compound. So again, this is also good guy here, right? Mesna is also good guy SH. So it's binding acrolein, which is the toxic metabolite. So it's taking away this toxic. So SHA. So yeah, sulfhydryl compound that binds acrolein. What is acrolein? It's a toxic metabolite of cyclophosphamide I-phosphimide. Where do we use this? Hemorrhagic cystitis from cyclophosphamide and I-phosphimide. Then rasparicase. Rasparicase is recombinant uricase that catalyzes the metabolism of uric acid to allantoin. This also you've seen before. Main use is in tumor lysis syndrome and hemorrhagic cystitis for this one. Yeah, tumor lysis syndrome, rasparicase. So too much uric acid will be there. So it's converting into allantoin, which is a water-soluble form. So it's excreted in urine. Then we have ondansetron, granisetron, which we saw earlier this morning. 5-HT3 receptor antagonist. Chlorchlorperazine and metoclopramide are D2 receptor agonists. And all these 4 are used for acute nausea and vomiting, which is within 1 to 2 hours. So this 2 and 3 should remind us it's within the hours range. So 1 to 2 hours after chemotherapy. And aprepitant and fosaprepitant are NK1 receptor antagonists. Delayed nausea and vomiting after 1 day. 1 for 1 day, which is more than 24 hours after chemo. Filgrastim, sargramostim, we mentioned this, Amna mentioned this before, recombinant G and granulocyte monocyte colony stimulating factor, and is used for neutropenia. Epoetin alpha, we saw it before, so this has it in the name, EPO. So that's a recombinant erythropoietin. Where do we use it? In anemia. So this is fairly easy, we already familiar with it. Amifostine is scavenging phosphate, maybe 3 radicals from the platinum compounds. Dextrozoxine ion chelator, leucovorin THF precursor, mesna sulfhydrin binding the acrolein, rasparicase converting uric acid to allantoin, ondan and grani 5-HT3 antagonists, chlorchlorperazine and metoclopramide D2 antagonists, aprepitant, fosaprepitant NK1. This is for acute. This is for 1 day later. Filgrastins, they are stimulators. So granulocyte stimulating, granulocyte and monocyte stimulating for GM-CSF. So this is doing for both. Actually, filgrastim is only for granulocyte, G-CSF. Sargram is both GM-CSF. Epoetin alpha is recombinant erythropoietin. This was in UWorld. Pirfenidone is an antifibrotic agent that inhibits TGF-beta. Another treatment option is nintedanib. Was it here in this nintedanib? Pirfenidone and Yeah, it wasn't. So Nintendo these are tyrosine kinase inhibitors that inhibit PDGF, FGF, and VEGF. So they're used in inhibiting three things. Nintendo is inhibiting PDGF, FGF, VEGF. Although neither drug is curative, these therapies have been shown to slow progressive fibrosis in patients with IPF, idiopathic pulmonary fibrosis. Okay. Pirfenidone for pulmonary fibrosis and nintedanib. Their TGF beta is the target. Okay. Okay. So this is the sticky one. All right. So last schemo man. Cisplatin carboplatin. So cisplatin, carboplatin, platinum earrings, ototoxicity, vincristine crisps the nerves, peripheral neuropathy, bleomycin, busulfan for the lungs, pulmonary fibrosis, doxodono for the heart, cardiotoxicity, trastuzumab, cardiotoxicity, which is reversible. Trust her, so you trust her, so she's reversible. Cisplatin and carboplatin also causing nephrotoxicity. Cyclophosphamide, Cy for the hemorrhagic cystitis. Non-specific common toxicity of nearly all chemotherapy therapies include myelosuppression, neutropenia, anemia, thrombocytopenia, GI toxicity, and alopecia. And done. Thank you. Let me stop the recording.